Hello guys, good afternoon everyone. Hope you are doing your preparation good. Okay. Uh, so the main aim of this class is to condense the most important topics in the physiology. Okay. So today we'll be condensing the most important topics in the physiology that you should be knowing for your exam. Okay. So from my side, I can guarantee you. Okay, if you haven't done your physiology, okay, if you are not good with your physiology, I'm guaranteeing you from my side, at least go through this video, you'll be able to answer the MCQs in your upcoming FMGE exam. Okay, so mostly I will be concentrating, okay, I will be mainly concentrating on the subject rather than explaining small doubts. Yeah, I will engage with you, I will answer your queries, but mainly I will be concentrating on the subject so that you will get the best, okay, out of the class. Chalo, we'll be starting first with the endocrine physiology. See, in endocrine physiology, what you should know for the, let's say, for the next 1 hour, we'll be mainly concentrating on the endocrine physiology and the things that you should know in the endocrine physiology for the next 1.5 hour only on the endocrine system. See, this endocrine physiology is highly integrated with your pathology as well as medicine also. Okay, so listen carefully. If you have any doubt, you can put it in the chat box. I will be going through the your comments. I will be going through your comments and I will answer you. If it is relevant, I will definitely answer you. Okay, na? Chalo. Now, first, how many types of hormones are there? Everyone knows that there are 2 types of hormones: lipid soluble hormones, water soluble hormones. Examples. You have to know the examples. What are the examples of lipid soluble hormones? Steroid hormones and thyroid hormones are examples of lipid soluble hormones. Again, repeat. Steroid hormones and thyroid hormones are examples of what? Steroid hormones and thyroid hormones are examples of lipid soluble hormones. Now, what is the meaning of a steroid hormone? See, you already know the examples of steroid hormones like estrogen, testosterone, progesterone, cortisol, aldosterone. They are all examples of steroid hormones. And you know the examples of thyroid hormones also. Thyroid hormones include T3 and T4. Okay? You are asking about the PDF. See, you will be getting PDF only after the class. Okay, sensible. You are asking that you are asking about the PDF. You will be getting PDF once the class is completed. Okay, you will get the annotated PDF. Annotated PDF you will get after the class, not now. Okay, so forget about the PDF for now. Only concentrate on my explanation. Okay, so that 17 marks will be in your hands. Now, tell me, steroid hormone. What is the meaning of the steroid hormone? What is the meaning of the steroid hormone? Steroid hormone means the hormone which is produced from cholesterol, which is a derivative of a cholesterol. A hormone which is a derivative of cholesterol is called as steroid hormone. Examples I have already taught you. Cholesterol derivative hormones are called as steroid hormones. Now, what are the examples of water-soluble hormones? The examples of water-soluble hormones include peptide hormones and amine hormones. Peptides and amines are the water-soluble hormones. Now, see, for your FMG exam, what you should know from this table. See, from this table, the differences between the lipid-soluble hormones and water-soluble hormones, what you should know. Exceptions are important. Lipid-soluble hormones are never stored. Usually, they are never stored in the body. They are produced and used up. Whenever there is a need, they are produced and used up. But they are never stored. But one exception is there. Which lipid-soluble hormone can be stored? It is the thyroid hormones. Thyroid hormones can be stored in the thyroid gland colloid. In the thyroid gland, they can be stored for almost 2 to 3 months. 2 to 3 months they can be stored. So tell me, which lipid soluble hormone can be stored? Thyroid hormones can be stored. Next, what about the water soluble hormones? Are they stored? Yes, they are stored in the vesicles. Next, what about the binding capacity? In the plasma, in the blood, so these hormones, are they alone? Are they bind with any plasma protein? Yes. See, the lipid soluble hormones, they are never alone. They are always bound with some plasma protein. For example, look here. T3 binds with which plasma protein? Albumin. T4 binds with thyroid binding globulin. Estrogen, testosterone binds with sex hormone binding globulin. So these are your MCQs. T3 bind with what? T3 bind with, right, T3 bind with albumin. T4 with thyroid binding globulin. Estrogen, testosterone binds with sex hormone binding globulin. Okay. Now, what was the FMG question? Already it's a PYQ. T4 binds with what? T4 binds with thyroid binding globulin. So you have to know it. So in this class today, I will be covering as many PYQs as possible. Okay. Chalo, next. Cortisol. You know, cortisol is a glucocorticoid from the adrenal gland. Cortisol and progesterone. Cortisol and progesterone, they binds with what? They binds with cortisol binding globulin. So I want you to remember this area for your FMG exam. T3 binds with albumin, T4 binds with thyroid binding globulin, estrogen, testosterone binds with sex hormone binding globulins, and cortisol and progesterone binds with what? Cortisol binding globulin. But what is the exception? Exception is there is a lipid soluble hormone, okay? There is a lipid soluble hormone, but it does not bind with any plasma protein. It's an exception. It's an exception. What is that exception? That is DHEA, dihydroepiandrosterone. Dihydroepiandrosterone, it is a lipid soluble hormone, but it is not bound with any plasma proteins. Exception. Next, what about the water soluble hormones? Water soluble hormones, yes, they do bind with plasma proteins. They are they do not bind with plasma proteins. One exception is insulin like growth factor 1. Insulin like growth factor 1, also called as the somatomedian C. So insulin like growth factor 1, it is water soluble. Yes, it is water soluble. But what is the exception point? Usually water soluble hormones, they are now never bound to the plasma proteins, but the only water soluble hormone which binds with the plasma protein is ILGF1. And what you should know for your exam, ILGF1 is responsible for what? Growth spurt. Which hormone is responsible for the growth spurt? Is it directly growth hormone? No. It is the insulin like growth factor 1 which is responsible for growth spurt. You know, during puberty you will suddenly start to increase in height, that is called as a growth spurt, and that growth spurt is because of insulin like growth factor 1, also called as somatomedian C. Okay. So someone is asking, sir, the session is going to be for how many hours? See, it will be a minimum of 6 hours. The session is going to be minimum of 6 hours because I have to complete all the systems, all the general physiology along with the PYQs. So definitely it's going to take some time, a minimum of 6 hours. Okay, minimum I'm talking about, minimum of 6 hours. Okay, because at the end of the day, it's not the duration which is important, it's the content. It's the content and how this will be helpful for you in exam. Okay, if I do the entire rapid revision in 2 hours and if it is not helpful for you, what is the point of doing it? Okay, so that's why I will try to cover as many PYQs as possible and all the important concepts as possible. Okay, chalo. Guys, the sending PDF is not in my hands, so I could not do that. Okay, it's beyond my capabilities, because like even I got the PDF just now. Okay, receptors. Now, guys, right? What about the receptors? Which hormones have the intracellular receptors and which hormones have the cell surface receptors? Students, look carefully. Imagine this is a cell. And here I am talking about a lipid soluble hormone. X is a lipid soluble hormone. So tell me, this X being a lipid soluble hormone, will it cross the cell membrane? Yes, it can cross the cell membrane. So it can cross the cell membrane and it will bind with the receptor inside the cell. So lipid soluble hormones have intracellular receptors. Lipid soluble hormones have intracellular receptors. Either they can be intracytoplasmic or maybe in the intranuclear. So the receptor may be in the cytoplasm or maybe in the nucleus. So now examples. Sir, which hormones have intracytoplasmic receptor? Which hormone have intracytoplasmic receptor? Okay. See, the hormones which I am going to teach you right now, they are all having the receptors in the cytoplasm. The first one is very, very important for your exam, aldosterone. Aldosterone. You know, aldosterone is a mineralocorticoid from the adrenal gland. Aldosterone receptor, intracytoplasmic receptor. Okay, others are also there, for example like testosterone, cortisol. Okay, other receptors are also there, but at least for your exam, remember aldosterone. If you can remember other things also, like for example testosterone, okay, testosterone, cortisol. Okay, they are also having intracytoplasmic receptors, but this is very, very important for your exam. Aldosterone have intracytoplasmic receptor. Then which hormones have the intranuclear receptors? Which lipid soluble hormones have the receptor within the nucleus? Okay, within the nucleus. See, for this I am going to give you a mnemonic. Okay, I am going to give you a mnemonic. A mnemonic. Okay, it's a little funny mnemonic. Sex with T3 and T4. Sex with T3 and T4. Sex with T3, T4. So here, what does this sex stands for? In sex letter, okay, in sex word, this E letter is there, no? E for estrogens. So sex hormones, especially estrogen, which have which type of receptor? Intranuclear receptor. And what is this T3D4? You already know T3D4 stands for the thyroid hormones. Even thyroid hormones have intranuclear receptors. Sex hormones like estrogen and T3D4 have intranuclear receptors. And this which stands for vitamin A and vitamin D. So vitamin A and vitamin D, they have the receptor in the nucleus. Some of the students, they come up with a doubt. Sir, I have studied in pharmacology that vitamin D receptors are in the cytoplasm. Listen, vitamin D receptors are predominantly intranuclear. They can shift into the cytoplasm, but predominantly, listen, vitamin A and vitamin D receptors are intranuclear receptors mainly. Can they be in cytoplasm? Yes, they can come into the cytoplasm, but primarily vitamin D receptor, intranuclear receptor. Okay, for your FMGE exam, this is the most important thing. Thyroid hormones have which receptors? Intranuclear receptors. Fine. Then what about the water soluble hormones? Water soluble hormones have cell membrane receptors, means on the cell surface. They produce as the secondary messengers. See, the water soluble hormones, whatever I am going to teach, later I will teach you. They all produce what? They all produce as something called as the secondary messengers. Exception, one exception is there. And what is, not one exception, like few exceptions are there. What are those exceptions? Let me tell you. Insulin. Okay. Insulin. Yeah. Insulin acts via different pathway. Insulin is not going to produce any secondary messenger because insulin receptor is different. Okay. So insulin acts via tyrosine kinase pathway. Okay. So tyrosine kinase receptors are the tyrosine kinase pathway. Very, very important from your biochemistry also. This is integrated. So insulin ka receptor is a tyrosine kinase receptor. Insulin produces any secondary messengers? No, insulin does not produce any secondary messengers. Insulin, tyrosine kinase pathway. Then mnemonic LPG. LPG. LPG stands for what? LPG stands for leptin prolactin growth hormone. Leptin prolactin growth hormone. Okay. Leptin prolactin growth hormone. See, this leptin prolactin growth hormone and even this insulin like growth factor 1. Okay, insulin like growth factor 1. They are all going to act via which mechanism? Not the secondary messenger mechanism. They do work via JAK STAT pathway. Okay, JAK STAT pathway. Guys, again tell me, even if you forget about this insulin like growth factor 1, no issue. But tell me, LPG hormones, leptin, growth hormone, prolactin. Leptin, growth hormone, prolactin. Leptin, growth hormone, prolactin. Are they water soluble? Yes, they are water soluble. Are they producing any secondary messengers? No, they are not producing any secondary messengers. Then how they are acting, sir? How they are going to bring the changes inside the cell? Via different pathway called as the JAK-STAT pathway. Insulin acts via which mechanism? Tyrosine kinase mechanism. All others acts via the secondary messenger pathway. Okay, done. Chalo. So these are some important differences which I want you to know. Okay, in the differences topic. See, if some topic is important, I will concentrate on that area. I will take more time on that particular area. Okay, don't worry about the timing. I will try to complete the whole session by within 7.5 hours it will be completed. Okay. Next, sir, then what are the different types of secondary messengers? I have already taught you. Secondary messengers are produced by which hormones? Lipid soluble or water soluble? Secondary messengers are produced by water soluble hormones. Secondary messengers are produced by the water soluble hormones. Then what are the different types of secondary messengers? See, in humans, there are different types of secondary messengers called as a cyclic AMP, cyclic GMP and inositol triphosphate. So these are the three types of secondary messengers that are produced inside our cells which will bring some changes. Okay. So now, what was the FMG question which was already asked? Secondary messenger function. What is the function of the secondary messenger? The function of the secondary messenger is to regulate, MCQ, is to regulate intracellular, not extracellular, intracellular reactions. Okay, someone is asking, sir, is this enough for the upcoming FMG exam? 100% enough, 100% enough. Okay, so whatever I am going to teach you, just follow that, okay, enough. Okay, trust me. So what is the function of the secondary messenger? The function of the secondary messenger is to regulate what? Intracellular reactions. Next, how many types of secondary messengers are there? 3 types: cyclic AMP, cyclic GMP, IP3 inside our cells. Now question is, sir, which hormones produce cyclic AMP? Which hormones produce cyclic GMP and which hormones produces IP3? I am asking you, sir, do we have only one type of water soluble hormone? No. So different types of hormones produces a different secondary messengers. Different secondary messengers control different reactions. Okay. So now you have to know the list of hormones which produces cyclic AMP. See the mnemonic I am giving you, flat, F-L-A-T, flat. F's for FSH, LH, ACTH and TSH. Okay, FSH, LH, ACTH, TSH. For those students who are asking about the PDF, I think the PDF was already shared in the Telegram group. Already the PDF was shared in the Telegram group. You once check the Telegram group and download it and you can annotate it. Okay, so chalo. So FSH, LH, ACTH, TSH. So they're all producing which secondary messenger, guys? They're all going to produce cyclic AMP. Cyclic AMP. Okay, now next step. Sir, few more hormones like CAMP, second mnemonic I am giving you, CAMP. CAMP stands for what? C for calcitonin. Calcitonin. A for antidiuretic hormone acting on which receptor? V2 receptors on the collecting ducts. Next, M for melanocyte stimulating hormone. You know melanocyte stimulating hormone which will give the pigmentation, melanocyte stimulating hormone. And P for parathyroid hormone. Parathyroid hormone. You already know parathyroid hormone, what it will do. Parathyroid hormone increases the calcium levels. Calcitonin decreases our calcium levels. Okay, these two are antagonistic hormones. Never forget, calcitonin is an antagonist of parathyroid hormone. Okay, that's fine, that's fine. But my question is, all these hormones are going to produce cyclic AMP inside our cell. Cyclic AMP. Next, any other hormones are there? Yes. Beta HCG. What is this beta HCG stands for, sir? What is this beta HCG stands for? Beta HCG stands for epinephrine acting on beta 1, beta 2 receptor. Beta 1, beta 2 receptor. When epinephrine is acting on the beta 1, beta 2 receptor, inside the cell, cyclic AMP is produced. Next, H stands for histamine. Histamine acting on H2 receptor. Histamine acting on which receptor? H2 receptor. Next, C stands for CRH, corticotropin releasing hormone. Corticotropin releasing hormone. And G stands for glucagon. Okay. So these hormones, which hormones again I am repeating? Epinephrine acting on beta 1, beta 2 receptor. H for histamine and beta HCG. Histamine and as well as HCG, both. C for corticotropin releasing hormone and G for glucagon. All these hormones are going to produce what? They are going to produce cyclic AMP inside the cell. So these are the hormones. Okay, these are the list of hormones: FSH, LH, ACTH, TSH, calcitonin, antidiuretic hormone, melanocyte stimulating hormone and parathyroid hormone, epinephrine, histamine, CRH and glucagon. All these hormones are going to produce what? Cyclic AMP. Cyclic AMP or cyclic AMP, whatever. Okay. Next. Now, a few more questions were there. Sir, okay, cyclic AMP is produced. But to produce the cyclic AMP, first of all, you have to stimulate a receptor. Look carefully here, guys. Sir, here there is a cell. Here there is a X hormone, water soluble hormone. So first this water soluble hormone has to act on a receptor. First this hormone, first it have to come and act on the receptor. Now the receptor, what it will do? It will activate an enzyme inside the cell. It will activate an enzyme, and this enzyme, what it will do? It will produce secondary messenger. It will produce secondary messenger. Now my question is, sir, what is the name of this receptor? What is the name of the receptor? And what is the enzyme? What is the enzyme needed? What is the enzyme required for the production of cyclic AMP? Sir, इस cyclic AMP को produce करने के लिए, in order to produce the cyclic AMP, what is the receptor that need to be activated? The name of the receptor is called as G stimulatory type of receptor. GS stands for, G protein coupled receptors. Or you can say GS, G stimulatory. GS, GI, GQ, different types of receptors are there. So cyclic AMP को produce करने के लिए, what is the receptor that is required? G stimulatory receptor. And what is the enzyme required? Enzyme required adenylate cyclase. Okay, sir, cyclic AMP is produced. Cyclic AMP produced हो गया. Now what the cyclic AMP will do? Once the cyclic AMP is produced, it will activate what? Cyclic AMP activates pKa. pKa stands for protein kinase A. Protein kinase A. Guys, all these are important MCQs. All these are important things. You have to know them. You have to know them. Okay. If something is important, I will stress on that. So tell me, what is the first secondary messenger? Cyclic AMP. What is the receptor required? G stimulatory. What is the enzyme required? Adenylate cyclase. Cyclic AMP, what it will do? Cyclic AMP activates. So the cyclic AMP or the cyclic AMP or the cyclic AMP activates what? Protein kinase A. Fine. Now in the same way, in order to produce this cyclic GMP को produce करने के लिए, in order to produce this cyclic GMP, which enzyme is required? Guanylate cyclase. Important for your exam? Not needed. But you have to know which hormones produce this guanylate cyclic GMP. Is atrial natriuretic peptide, brain natriuretic peptide, and nitric oxide. Nitric oxide. Guys, please don't take me wrong that I'm not interacting very much with you because I have to complete the all these important things. Okay, so yeah, I am reading your comments, but I want to mainly concentrate on the content. Okay, so that's why. Chalo, next, ANP, atrial natriuretic peptide, brain natriuretic peptide, and nitric oxide. All these three things, what they will do? They are going to produce cyclic GMP. Next, sir, IP3, the third one, IP3, inositol triphosphate. Who produces this inositol triphosphate, sir? Who produces this inositol triphosphate? See, hormones. Now I am going to write the hormones. Hormones which are coming from the posterior pituitary, you have to remember, like oxytocin and antidiuretic hormone acting on V1 receptor. Listen, oxytocin and antidiuretic hormone acting on V1 receptor, not the V2, V1 receptor. Because here I have taught you, antidiuretic hormone acting on the V2 receptor produce cyclic AMP, but the antidiuretic hormone acting on V1 receptor produce IP3. Okay, next, in the same way, histamine acting on H1 receptor, gastrin, angiotensin 2, cholecystokinin, epinephrine acting on alpha 1 receptor. See, what is something common between all of them? What is something common? What is something common between all of them? All are going to cause the smooth muscle contraction. Think about the oxytocin ones. Sir, oxytocin क्या करेगा? Uterine contraction. Antidiuretic hormone acting on V1 receptor. Antidiuretic hormone also called as vasopressin. Vasoconstriction करेगा. Smooth muscle contraction. Histamine, bronchoconstriction करेगा. Gastrin, GIT contractions. Angiotensin 2, vasoconstriction. Cholecystokinin, gallbladder contraction. Epinephrine, vasoconstriction. So those hormones which are causing the vasoconstrictions and smooth muscle contractions, they're all going to produce what? They're all going to produce IP3. So simple trick. Any hormone which is associated with, or any hormone which is going to cause the contraction of the smooth muscles or the vasoconstriction, they produce which type of secondary messenger inside the cell? IP3, IP3, IP3. Okay. So now, what is this IP3 doing? Look carefully. So this IP3, it acts on, right? IP3 acts on your endoplasmic reticulum, releases what? Releases the calcium. And what is the function of this calcium? The calcium is smooth muscle contraction. Smooth muscle contraction. Excellent. 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 Nirisha? Yeah. Excellent. Smooth muscle contraction. So, now tell me, which secondary messenger is going to increase the calcium levels? Which secondary messenger, sir? IP3. IP3 increase your intracellular calcium levels, and the calcium is going to cause the contraction. And you also have to remember, so the calcium is also considered as a secondary messenger. Okay, in your exam, if there is an option, which of the following is a secondary messenger? Yeah, calcium can be considered as a secondary messenger. Okay, so cyclic AMP, cyclic GMP, IP3/calcium, they're all secondary messengers. Okay, done. Chalo. So this table is also very, very important for your exam. Remember it. If I am the examiner, this is what I will ask you. FSH acts via cyclic AMP. Nitric oxide acts via cyclic GMP. Next, oxytocin acts via IP3. Which of the following is a secondary messenger? Calcium is a secondary messenger. Which ions act as a secondary messenger? Calcium ions. Okay, no? Done. By heart it. Chalo, next. After that, in this, Started? Okay. Guys, there is a small technical glitch. That's why it happened. Chalo, let's continue. Let's continue. Now, see in this page, what you should know. Okay. Actually, a question in the recent exams. Actually, a question came from this particular page. What is that? First, let's discuss about the females. Okay. First, let's discuss about the females. See, in females, hypothalamus is there. Yes, females do have hypothalamus. And anterior pituitary is there. Yes, anterior pituitary is there. You can clearly see that the hypothalamic hormones, these are all the hypothalamic hormones. See, these hypothalamic hormones, they are controlling the anterior pituitary. The hypothalamus controls anterior pituitary. And what anterior pituitary will do? Anterior pituitary releases FSH, LH, ACTH, TSH, growth hormone, prolactin, different hormones. So, hypothalamus regulates the pituitary gland. See, hypothalamus is the master regulator of endocrine system. Hypothalamus controls anterior pituitary. Okay. What you should know for your exam? See, now this cell GT stands for what? Gonadotrope. Okay, gonadotropes are there in the anterior pituitary. Now these gonadotropes are producing what? FSH, LH, FSH, LH. Now you tell me, where is this FSH acting? Sir, FSH, it is acting, look carefully, FSH is acting on the ovaries. So it is stimulating the follicles, it is stimulating the ovarian follicles, follicle stimulating hormone. So now the follicles are getting stimulated. Now these ovarian eggs or the ovarian follicles are getting stimulated. So now these follicles, they will produce what? Estrogens and inhibin B. So now tell me, whenever the FSH is stimulating the ovaries or the ovarian follicles, the ovaries are going to release what? Estrogens. Estrogens. Along with the estrogens, who else is produced? Inhibin B. Inhibin B. In the first 14 days of the menstrual cycle. In the first 14 days of the menstrual cycle, because of the FSH, see in the first 14 days, the FSH is stimulating the follicles to grow and to release estrogen and inhibin. Now you might be thinking, sir, what is the FMGE question? So tell me, what is this estrogen going to do? Sir, estrogen, right, estrogens helps in breast development. But which part of the breast? Yes, estrogens causes the breast development, but which part of the breast? Is it the lobular part? Is it the alveolar ducts? Which part of the breast will be developed because of the estrogens? So always remember, the estrogens are going to cause the development of the lactiferous ducts or the alveolar ducts. Okay, the ducts which supply the milk. Okay, so lactiferous ducts. It's a ductal development. It's the ductal development. Alveolar ducts. Excellent. Excellent. Excellent, Nidish. Excellent, Asik. Yeah, it's the ducts. Next, what else you should know here is, then what about the alveolar sacs or the lobular part of the breast? It's a lobular part of the breast. The lobular part of the breast will be developed with the help of progesterones. Progesterones helps in, see the progesterone which I am showing you here. See the progesterone, it is going to help in the breast development. Yes, but which part of the breast? It is alveolar sac. Sacs are the lobular part of the breast. Lobules. Okay, lobules. Lobular part of the breast which produces the milk actually. Okay. Now, see my questions to you. Sir, estrogen, it is coming from ovaries. Yes, estrogen is coming from ovaries. Which part of the ovaries? Follicles. Which cells of the follicles? It's a granulosa cell actually. So, it's a granulosa cell. Listen carefully. Under the influence of FSH, the granulosa cells, these granulosa cells will produce estrogen. So tell me, which cells produces the estrogen in the females? All credit goes to granulosa cells. Granulosa cells produce estrogen. Estrogen helps in breast development. Which part of the breast? Lactiferous ducts. Then what about the alveolar sacs or the lobular part? It is the progesterone. It is the progesterone. Okay. Now you are having a doubt, sir, from where this progesterone is coming? Let me tell you, first 14 days completed. Okay. First 14 days of the menstrual cycle completed. See, do you know what happens on the 14th day? On the 14th day, it is the estrogen. It is the estrogen. It gives the positive feedback for the release of which hormone? LH. So in the first 14 days, listen carefully, in the first 14 days, the estrogen levels in the female increase, and on the 14th day, it is this estrogen which will give the positive feedback for the release of what? LH. This is called as what? LH surge. Okay, so now write the question in your book. Positive feedback for LH surge given by. So tell me, on the 14th day, yes, there is LH surge, and who gives the positive feedback for the LH surge? It is the estrogens. It's the estrogens which gives the positive feedback for the LH surge. Okay, now fine. Now, LH, what it will do? Sir, once the LH is released, LH is going to act on the Graafian follicle, this matured follicle. See, on the 14th day, the follicle is developed, well developed. So this follicle, this immature follicle, let's say it is well developed. So this well developed follicle is called as what? Graafian follicle. So now this LH on the 14th day, it will cause the rupture. It will cause the rupture of this Graafian follicle, and that is called as what? Ovulation. So now tell me, which hormone is responsible for ovulation? Is it FSH? No. FSH is not responsible for the ovulation. It is the LH. LH causes ovulation. Second MCQ. Okay, ovulation due to which hormone? LH, not FSH, LH. Okay, next question to you. Sir, now okay, the follicle got ruptured. This ovarian, this Graafian follicle rupture ho gaya. So the rupture of this Graafian follicle is called as ovulation. Now this ruptured Graafian follicle will become corpus luteum. This ruptured Graafian follicle, the ruptured Graafian follicle will become corpus luteum, and this corpus luteum is the one which produces progesterone. So tell me, progesterone is coming from where? So the progesterone is coming from corpus luteum. What is corpus luteum? The corpus luteum is nothing but the ruptured Graafian follicle. So write next MCQ. Progesterone coming from where? Sir, progesterone, it comes from corpus luteum. But only corpus luteum produces the progesterone? No, it's not just the corpus luteum. Even the placenta can produce the progesterone during the pregnancy. Even the placenta can produce the progesterone from the 3rd month up to 3 months of the pregnancy. Up to 3 months, the corpus luteum produces the progesterone. From the 3 months till to the term, it is the placenta which produces the progesterone. Next question to you. Guys, I'm asking you, is it good to have too much amount of estrogen in the body? I'm asking you, is it good to have too much amount of estrogen? No, definitely not. Estrogen is too much estrogen is bad, because too much estrogen will cause the breast cancer. Too much progesterone is also bad. Too much of anything is bad. Remember this thing in your life, too much of anything is bad. So if you have sufficient amount of estrogen, and sufficient amount of progesterone, what they will do? Estrogen will give the negative feedback. See, estrogen, it is giving what? Negative feedback. Estrogen gives the negative feedback to FSH. Progesterone gives the negative feedback to LH. So always remember, very, very important FMGE question. You will again study this in your gynae also, that estrogens gives the negative feedback to FSH. Progesterone gives the negative feedback to the which hormone? LH. Estrogen gives the negative feedback to FSH. Progesterone gives the negative feedback always to LH. Okay. So this negative feedback is also very important. Next, they will ask you, sir, then what about the inhibin A and inhibin B? In this diagram, I can see inhibin B is there in the first 14 days of the menstrual cycle. Here inhibin A is there in the last 14 days of the menstrual cycle. What is this inhibin B and inhibin A doing? ये क्या कर रहे sir? Body में, female के body में क्या कर रहे sir? Always remember, inhibins give the negative feedback to FSH only. That is inhibin B as well as inhibin A, they will give the negative feedback only to FSH, So write inhibins, both inhibin A as well as inhibin B, both, they will give negative feedback. To which hormone? FSH. Inhibin B is produced in the first 14 days of the menstrual cycle. Inhibin A is produced in the last 14 days of the menstrual cycle. Okay, so this one also important. Inhibin A, inhibin B gives the negative feedback to FSH. Estrogen to the negative feedback to FSH. Progesterone gives the negative feedback to LH. Fine. Next, what else you should know from this page? Okay, what else you should know? See, look at the concentrate on the last cell. Concentrate on the last cell. See this cell. What is this cell? This is a lactotrope. What it will produce? Prolactin. It will produce prolactin. Prolactin helps in milk production. But wait, I'm asking you, imagine a 20-year-old girl. Okay, imagine a 20-year-old girl. See, this 20-year-old girl, is she having hypothalamus? Yes. Pituitary gland? Yes. Breast tissue? Yes. Then why she is not producing the milk? See, she is having the breast tissue, no? Then why she is not producing the milk? Why she is not lactating? Because see, we all know without having a baby, a female is never going to produce a milk. Okay? Why? The reason is, look carefully here. Hypothalamus is producing something called as dopamine. Hypothalamus produces what? Dopamine. This dopamine is also called as prolactin inhibitory factor. Prolactin inhibitory factor. What it will do? See, it is giving the inhibitory signal for the lactotropes. So, lactotropes are activated or inhibited? Lactotropes are inhibited. Without lactotropes, without lactotropic activation, no prolactin, no milk production. So, tell me, who stops the milk production? Which hormone is inhibiting the milk production? Dopamine. Dopamine is also called as prolactin inhibitory factor. Prolactin inhibitory factor or dopamine inhibits the milk production. Inhibits the milk production. So, this is also very important. You already know this, but right. Dopamine. Dopamine क्या करेगा sir? Inhibits prolactin. Okay. So, more dopamine means less prolactin. Opposite. Okay, dopamine is also called as what? Prolactin inhibitory factor. Next, what else you should know? What else you should know? See, in the anterior pituitary, my dear students, in the anterior pituitary, you see gonadotrope, corticotrope, thyrotrope, somatotrope, lactotrope, different types of cells are there, right? These are all different types of cells are there, producing different types of hormones, But out of all these cells, two cells will become pink in color. Upon staining, two cells are going to become pink in color. Okay, let me choose the colors. Yeah, two cells, they will stain pink in color. But remaining cells are going to stain blue in color. So, you already know this. From your pathology. Some cells are acidophilic cells, some cells are the basophilic cells. Excellent. Yeah, excellent, Kirtana. Himanshu. Yeah, I highly recommend this for your NEET PG, upcoming NEET PG exam also, 2026. Okay. So, tell me, which cells are acidophilic cells and which cells are basophilic cells? Which are acidophilic and which are basophilic? Right. Out of all these cells, these two which I am pointing right now, the somatotrope and lactotrope, right? In the next page, right, acidophilic cells, that is somatotropes, and lactotropes. Okay, somatotropes and lactotropes are what? They are acidophilic cells. They stain pink in color. Important. And what are the twin hormones, sir? What is the meaning of the word twin hormone? Twin hormones means the hormones which are same in structure, wise same, mechanism wise same. Okay. So, what is this concept of twin hormones? Say, whenever your growth hormone level increases in your body, whenever the growth hormone level increases, also prolactin, they both increase at same time. Growth hormone, whenever the growth hormone level increases in your body, prolactin also increases at the same time. Growth hormone, prolactin have the same structure. Still remember LPG mnemonic? LPG, growth hormone, prolactin, leptin, they are all acting via the same pathway, that is the JAK-STAT pathway. So, because same structure, growth hormone, prolactin have same structure. Okay, they both increase at the same time, so they are called as the twin hormones. Next, inhibitory signal from hypothalamus. See, your hypothalamus, okay, your hypothalamus always shows inhibitory signal. It will always try to inhibit something. Have I already taught you? Hypothalamus, by producing the dopamine, it will inhibit prolactin. Okay, by producing a hormone called as a somatostatin. Yes, your hypothalamus produce somatostatin, also called as what? Growth hormone, inhibitory hormone. Growth hormone, inhibitory hormone inhibits growth hormone release. Growth hormone release. So somatostatin inhibits growth hormone. Dopamine inhibits prolactin. Dopamine inhibits the release of the prolactin. Okay. Next. Have I already taught you this? FSH, have I already taught you? FSH helps in the production of estrogens. LH helps in the ovulation and helps in the production of progesterone. FSH helps in the production of estrogens. True. LH causes ovulation and helps in the production of progesterone. True. But estrogens always give the negative feedback to FSH. Progesterone always give the negative feedback to LH. Both inhibin A and inhibin B gives the negative feedback to FSH only. FSH only. Okay. Next. Sir, inhibin A is produced from where? Inhibin A is produced from where? Sir, inhibin B. Wait. Look at here. Look at this diagram. So, inhibin B, it is produced from the granulosa cells. It is this granulosa cells which produces the estrogen as well as the inhibin B. Then what about the inhibin A? Inhibin A is produced from corpus luteum. So, right, inhibin A, it is produced from corpus luteum. These are all MCQs. And also from placenta. Okay, already question asked. Guys, again I am emphasizing this. Just follow this. If your physiology is not done, if you feel like, sir, I couldn't able to finish the physiology on time, last 50 days are there, I don't know what to do with the physiology, just follow this. Okay, imagine, for example, this video is going to be, for example, 7.5 hours. Recommend your friends also. Okay, 7 hours or 7.5 hours. How much time? You can do it in 2 days. 3.5 hours one day, 3.5 hours other day. You can do the entire physiology. Okay, in 7 hours you are done with the entire physiology with the PYQs. Okay, so these are all the PYQ questions. So inhibin A is produced from where? The inhibin A is produced from the corpus luteum as well as the placenta. Who gave the positive feedback? Have I already taught you? The positive feedback for the LH surge is given by, the positive feedback for the LH surge on the day 14th is given by estrogens. Okay, estrogens. Done. Singular questions completed. Now let's discuss about the clinical cases. Okay, directly I am going to tell you what is the answer. See, imagine if the pituitary stalk of a female is damaged. Imagine this is happening in a female where her pituitary stalk cut ho gaya, sir. Look, this is the hypothalamus, here is the pituitary stalk, and here is the anterior pituitary and posterior pituitary. Now you tell me, if the pituitary stalk is cut, what will happen? What kind of features she is going to have? Because of the road traffic accident, she is having a head trauma. During this head trauma, the pituitary stalk cut ho gaya. So what will happen? So now tell me, your hypothalamus, will it control pituitary gland? No, not possible. Not possible. So what will happen to all the anterior pituitary hormones? All the anterior pituitary hormones like growth hormone, TSH, FSH, LH, ACTH, all of them are, see, decreasing. So all the anterior pituitary hormones will decrease. And what about the dopamine, sir? Do you think that dopamine from the hypothalamus, do you think it can come? No, dopamine is unable to come. No dopamine means no inhibition. No inhibition means prolactin is produced. So prolactin is produced, and the prolactin is going to, this unnecessary prolactin is going to cause galactorrhea. So in this female, because of the pituitary stalk injury, so tell me, pituitary stalk, if it is damaged, her prolactin level increases and she is going to have abnormal milk production called as a galactorrhea. Okay, fine. Excellent, Asik. Yeah, Asik Ali, yes, you are true. Next, Sheehan syndrome. Sir, what is the Sheehan syndrome? Sheehan syndrome. See, Sheehan syndrome meaning after delivering the baby, 9 months completed, you are delivering the baby. So after delivering the baby, because of massive blood loss, that is postpartum hemorrhage. See, now the female is having what? Postpartum hemorrhage. So that postpartum hemorrhage decreases the blood volume in the body, decreases the BP, less blood. Now she is into shock. Less blood is going to the pituitary gland. Pituitary gland mar gaya. So pituitary gland Now it's dead. Now it is dead. Pituitary gland is dead. So tell me, after delivering the baby, because of the massive postpartum hemorrhage, there is decreased blood volume in the body. Her BP decreases. She is into shock. Less blood is going to the pituitary gland. So pituitary gland is not happy because there is ischemia that is leading to hypoxia. That will ultimately lead to necrosis of the pituitary gland. So this is called as a postpartum necrosis of the pituitary gland in some females due to the complication of postpartum hemorrhage. So now you tell me, this condition is called as Sheehan syndrome. What is the problem? What is the problem in the Sheehan syndrome? Sir, entire anterior pituitary gland mar gaya. Entire anterior pituitary is dead. So all the pituitary hormones like growth hormone, TSH, FSH, LH, ACTH, even prolactin is going down. So all the pituitary hormones, all the anterior pituitary hormones will decrease. Sir, she is a mother. She want to give milk to the baby. So tell me, without pituitary gland, without prolactin, will she be able to lactate? Can she give the milk? No. So failure to lactate. Failure to lactation. So this is the thing which I want you to know. Okay, failure to lactation, guys. Guys, again I'm telling you, out of these two, one MCQ. Okay, one MCQ you may expect in your exam. Pituitary stalk damage. What is going to happen? Sir, pituitary stalk damage, all anterior pituitary hormones will decrease except prolactin. But what about the Sheehan syndrome? Sir, in Sheehan syndrome, all anterior pituitary hormones will decrease even along with prolactin. Even prolactin will also go down. So failure to lactation. Being a mother, she will always complain to the doctor that, doctor, I am not able to lactate. Okay, that's the thing. Next, the third clinical case which I want you to know. See, the third clinical case is, normally you already know this. Sir, this hypothalamus, there is a nucleus. This nucleus, what it will release? GnRH, gonadotropin releasing hormone. See, this gonadotropin releasing hormone, it will stimulate the gonadotropes. And the gonadotropes are going to release what? FSH, LH. First 14 days may FSH is released. Last 14 days may LH is released. This is what you already know. Okay, but wait. Now little difference is there. See, if the GnRH normally in our body, okay, let me show you here. Sir, normally in our body, how the GnRH is released? Sir, this GnRH, okay, let me write in the full form. Yeah, now it is clear. Now, GnRH, how it is released? Normally, physiologically. Sir, GnRH is released in pulsatile doses. See, pulses means regular intervals. So, if GnRH is released in pulsatile doses, pulsatile release of the GnRH, what the GnRH will do? Sir, GnRH stimulates the gonadotropes and gonadotropes produces FSH, LH. Normal. But if the same GnRH, if it is released continuously, now I am showing a solid line. Not pulsatile doses, not regular intervals, continuous administration of the GnRH. What it will do? It will actually inhibit the gonadotropes. For example, imagine you are having a girlfriend. Do you think your girlfriend is always going to excite you? Your girlfriend will always make you happy? No, sometimes she is going to make you happy. Sometimes she is going to make you feel sad. Sometimes she is going to fight with you. Sometimes she will depress you. Okay, so it is the same GnRH. How it is released? If it is released in pulsatile doses, sir, if it is released in pulsatile doses, yes, if it is released in pulsatile doses, FSH is produced and LH is produced. But if the same GnRH is given in continuous doses, the gonadotropes are inhibited and FSH level, times you can use it. Where, sir? Sir, in pulsatile doses, I will use it for the treatment of, Nafrelin is used in pulsatile doses for the treatment of delayed puberty. You know, delayed puberty means 16 years old girl without breast development, 16 years old girl without menstrual cycles, menses, no menses. So, she haven't started her puberty. अरे puberty को start करने के लिए, okay? So, delayed puberty को treat करने के लिए, in order to treat this delayed puberty, what you have to use? Nafrelin. How, sir? Pulsatile doses में. Because you already know if you use the drugs in pulsatile doses, gonadotropes are activated, FSH is produced, LH is produced. FSH helps in estrogen production, estrogen causes the breast development, estrogen causes the endometrial growth. You already know that, okay? But the continuous doses, right? Continuous doses of the GnRH analogs are used to stop the puberty. It's used to stop the puberty. That condition is called as precocious puberty. Precocious puberty. Okay, so delayed puberty को treat करने के लिए, in order to treat the delayed puberty, nafrlin is used in pulsatile doses. In order to treat precocious puberty, nafrlin is used in continuous doses. Okay, so these are the three very important clinical cases which I want you to know. At least you can expect one MCQ in your exam. One MCQ in your exam. Okay, chalo, done. Next, let's discuss about the posterior pituitary. Now tell me, posterior pituitary, it produces any hormones? No. Posterior pituitary just stores, not produces, just stores oxytocin, antidiuretic hormone. So from then where they are produced? Hypothalamus. Antidiuretic hormone and oxytocin, they are not produced in the posterior pituitary, but they are produced where? They are produced in hypothalamus. In which area, in which nuclei? Let me tell you. The mnemonic that I am going to give you, okay, that is SOAP. Mnemonic is SOAP. SOAP, SOAP. What is SOAP stands for? Supraoptic nucleus produces the antidiuretic hormone, paraventricular nucleus produces the oxytocin. So yeah, my students already knows this. So right, oxytocin is produced from where? Oxytocin produced from paraventricular nucleus. What is the function of oxytocin? You already know the function. Guys, you already know the function of the oxytocin. What is the function of the oxytocin? The function of the oxytocin is to cause uterine contractions. Uterine contraction. This is going to cause the uterine contraction and helps in the labor. It helps in the labor, and it also causes the milk ejection. Milk ejection. Okay, milk ejection means galactokinesis, the ejection of the milk let out, okay. So how the question was asked, okay, how the question was asked in the recent FMGE exams, the question was something like, female, okay, she is breastfeeding her baby, a female, she is breastfeeding her baby. The question was, which of the following hormone is involved during this process? Breastfeeding means what? Milk is coming out. Milk is coming out means it is because of the oxytocin, that is galactokinesis. And one more question. Which of the following hormone is responsible for the breast cramps? Okay, sir, breast cramps during the breastfeeding. Okay, the pain, whenever the female is giving the breastfeeding, definitely that's going to be a little painful because the oxytocin, it causes the contractions within the breast, and that will lead to discomforts or cramps. So the hormone responsible for the breast cramps, oxytocin. Okay, chalo, next. Next, sir, how the oxytocin is released? Okay, how this oxytocin is released? Let me tell you. Oxytocin is released via, okay, oxytocin is released via a reflex called as, very important for your especially NEET PG and INICET exams, released via the neuroendocrine reflex. Oxytocin is released via the neuroendocrine reflex. Now you are having it out. Sir, what is this neuroendocrine reflex and what I should know for my FMGE exam? Let me tell you. Guys, look at here. This is the neuroendocrine reflex. Everything I am showing here. Everything about the neuroendocrine reflex I am showing you here. Okay, now only concentrate on what I am teaching. Okay, rather than like writing, mainly concentrate. If you can write, but mainly concentrate on the things that I am teaching. Okay, see, you tell me, baby is going to stay in the uterus for how many days? Sir, baby is going to stay in the uterus for, let's say, 9 months. 9 months. The baby is going to stay in the uterus for 9 months. So tell me, after 9 months, what will happen? Sir, after 9 months, the baby's head, it is going to stretch the cervix. The baby's head is going to stretch the cervix. That is the stimulus for the release of oxytocin. So when the baby's head circumference increases, and that is stretching the cervical wall, so that gives the signal from here, a sensory neuron, okay, let me draw it here. A sensory neuron from the cervix will take that information to the hypothalamus. It will take the information to the hypothalamus. That means the cervix is getting stretched, 9 months completed, baby is ready to deliver. Okay. Now the hypothalamus will understand. Now the hypothalamus will give the signal for the posterior pituitary to release. Posterior pituitary, now it releases oxytocin. So tell me, sir, here a sensory neuron is involved. So that's why the word neuro. And in response, who is getting released? Oxytocin. Oxytocin is getting released. So that's why the name neuroendocrine reflex. Okay, it's a neuroendocrine reflex. The information is going to the central nervous system with the help of this neuron, and as a result, oxytocin is getting released. So neuroendocrine reflex. And what the oxytocin will do? Oxytocin causes the uterine contractions. The labor is going to happen. Okay, labor is going to happen. Okay. So now this is example number 1. But what is the example number 2? The example number 2 is, okay, imagine the baby is delivered. Baby deliver ho gaya, sir. Baby is delivered. Now what the baby will do now? The baby, now see, it is sucking the nipple. It is sucking the nipple and it is drinking the milk. So now I am asking you, when baby is sucking the nipple, see, when the baby is sucking the nipple, okay, again the information from the areolar region, from the breast region, again the information is going to the central nervous system with the help of a sensory neuron. See, this is the sensory neuron which is taking the information. And again hypothalamus, what it will release? Again the hypothalamus is going to release the oxytocin. Again the oxytocin is released, that is going to cause the contraction of the myoepithelial cells and milk ejection will happen. So again the word neuroendocrine reflex. Neuroendocrine reflex. So tell me, what are the 2 examples of the neuroendocrine reflex? The 2 examples of the neuroendocrine reflexes, sir. One is labor, releases oxytocin, and second one is breastfeeding, also releases the oxytocin. Okay, so tell me, what are the 2 examples of neuroendocrine reflex? The 2 examples of the neuroendocrine reflex. One is labor and other is breastfeeding. So how the question may come up in your exam, especially, sir, NEET PG exam. Labor is similar to which of the following? So labor is similar to breastfeeding, because in both the conditions, they are examples of neuroendocrine reflex, and in both conditions, it is the oxytocin that is getting released. Okay, so yeah, that is the important thing which I want you to know. So tell me, what is the condition where the oxytocin is released? Sir, oxytocin released by the neuroendocrine reflex. 2 conditions, labor, breastfeeding. Chalo, next. Vasopressin. Vasopressin is also called as what? Sir, vasopressin. Vasopressin is also called as antidiuretic hormone, right? Vasopressin produced from supraoptic nucleus. Keep 5-star marks here. Very, 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 very important. Antidiuretic hormone produced from supraoptic nucleus. Oxytocin produced from paraventricular nucleus of hypothalamus. Next one. What is the function? First, okay, rather than writing function, first write stimulus. What is the stimulus for the release of the vasopressin? See, tell me, what is the stimulus for the release of the oxytocin? Sir, oxytocin is released during the breastfeeding, and the oxytocin is also released during the uterine that's the labor. So now tell me, then in which conditions the antidiuretic hormone is released? Sir, antidiuretic hormone is released whenever the person is having dehydration. Okay, dehydration. But what is the best answer, sir? Let me write here. You have to mark hypertonic plasma. It is nothing but dehydration only, no? Hypertonic plasma means what? Concentrated blood. Sorry guys, hypertonic plasma means what? Hypertonic plasma means a concentrated blood. And in which conditions you will be having the concentrated blood? During dehydration. So right. So this is your question in your exam. Hypertonic plasma. Hypertonic plasma is the stimulus for the release of the antidiuretic hormone. Hypertonic plasma / dehydration. Okay. Then functions. What are the functions of the antidiuretic hormone? Sir, antidiuretic hormone, it's going to act on the nephron. It's going to act on the collecting duct, increases the water reabsorption. Now question is, okay sir, but which part of the nephron? Collecting duct. Which part of the collecting duct? Is it the cortical collecting duct or medullary collecting duct? What is the main site of action? The main site of action of the antidiuretic hormone. The main site of action of the antidiuretic hormone. Is it the cortical collecting duct or medullary part of the collecting duct? It is, sir, actually it acts on both cortical as well as medullary, but medullary collecting ducts, sir. Okay, medullary collecting ducts is the best answer. Medullary collecting duct is the main site of action for the antidiuretic hormone to reabsorb the water. Medullary collecting duct. Okay, medullary collecting duct followed by cortical collecting ducts. Okay, medullary collecting duct followed by the cortical collecting duct. MCQ. Okay, with the help of when antidiuretic hormone acts on the collecting ducts, with the help of aqua pouring 2 channels, water will be reabsorbed. Okay, done. So these are the basic things completed. Now regarding hormones, now we are going to discuss about the hormones. See, regarding the hormones, for the next half an hour we'll be discussing the most important things that you should know. Okay, see, in growth hormone topic, what you should know. In growth hormone topic, what you should know. Sir, growth hormone anabolica, catabolica. First, number 1 point, 5 minutes regarding one hormone. Growth hormone, first of all, it is anabolic hormone. Okay. Anabolic hormone. Fine, sir. Next, sir, being an anabolic hormone, what it will do? Sir, growth hormone anabolic, so it will cause breakdown or build up, body build up, protein synthesis. Okay, so 3 things which I want you to know. What growth hormone do to your carbohydrates, proteins and fats? Carbohydrates ko kya karega? What it will do to the carbohydrates, proteins and fats? Okay, anabolic hormone, no. So listen, number 1, growth hormone, listen, growth hormone, number 1, it stimulates glycogenolysis in the liver. Glycogenolysis. So tell me, what is the meaning of the word glycogenolysis? Glycogenolysis means glycogen breakdown. Glycogen breakdown is going to increase your blood sugar levels. So tell me, sir, growth hormone hyperglycemic, hypoglycemic? Sir, growth hormone causes the glycogenolysis in the liver and it's going to increase the blood sugar levels. Yes, it's a hyperglycemic hormone. It increases the blood sugar levels. Hyperglycemic hormone. Next, protein synthesis, protein metabolism, lipolysis. So that's it. These are the 3 things which I want you to know for your exam. 1, 2, 3. 1, 2, 3. So glycogenolysis करेगा, blood glucose levels को बढ़ेगा sir, blood glucose levels को बढ़ेगा. Protein synthesis करेगा, body build up, and lipolysis. Okay, extra fats will be broken down. And anyway, you already know, sir, growth hormone is going to cause the epiphyseal growth. Growth hormone causes the epiphyseal growth, means the bone growth. Fine. But let me tell you something important. Sir, growth hormone, when it acts on the liver, it's the same growth hormone. When it is acting on, where's the liver? When it acts on liver, growth hormone going and stimulating the liver. Now the liver is going to produce something called as insulin-like growth factor 1. Okay. So when growth hormone acts on the liver, liver will produce insulin-like growth factor 1, also called as a somatomedian. SMC means somatomedian. So what this fellow is doing to our body? What is this insulin-like growth factor does to our body, sir? See, in the name itself, it's there, insulin-like. Insulin jaisa काम करेगा, sir. Insulin jaisa काम करेगा, which means it decreases our blood sugar levels. Okay. Sir, growth hormone wants to increase my blood sugar levels, but insulin-like growth factor 1 decrease my blood sugar levels. Growth hormone, it wants to cause lipolysis, but here anti-lipolysis. Okay. So, one is like a brake and other is like an accelerator. Again, in a car we require both accelerator as well as a brake. Dono chahiye, sir. So in the same way, in our body also, there are some anabolic hormones and there are some catabolic hormones. Okay, and there are hormones which are producing glucose. There are the hormones which increase the blood glucose and there are hormones which decrease the blood glucose to maintain the homeostasis in the body. Growth hormone increase the blood glucose. This will try to decrease the blood glucose to maintain the homeostasis, not too much high, not too much low. Okay, something like that. So tell me, insulin-like growth factor 1 is produced from PYQ, liver. Insulin-like growth factor 1 coming from liver. Insulin-like growth factor 1, lipolytic? No, anti-lipolytic. Insulin-like growth factor 1, decrease the blood sugar levels. That's it. Next, keep 5-star marks for this table. Now, in which conditions in your body the growth hormone level increases? Stop. Tell me when oxytocin level increase in the body. Sir, oxytocin is increased during labor. Oxytocin is increased during the milk feeding, like that's galactokinesis. Oxytocin is increased whenever the baby is sucking the nipple. Okay, when antidiuretic hormone is released, antidiuretic hormone is released whenever the person is suffering with dehydration. Dehydration, hypertonic plasma. Hypertonic plasma is the stimulus for the release of antidiuretic hormone. In the same way, कौन से conditions में, in which conditions the growth hormone levels are going to increase? Growth hormone levels किस conditions में बढ़ेगा sir? So by heart this table, all the hypoglycemic conditions means conditions where my blood glucose levels are going down. All hypoglycemic conditions, fasting, exercise, stress, trauma, and hormones like ghrelin, glucagon, after eating protein meals like chicken biryani sir, after eating meals, and sleep, during sleep, especially that to deep sleep, NREM stage 3 and 4. So in these conditions में growth hormone levels बढ़ेगा. In the blood the growth hormone levels are going to increase. So tell me, what are the conditions in which the growth hormone level increases? All hypoglycemic conditions, fasting, ghrelin, glucagon, exercise, stress, trauma, after eating protein meals, NREM stage 3 and 4, deep sleep. In all these conditions, the growth hormone levels are going to increase. Growth hormone level increases. Now, some students are having a doubt. Sir, what about this ghrelin, sir? Okay, what about this ghrelin? I have never heard about this ghrelin. Some of you already know this. Ghrelin. What is this ghrelin, sir? See, ghrelin is a hormone. Okay, ghrelin is a hormone produced from pancreas. Produced from pancreas during fasting. Yes, Keval, yeah, you are true. Okay, excellent, Elon Musk, yeah, you are also true. So, ghrelin is the one which is produced from the pancreas during fasting. What it will do? Very, very important FMGE question. It increases your hunger. Hunger sensation is increased by. Hunger sensation is increased by the ghrelin. And from where it is coming? It is coming from the pancreas. During which condition? During fasting condition. And anything else about the ghrelin you should know? Yes, ghrelin increases your growth hormone. Ghrelin increases your growth hormone. Okay. So that's why it is very good to do the fasting at least once a week or twice in a month. At least twice in a month do the fasting, your growth hormone level increases. Okay. Next, then who decreases the growth hormone, sir? Growth hormone decreased by. Sir, growth hormone is decreased whenever there is hyperglycemia, like diabetics. Okay, hyperglycemia. Somatostatin, also called as what? Somatostatin is also called as a growth hormone inhibitory hormone. And during REM sleep, during rapid eye movement sleep, the growth hormone level decreases. And cortisol. Stop. Sir, cortisol, which hormones, tell me, which hormones increases the growth hormone? Ghrelin, glucagon, they increase the growth hormone. But cortisol, it's a catabolic hormone or catabolic hormone. So cortisol kya karega? Cortisol decreases the growth hormone. Cortisol decrease the growth hormone. So hormones increasing growth hormone and the hormones decreasing growth hormone. You should know. You should know from this table. Ghrelin, glucagon increase the growth hormone, but cortisol decrease the growth hormone. So how you can expect a question? You can expect a question something like this from this table. See, they will show a table something like this. They will ask you, sir, what is this hormone increasing after eating, taking protein meals, and increasing again after exercise, again increasing after sleep, again increasing in the deep sleep. So what is this hormone? Identify the hormone. Image based question. So growth hormone increases during, come on, repeat after me. Growth hormone किस conditions में बढ़ेगा sir? Growth hormone increases during all hypoglycemic conditions, fasting, ghrelin, glucagon, exercise, stress, trauma, after eating protein meals, and sleep. NREM stage 3 and 4. Deep sleep के time में growth hormone levels will increase. Which hormone decreases the growth hormone? Cortisol decreases the growth hormone. Done. Okay, growth hormone important things completed. You already know whenever the growth hormone level increases, that will cause gigantism and acromegaly in adults. Whenever the growth hormone level decreases, that will cause a dwarfism in children. Children may dwarfism. Less growth hormone. Okay, let me just here. Okay, so growth hormone. Okay, let me write in the middle of the page. Growth hormone
deficiency will cause what? Dwarfism. Growth hormone level excess. Okay, if it is excess during the childhood, that will cause gigantism. If it is excess during adulthood, it will cause which condition? Acromegaly. Okay, acromegaly. So now from your medicine, I'm asking you this question. Tell me, I'm the one, imagine I'm the one who is suffering with the acromegaly. I'm the one who is suffering with which condition? Acromegaly. So tell me how you are going to treat me. What is the drug of choice for the treating of acromegaly? Body पे ज़्यादा growth hormone है. Body पे ज़्यादा growth hormone है. So tell me how you are going to deal with me, the patient of acromegaly. What is the drug of choice? Okay, octreotide, lanreotide. Okay, octreotide or lanreotide. Octreotide, lanreotide. Most of the time in your exam, they will use, instead of using octreotide, they will use the lanreotide. Both are same things. Okay, octreotide, lanreotide, they are somatostatin analogs. Octreotide, yes, yes, yes. See, Piyush, don't get confused. See, this stress is different. Okay, here don't confuse. Okay, just wait. So Piyush is having it out. So stress means stress hormone like cortisol. No, this stress is different. Okay, the degrees of stress are different. Okay, see here high cortisol levels in the body. For example, like Cushing syndrome. Okay, see this stress is like a bit. Okay, whenever you are doing fasting is also a stress on the body. Exercise is also a stress on the body. So yes, the degree of stress is different. No, so if they use the word stress, if they use the word stressful conditions, increase the growth hormone. Okay, so here high levels of cortisol, the too much high levels of cortisol like in Cushing syndrome, that will decrease the growth hormone. Okay, chalo, done. Next, after this, let's go with the thyroid hormones. In thyroid hormones, what is the important thing that you should know? Sir, for the production of T3, T4, what is the enzyme required? Come on, tell me. Enzyme required for T3, T4 production. There is one important enzyme. So, in the thyroid gland, to produce this T3, T4, what is that one super important enzyme that is required? The one super important enzyme that is required for the production of T3, T4 is thyroid peroxidase. In short form, you can call it as a TPO. So TPO, that's a thyroid peroxidase. TPO, that's a thyroid peroxidase, which is required for the production of T3, T4. Next question to you is, sir, this thyroid peroxidase, yes, it is an enzyme. No, it will do some reactions. Which reactions, sir? It will do three reactions. It will do three reactions. What are the three reactions? The three reactions are oxidation, organification, and coupling reaction. So these three steps are required for the production of T3, T4. Repeat. Sir, what is the enzyme that is required for the production of T3, T4? Thyroid peroxidase. Okay, thyroid peroxidase. And what this thyroid peroxidase will do? So the thyroid peroxidase, it will help in three steps called as oxidation, organification, coupling reaction. These three steps help in the production of T3, T4. T3, T4 produce करने के लिए these three steps are required: oxidation, organification, coupling reaction. Now, for your FMGE exam, what you should know, sir, this thyroid peroxidase can be inhibited. TPO inhibitors. Sorry. TPO inhibitors. Can you tell me some drugs which are TPO inhibitors, thyroid peroxidase inhibitors? Thyroid peroxidase can be inhibited. Thyroid peroxidase can be inhibited by certain drugs. Come on. Excellent, Keval. Yeah. Arsh. Yeah, you're true. Yeah. So TPO inhibitor, thyroid peroxidase inhibitors are propylthiouracil. Okay, propylthiouracil. Next, any other? Carbimazole, methimazole. Okay. Propyl thiouracil, carbimazole, methimazole, these are the thyroid peroxidase inhibitors. So now tell me, for your FMG exam, sir, this propyl thiouracil, prothyroid drug, anti-thyroid drug, they are anti-thyroid medications. They decrease the T3D4. They will inhibit this enzyme. So what these drugs will do? So they are all anti-thyroid medications. They will decrease T3D4 production. So they are all anti-thyroid drugs. Anti-thyroid. Okay, now they are all anti-thyroid drugs. Okay, but where we will use them? Propyl thiouracil is the drug of choice for hyperthyroidism. Okay, now propyl thiouracil is the drug of choice for what? Hyperthyroidism. Where? In the first trimester of the pregnancy. The first trimester of pregnancy. So during pregnancy, in the first trimester, what is a safe drug that should be used? Propyl thiouracil, and it is also safe drug during lactation. It's also safe drug during lactation. Then what about the drug of choice for hyperthyroidism in the second and third trimester? So right, in the second and third trimester. In the second trimester, third trimester, and also for the treatment of Graves' disease, what is the drug of choice? Carbimazole. Okay, carbimazole. Okay, so for the second and third trimester, you can go with the carbimazole, methimazole. Okay, carbimazole, methimazole are for the second and third trimester as well as the Graves' disease. But first trimester of the pregnancy, lactation में propyl thiouracil. Next, sir, in the thyroid hormones, what else you should know? Tell me, thyroid hormones are derivatives of T3 and T4. Thyroid T3 and T4 derivatives of which amino acid? Sir, T3, T4 are, they are derivatives of which amino acid? They are derivatives of tyrosine. Tyrosine amino acid. They are derivatives of what? Tyrosine amino acid. They are derivatives of tyrosine amino acid. Next, thyroid hormones behave like dash. Thyroid hormones behaves like what? Sir, thyroid hormones, they are lipid soluble hormones. So they will cross the cell membrane. So they behave like steroid hormones. So thyroid hormones and steroid hormones both are lipid soluble hormone. They crosses the cell membrane. They will enter into the cell. So yes, thyroid hormones behaves like steroid hormones. Thyroid hormones behaves like steroid hormones. And one more thing which I want you to know regarding the thyroid topic, very, very important topic. Tell me, sir, if you take lot of iodine, okay, increase iodine uptake. So normally, you know, this iodine is very much required for the production of the thyroid hormone. Iodine is required for the production of what? Thyroid hormones. Iodine helps in the thyroid hormone production. You already know this. But increase iodine uptake means you are taking too much amount of iodine every day. So the increased iodine uptake will actually decrease T3, T4 production. Means high doses of iodine uptake actually decrease the T3, T4 production. Rather than increasing, paradoxically decreases the iodine, decreases the T3, T4 production. What is this effect called as? Excellent. Caroline, Keval, yes. That is Wolff-Chaikoff effect. Wolff-Chaikoff effect. That is, increased iodine uptake is going to decrease the T3, T4 production. Next thing, sir, which thyroid hormone is mainly produced? Mainly, that's the T4. T4 is mainly produced in high quantities. Okay, it's mainly produced in high quantities. So you have to convert what? You have to convert the T4 into the T3 form, because you know already T3 is the most active form. You have to convert this T4, which is slightly inactive, less active form. Sir, you have to convert this less active form to highly active form. T4 need to be converted into what? T4 need to be converted into T3. You have to activate it. So what is the name of this reaction called as? The name of this reaction is called as the conversion of T4 into T3. What is the name of this reaction called as? The name of this reaction is called as peripheral conversion. Peripheral conversion. Okay, now peripheral conversion with the help of an enzyme. With the help of an enzyme. What is the name of the enzyme called as? 5' deiodinase. 5' deiodinase. Excellent. Excellent. Harka, yes, you are true. Peripheral conversion, ASIC. Peripheral conversion with the help of which enzyme? 5' deiodinase, also called as D1. Remember D1 for your exam. D1 deiodinase or the 5' deiodinase converts the T4 into T3. Okay. Now, questions to you. Sir, where is this D1 deiodinase present? Idhar hai sir. Where is this D1 deiodinase present? Where is this conversion happening? Sir, this conversion is happening, peripheral conversion is happening in your liver mainly and kidneys. This peripheral conversion, the conversion of T4 into T3 mainly happens in the liver and kidneys. Liver and kidneys. Next. Now tell me, so what is the drug which can inhibit? There are certain drugs which can inhibit this peripheral conversion. There are drugs which can inhibit this peripheral conversion. Can you tell me what are those drugs? Drugs inhibiting the peripheral conversion. Two drugs are there which will start with the letter P. That is propyl thiouracil and propranolol. Okay, propyl thiouracil, propranolol. How to remember for your exam? PPP. Remember, peripheral conversion is inhibited by propyl thiouracil and propranolol. Everything PPP. So peripheral conversion can be inhibited by propyl thiouracil and propranolol. Usually, where we will use these drugs? We'll use these drugs in the treatment of. Thyroid storm. Excellent. Excellent, Keval. Thyroid storm. We'll use these drugs in the treatment of thyroid storm. And you know what thyroid storm is? Thyroid storm means what? Sudden increase in thyroid hormones in the blood. Sudden increase in thyroid hormones in the blood during the surgery. Okay. So if suddenly the T4 level increases in the blood. Okay. If suddenly the T4 level increases in the blood, the T4 will be converted into what? T3. T3 will cause a lot of problems. Suddenly if the T3 levels increase in the blood, that will cause tachycardia, that will cause high body temperature, that will cause high BP, that can actually kill the patient. So what you have to do? You have to stop this peripheral conversion. So how to stop this peripheral conversion? By giving propyl thiouracil and propranolol. Fine. Next. Regarding thyroid hormones, what else you should know? Very important topic. Very important topic. Difference between primary versus secondary hyperthyroidism. Difference between primary versus secondary hyperthyroidism. Primary means what? Let me tell you. Sir, primary hyperthyroidism means, just listen carefully. Here is the hypothalamus, pituitary gland and thyroid gland. So imagine today you are having a tumor here, where the tumor in primary problem lies in the thyroid gland. Here there is a tumor. What the tumor is doing? So the tumor is producing lots and lots of T3 and T4. Lots and lots of T3, T4 is produced. So now when you have sufficient amount of T4, when you have sufficient amount of the thyroid hormones, not sufficient, too much amount of thyroid hormones are there. Now what this thyroid hormones will do? The thyroid hormones will give the negative feedback to the pituitary gland and will suppress TSH. So in primary hyperthyroidism, the TSH levels are low, T3, T4 levels are high. T3, T4 levels are very high. Okay. But what about the secondary hyperthyroidism? Sir, in secondary hyperthyroidism, look carefully, there is a problem. The problem is here. The problem lies in the pituitary gland. Look here. So now here is a problem. Where is the tumor? Now the tumor is in the pituitary gland. Now what the tumor is doing? So the tumor is producing excessive amount of TSH Now the TSH is stimulating the thyroid gland so much. Now the thyroid gland is producing lots and lots of T3 and T4. As there is excessive amount of TSH, this excessive amount of TSH stimulates the thyroid gland too much. So thyroid gland is making too much amount of T3 T4. So tell me here T3 T4 is more as well as the TSH is more, as well as the TSH is more. So TSH here, TSH is high as well as the T3 T4 also high, also high. So both TSH, T3 T4 also high. Okay, so these are some things which I want you to know, the difference between primary and secondary hyperthyroidism. Last and final, sir, thyroid hormones anabolica, catabolica. Thyroid hormones anabolica, catabolica. Thyroid hormones are catabolic. Catabolic, which means breakdown or build up. Breakdown, everything breakdown. So glycogenolysis. Next, proteolysis, lipolysis, everything breakdown. Glycogenolysis, proteolysis, lipolysis, everything breakdown, everything breakdown. Okay. Next, what else you should know regarding thyroid hormones? So thyroid hormones, they increases sodium, potassium pumps or ATPases. They increases our sodium potassium pumps or ATPases on our cell surface. So now whenever the thyroid hormones are there in our body, the thyroid hormones increase the number of the sodium potassium ATPases. So more ATP breakdown or less ATP breakdown. So in the body there is more energy breakdown, sir. More ATP is getting broken down. So you will use more energy in a day or less energy in a day. You will use up more and more energy. Instead of using 3000 kilocalories, now you will start to use 4000 kilocalories or 5000 kilocalories. So your metabolism increases, your basal metabolic rate increases. The number of calories you are using in a day increases. How? By increasing the sodium potassium pumps. So yes, thyroid hormones increase the sodium potassium pumps. More the sodium potassium pumps, more the basal metabolic rate. So yes, which hormone increases the basal metabolic rate? Thyroid hormones increase the basal metabolic rate by increasing which pumps? Sodium potassium ATPase or sodium potassium pumps. Last and final thing, sir, thyroid hormones, what they will do to your bones? Bone development as well as brain development. बोन डेवलपमेंट एज वेल एज ब्रेन डेवलपमेंट. बोन्स को डेवलप करने के लिए, स्केलेटन को डेवलप करने के लिए, एज वेल एज ब्रेन को डेवलप करने के लिए, सर विच हार्मोन्स आर रिक्वायर्ड? थायराइड हार्मोन्स आर रिक्वायर्ड फॉर द बोन डेवलपमेंट एज वेल एज द ब्रेन डेवलपमेंट. सो दैट इज द रीजन व्हाई whenever the thyroid hormones are not there in the baby, imagine I am the baby, sir, I am the baby, I am not having thyroid hormone. So from my birth itself, I am not having thyroid hormone. That is congenital hypothyroidism. Means by birth itself thyroid hormones are not there. So do you think I can grow? No, stunted growth, mental retardation, brain is not going to develop. So this condition is called as a cretinism. So congenital hypothyroidism means from the birth thyroid hormones are not there, means the baby is not going to grow and the babies become mentally retarded. So this condition is called as cretinism. So let me write here, congenital hypothyroidism. Congenital hypothyroidism will lead to cretinism. Okay, will lead to cretinism. And you know what exactly is seen in the cretinism? Stunted growth. The baby is not going to grow. The stunted growth along with the mental retardation. The baby's brain will not be developed, mentally retarded. Okay, so with this successfully what we have completed, thyroid hormone topic also completed. Guys, is it everything clear? See, I am trying to cover as much as possible. Regarding the every hormones. So let's say if endocrine, if you are getting some 3 questions out of the endocrine. Okay, if you get 3 questions out of the endocrine, yeah, we should be able to do that. Okay. Chalo. Let's continue. Now let's discuss about the insulin. Sir, regarding insulin topic, now what you should know? Regarding insulin hormone, what you should know? Sir, we all know insulin is released from where? Insulin is released from the beta cell of the pancreas. Okay, beta cell of the pancreas. Insulin को release करने के लिए, see, these are the vesicles which contain insulin. Insulin is present here. Insulin is present here. Insulin को release करने के लिए, see, insulin को release करने के लिए, you have to block these channels. You have to block these channels. Which channels you have to block? This channel is called as ATP sensitive potassium channel. So the ATP levels inside the cell, when the ATP level inside the cell increases means see after eating your cells are getting the glucose. Okay, your pancreatic beta cells are getting the glucose. See, after eating, the glucose will go where? Into the pancreatic beta cell. Glucose will produce ATP. What this ATP will do? ATP is going to block the potassium channels. So right, number 1. Sir, ATP sensitive potassium channels are present where? ATP sensitive potassium channels are present on the beta cells of the pancreas. Beta cells of the pancreas. You have to block them. See, ATP inhibits these potassium channels. So which hormone is released finally? Insulin will release. So insulin को release करने के लिए which channels you have to block? Potassium channels you have to block. Who blocks these potassium channels? ATP. How ATP levels will increase? Because of the glucose. When you have the glucose into the cell after eating, so खाना के बाद after eating your blood glucose levels increases, glucose goes into the cells, glucose converts into ATP, ATP blocks these channels. Right. One more thing, sir, in order to do this exocytosis of insulin, see the insulin vesicles are undergoing exocytosis. Okay. So exocytosis करने के लिए you require some important ions. Which ions are required? Calcium. Calcium ions are required. So which ion helps in exocytosis of the vesicles? Not only insulin but any other thing. So exocytosis करने के लिए which ions are required? Calcium. Calcium helps in exocytosis. FMGE question. Calcium helps in exocytosis of the vesicles. Okay na? Next. What else you should know? Sir, insulin is acting on which receptor? Insulin is acting on, see this is the insulin, these are the insulin molecules. Insulin is acting on, have I taught you? Insulin acts on tyrosine kinase receptor. Insulin acts on what? Tyrosine kinase receptor. Sir, where is this tyrosine kinase receptor present? On all the cells in the body? No. Sir, this tyrosine kinase receptor, it is present on your fat cells, adipocytes and skeletal muscles. Okay. So whenever insulin is acting on the cells will produce, GLUT4 transporters. With the GLUT4 transporters, the remaining glucose from the blood will go into the cells. So important questions, let's write one by one. Right. Number 1. GLUT present on the pancreatic beta cell. Which type of GLUT is present on the pancreatic beta cell? Okay, GLUT on beta cell of the pancreas. Which GLUT? Check. Sir, on the beta cell of the pancreas. See, this is the beta cell of the pancreas. Which type of GLUT is present? Sir, it is GLUT2. Okay. Answer is GLUT2. Next. Which type of GLUT is present on adipocytes and skeletal muscles? The answer will be GLUT4. Okay. Next, insulin receptors. Where are insulin receptors present in our body? Insulin receptors are present on brain? No. Insulin receptors, that is the tyrosine kinase receptors, present on adipocytes and skeletal muscles. Next, what else you should know? Sir, wherever you see the word GLUTs, see, you know, GLUTs helps in the transport of the glucose. GLUTs means glucose transporters, helps in the movement of the glucose. That is type of which transport? GLUTs are examples of. Okay, GLUTs are examples of. Always GLUTs are examples of facilitated diffusion. Okay, GLUTs are examples of what? Facilitated diffusion. Means they are helping the movement of glucose from high concentration to low concentration. Look carefully here. Here the glucose is going from high concentration to low concentration. Here also glucose is going from high concentration to low concentration. So doesn't matter GLUT1, GLUT2, GLUT3, GLUT4, GLUT5, GLUT7, GLUT12, doesn't matter. Always the GLUTs are examples of movement of glucose from high concentration to low concentration. So facilitated diffusion. So how to remember this exam? I give you a mnemonic. In classes, I gave you a mnemonic. That is GF. All gluts are examples of facilitated diffusion. Gluts are examples of what? Facilitated diffusion. GF, like girlfriend, gluts facilitate diffuse. Okay, facilitated diffusion. Next, a few more. Sir, insulin dependent glut. Where is insulin dependent glut? Insulin dependent glut. Which gluts are insulin dependent? In the glut transporters which require insulin. So insulin dependent glut, answer should be glut 4. I have taught you glut 4, which is present on the skeletal muscles, adipocytes, they require the insulin. You have to have insulin for the production of the glut 4. So glut 4 को produce करने के लिए insulin चाहिए sir. Okay, so insulin dependent glut is glut 4. Hello, 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 hello. Start. Continue. Yeah, chalo. Again, there is a small technical glitch, guys, with the audio. So yeah, let's continue. Okay, let's continue. If there is any like technical glitch, you'll be getting a short break. In that short break, you can revise. Okay, you can revise. Next, what else you should know regarding the insulin? So insulin, it's an anabolic hormone, right? Insulin, kya hai sir? It's an anabolic hormone. Anabolic hormone. Now, what it will do to our body? Sir, being an anabolic hormone, definitely it will cause a protein synthesis. Everyone knows causes protein synthesis. Okay, insulin, anabolic hormone, protein synthesis. That's the body buildup. Apart from this, what else you have to know? Sir, insulin activates what? Glycogenesis, or you can say glycogen synthesis. Glycogen synthesis means insulin always try to cause the glycogen synthesis, means conversion of the glucose, taking the glucose from the blood, converting into glycogen in the liver, trying to decrease the blood sugar levels. So I'm asking you, you tell me, what is the role of glycogen synthesis? Glycogen synthesis is to convert the glucose into glycogen, converting the glucose into glycogen, so blood glucose levels will decrease. That is what we want. No, insulin always wants to decrease the blood glucose levels. Insulin activates lipogenesis, means taking the glucose out of the blood, converting into fats in the adipose tissue. So it promotes lipogenesis, and it also promotes glycolysis. What is glycolysis meaning? Glycolysis meaning taking the glucose into the cells, converting into ATP, using it for the production of the ATP. Okay, first pyruvic acid and later ATP. So insulin, which reactions it will activate, which reactions it will inhibit? Biochemistry, insulin biochemistry. Insulin activates glycogen synthesis, lipogenesis and glycolysis. Then insulin inhibits which reactions? Insulin inhibits. See, insulin always wants to inhibit glycogenolysis. Glycogenolysis. You tell me, what is the outcome of glycogenolysis? Sir, glycogenolysis means glycogen breakdown. So glycogen breakdown means more increase in the blood glucose levels. No, we don't want that. Insulin don't want that. Insulin always inhibit the glycogenolysis. Inhibits gluconeogenesis, means production of a new glucose. Whenever there is insulin, insulin promotes lipogenesis, so lipolysis is inhibited. Till the time insulin is there in the body, ketone bodies are not produced. Ketone bodies or keto acids are not produced. You know, these ketone bodies are nothing but acids. Ketone bodies are nothing but the acids. Okay, so tell me, insulin activates which reactions? 3. That is glycogen synthesis, lipogenesis, glycolysis. All of them are activated. But insulin inhibits what? Insulin inhibits glycogenolysis, gluconeogenesis, lipolysis and ketogenesis are all inhibited. So now, based on this, tell me, today sir, हमारे body में insulin नहीं है. That is insulin deficiency, type 1, diabetes mellitus. So there is no insulin. Whenever insulin is not there, tell me what will happen? Sir, insulin is not there. इंसुलिन नहीं है तो क्या हो जाएगा सर? देयर इज इंक्रीज ketones or increase keto acids in the body, like beta hydroxybutyric acid. It's a ketone body. So body में insulin नहीं है तो ketone bodies बढ़ जाएगा, keto acids बढ़ जाएगा. So what will happen to the pH? pH will decrease. Okay, the pH will decrease less than 7.35. pH will decrease less than 7.35. So that is going to cause metabolic acidosis. So that condition is called as diabetic ketoacidosis. So tell me, in the type 1 diabetic patients who is not taking the insulin, the type 1 diabetic fellows who is a defaulter of insulin, they are not taking the insulin. Whenever they are not taking insulin, their ketone levels increases in the body, and ketones are always acid. Acid क्या करेगा सर? Metabolic acidosis करेगा. हमारे body pH कम हो जाएगा. Okay, acidosis हो जाएगा. So now tell me, what is the most common cause of death in DKA? Very famous question. Sir, what is the most common cause of death in DKA? Sir, DKA fellows will die with what? Sir, the DKA fellows will die with cerebral edema. Okay. The rapid correction, yes, exactly. The rapid correction of the blood glucose levels is going to cause a cerebral edema. Cerebral edema. The most common cause of decay, the most common cause of death in decay is cerebral edema. But what is the treatment of choice? If they ask you what is the drug of choice or treatment of choice, first line treatment, tell me first line treatment. First line treatment. What is the first line treatment in DKA? Hypertonic salina or hypotonic salina? What is the first line treatment in DKA? DKA, not cerebral edema, not cerebral edema. What is the first line treatment for the DKA? See, I am the baby with the DKA. I am the 10-year-old with the DKA. I am coming to you. So, what is the first line treatment for the DKA? That is normal saline. Okay, not hypertonic or not hypotonic, normal saline, that is 0.9% sodium chloride. 0.9% sodium chloride solution is called as normal saline. Normal saline. What is the drug of choice for the DKA? Drug of choice for DKA is regular insulin. Regular insulin. They will ask you fast acting insulin or long acting, something like that. So it's a regular insulin. Normal saline is given, and most common cause of death is cerebral edema. Cerebral edema. And one more thing regarding the diabetic ketoacidosis. See, if I am the one with the diabetic ketoacidosis, listen, I am the one with DKA. Do you know how I will breathe? I will breathe like this. So always the DKA patients always have hyperventilation. What is the name of that hyperventilation is called as? So in DKA there is going to be hyperventilation. So that hyperventilation is called as Kusumal breathing. Okay, so Kusumal breathing is the hyperventilation, not the hypo, it's the hyperventilation which is seen in the patients of diabetic ketoacidosis. Why they are doing the hyperventilation? Why they are doing this Kusumal breathing, sir? Why they are doing this hyperventilation? अरे acidosis है ना body में? Okay, ज़्यादा carbon dioxide है ना? Sir, to decrease the carbon dioxide levels. They are doing the hyperventilation to decrease their carbon dioxide levels in the blood. So carbon dioxide decrease means acid decrease. Okay, because you know carbon dioxide is an acidic gas. Carbon dioxide is an acidic gas. So if you decrease the carbon dioxide, acid levels in the body decreases. pH will come back to normal. Compensation करने के लिए, this metabolic problem is compensated by respiration. So that's why these babies are going to do, these fellows are going to do hyperventilation. Okay, to correct the pH. So done. Next, after this, last but important thing, one thing about the insulin is, sir, if one molecule of insulin is produced in the body, one molecule of insulin is produced, one molecule of one more substance is produced, sir. With every one molecule of insulin, one molecule of C-peptide is produced. With every molecule of insulin that is produced endogenously, one molecule of C-peptide is produced. Okay, so this is the question that they will ask you. C-peptide is produced equally along with what? Insulin. C-peptide is produced in equimolar concentration along with insulin. So, can I say, if there are 100 C-peptides in the urine, it's a waste product. C-peptide is a waste product. It will come out of the body. If there are 100 C-peptides in the urine, how much insulin is produced in the body? 100 molecules of insulin is produced in the body. So that's why C-peptide is the marker for endogenous insulin levels. So I want to know how much insulin is there in your body. How I can know that? I cannot directly know the insulin levels because insulin levels are going to be, insulin is going to have a very short half-life. So I cannot directly know your insulin, but indirectly I can calculate your insulin by using C-peptide. So C-peptide is a marker of endogenous insulin levels. Done? So now we are going to the end. Aldosterone. Now let's discuss about the aldosterone. Sir, aldosterone does three things in our body. Aldosterone, right, acts on collecting ducts of the nephrons. What is the stimulus for the release of aldosterone? What is the stimulus for the release of aldosterone? When, in which condition aldosterone is released? What is the stimulus for the release of aldosterone? The stimulus for the release of aldosterone is hyperkalemia. Means whenever your potassium level increases, that is called as a hyperkalemia. Hyperkalemia stimulates the release of aldosterone. Now, next question to you, sir, at what level you will say the hyperkalemia, sir? Normally, potassium level is from 3.5 to 5. 3.5 to 5 milliequivalents per liter is the hyperkalemia. But if your potassium levels become more than 5.5 milliequivalents per liter, if your potassium levels become more than 5.5 milliequivalents per liter, then it is called as hyperkalemia. Okay, hyperkalemia. So next question to you. Sir, okay, hyperkalemia releases aldosterone. Okay, fine. Then what is the function of the aldosterone, sir? The functions of aldosterone are three functions are there. What are the three functions of aldosterone? Aldosterone will increase your sodium levels in the body, increases the sodium reabsorption from the urine. Aldosterone increases the sodium reabsorption from the urine, but aldosterone decreases the potassium levels in the body. Aldosterone causes the potassium excretion. Out of the body, so blood potassium level decreases and acid level also decreases. Excrete acid. So aldosterone excrete potassium, true. Aldosterone excrete acid, true. Aldosterone reabsorbs sodium. So aldosterone सोडियम को क्या करेगा सर? सोडियम को reabsorb करेगा, पोटेशियम को excrete करेगा और एसिड्स को भी excrete करेगा. Okay, so these are the functions of the aldosterone. Now I am asking you, tell me what is the drug of choice for hyperkalemia? Sir, hyperkalemia drug of choice is calcium gluconate. Just know this one thing. Hyperkalemia, what is the drug of choice? Calcium gluconate. Okay, sir, fine. Then what is Conn syndrome, right? Sir, Conn syndrome. In Conn syndrome, what you should know is, here is the adrenal gland, here is the adrenal medulla, and here there is a tumor. What is the name of this tumor? The name of this tumor is called as adrenal adenoma. Here there is an adrenal adenoma. So what this adrenal adenoma is doing my dear students, sir, this adrenal adenoma, okay, it is producing excessive amount of aldosterone in the body. इस ज्यादा aldosterone की वजह से, see, can I call it as a hyperaldosteronism? Conn syndrome is an example of primary hyperaldosteronism. Okay, primary hyperaldosteronism. ज्यादा aldosterone है बॉडी में, इस ज्यादा aldosterone की वजह से सोडियम लेवल्स बॉडी पे बढ़ेगा और पोटेशियम लेवल्स कम हो जाएगा और एसिड लेवल्स भी कम हो जाएगा सर, लीडिंग टू hypertension. Okay, sodium levels are increasing, that will lead to hypertension. Potassium levels are decreasing, that will lead to hypokalemia. And acid levels are decreasing, that will lead to metabolic alkalosis. So the name of this condition is called as what? Conn syndrome, which is an example of a primary hyperaldosteronism due to a adrenal adenoma, due to aldosterone secreting tumor. This one, aldosterone secreting ट्यूमर. ज्यादा aldosterone बॉडी पे ज्यादा aldosterone है तो क्या हो जाएगा? ज्यादा aldosterone है तो there will be high sodium levels in the body, that will lead to hypertension with the hypokalemic alkalosis. Okay, na? So now I am asking you, you tell me, what if what is the treatment for this condition? What is the treatment for the Conn syndrome? So the treatment for the Conn syndrome is a surgical resection, okay, but drug, medical management I am asking you. अरे बॉडी पे ज्यादा aldosterone है ना, so aldosterone antagonist दे दो. So that is spironolactone, aldosterone antagonist, that is spironolactone. Fine. Next, regarding Addison's disease, what you should know for your exam. Okay, regarding Addison's disease. Sir, Addison's disease में, wait. Listen carefully guys, here this is little important, a few more important MCQs were there. Look, sir, what is normal? Normal is your hypothalamus releases a hormone called as a CRH, corticotropin releasing hormone. The corticotropin releasing hormone comes and acts on corticotropes. So corticotropes produces ACTH, adrenocorticotrophic hormone. Now this adrenocorticotrophic hormone acts on the adrenal gland. It acts on the adrenal gland. So now the adrenal gland is going to produce. Now the adrenal gland produces cortisol, also aldosterone. Okay, adrenal gland is producing the cortisol, aldosterone. Okay, these mineralocorticoids as well as the glucocorticoids. Now question is, sir, when you have sufficient amount of this cortisol, cortisol kya karega? Cortisol gives the negative feedback. Cortisol gives the negative feedback to ACTH. Cortisol is down regulating the release of the ACTH to maintain the homeostasis. Today, what happened? Sir, today your adrenal gland destroyed, sir. Adrenal gland mar gaya because of TB or because of some autoimmune damage or because of some reason, your adrenal gland is getting damaged. So you tell me, whenever the adrenal gland is damaged, do you think the adrenal gland can produce aldosterone now? No, aldosterone is not there. Cortisol is there now? No, cortisol is not there. So you can call it as adrenal insufficiency. The adrenal gland is not producing the hormones. Aldosterone nahi hai, cortisol nahi hai body pe. So now tell me, sir, aldosterone nahi hai. So what will happen? Sir, aldosterone body पे नहीं है तो sodium levels गिरेगा sir. Sodium levels decrease हो जाएगा. Okay. Next, potassium levels बढ़ेगा. Acid levels भी बढ़ेगा body पे. So what is the name of this condition called as? See, there is a hyponatremia with hyperkalemia and acidosis. इस acid के वजह से acidosis आ जाएगा. Hyperkalemia आ जाएगा. And hyponatremia. So let me write here, hyponatremia, sodium levels are less, hyperkalemia and metabolic acidosis. Metabolic acidosis. Okay, fine. Now, okay, you tell me, cortisol is there? No, cortisol is not there. So negative feedback, will it work? So negative feedback is not going to work. Negative feedback not going to work. Whenever the negative feedback is not going to work, what will happen to the ACTH levels? Sir, ACTH levels badhega. There is going to be more ACTH. Now what this ACTH will do, sir? Now this extra ACTH, do you know what it will do? Now this ACTH will stimulate melanocytes. Now melanocytes, whenever they are stimulated, that is going to increase the melanin production in the body, that will lead to hyperpigmentation. So now tell me, what is the hormone responsible for the hyperpigmentation? So the hormone which is responsible for the hyperpigmentation in Addison's disease is ACTH. So ACTH is the hormone responsible for what? ACTH is the hormone responsible for the hyperpigmentation in Addison's. Addison's means adrenal insufficiency. Aldosterone nahi hai, cortisol nahi hai. So that will lead to hyponatremia with hyperkalemic acidosis. So at the end of the day, what was the FMGE question, sir? FMGE question, hyperpigmentation of the palms and soles is due to excessive ACTH. Next one, sir, aldosterone nahi hai to body pe acid levels badhega. That will lead to acidosis. So this is called as, right, aldosterone deficiency. Aldosterone deficiency will lead to acidosis. Okay, aldosterone deficiency will lead to acidosis. Which type of acidosis? Renal tubular acidosis type 4. Renal tubular acidosis type 4. RTA type 4. So tell me, RTA type 4, the renal tubular acidosis type 4 means unable to excrete the acid out of the body. Unable to excrete the acid out of the body. Why? Because aldosterone is not there. So RTA type 4 is due to deficiency of what? Aldosterone. Okay. So yes, with this successfully what we have completed? We have completed the Addison's disease and Conn's syndrome. Addison's is an example of aldosterone deficiency, but Conn's is an example of hyperaldosteronism. Okay. Now here itself, let me take some time and explain you the cortisol and Cushing here itself. Okay, cortisol and Cushing's here itself. So now tell me, what are the important things about the cortisol, but that you should know for your FMG exam. First of all, right, cortisol is an example of catabolic hormone. An example of catabolic hormone. Catabolic hormone means everything you already know. glycogenolysis, lipolysis, proteolysis, everything lysis only. Okay, it's a catabolic hormone released in diurnal fashion. Okay, reason diurnal variation, or it shows diurnal variations, or it is released in diurnal fashion. Sir, what is this diurnal fashion or diurnal variation? Let me tell you, sir, in a 24 hours, let's say this is the 24-hour time period. Okay, here is a 24-hour time period. So, diurnal variation means sometime in a day the cortisol levels are going to be very, very high, peak, and sometimes in a day the cortisol levels are going to be very, very less. So, in a day, in a 24 hours time period, sometimes the cortisol levels are going to be very high, and sometimes the cortisol levels are going to be very less. So, this variation, this pattern is called as what? Diurnal variation. So, which hormone shows diurnal variation? Cortisol. Every day early morning 8 a.m. Every day early morning 8 a.m. your cortisol levels are going to be very high, and every night during somewhere around 1 p.m. Okay, 1 p.m., 2 p.m. and during night, sir, your cortisol levels are going to be very, very less. So, sometimes the cortisol levels are going to be very high, and sometimes the cortisol levels are going to be very low. So, such variation is called as what? Diurnal variation shown by cortisol. Next, if there is excessive amount of cortisol excess causes Cushing syndrome. Cortisol excess cause what? Cushing syndrome. Cortisol excess causes what? Cushing syndrome. So, especially in your medicine, I want you to know, go through the dexamethasone challenge test, which is very important for your FMG exam. Anyway, Priyan sir is going to do the rapid revision. Okay, so the dexamethasone challenge test, okay, to find out whether it is Cushing syndrome or whether it is a Cushing disease or whether it is ectopic Cushing. So, that difference you have to know. Okay, so now in Cushing syndrome, what you should know? Okay, in Cushing syndrome, what you should know? You already know in a patient of Cushing's how the patient will appear. That the patient is going to have moon face. How about the abdomen? If you look at the abdomen is going to be like a lemon shaped. Okay, why? Because too much amount of cortisol excess in the body promote lipogenesis. Guys, cortisol excess, not normal. Normal cortisol causes lipolysis, but too much amount of cortisol actually promote lipogenesis. Because of too much amount of lipid accumulation, fat accumulation, she is going to have moon face, buffalo hump, and lemon shaped body. But if you look at her hands and legs are going to be very thin. Like a matchsticks. So this is called as lemon standing on matchstick appearance. Lemon shaped body. But if you look at the extremities, they are like sticks. So this is called as lemon on stick appearance. Is going to be seen with Cushing syndrome female. Now, sir, regarding this cortisol topic, what you should know, sir? Let me tell you. Guys, normally, this is normal. Cortisol decreases all your WBC. Cortisol, it's a anti-inflammatory immunosuppressant agent. It decreases all the WBC except neutrophils and monocytes. This is the one thing which I want you to know. Cortisol kya karega, sir? Cortisol decreases all the WBCs except neutrophils and monocytes. Then what about RBCs? Increases the RBCs, increases the platelets. Okay, this is a PYQ. It's already a PYQ. Cortisol increases all the blood cells except WBC. Okay, all the WBCs will go down except the neutrophils and monocytes. RBC level increases, WBC amount increases. Okay, next, what else is very important for your FMG exam? Let me tell you here. See, look at here. Here is the hypothalamus and pituitary gland. Hypothalamus and pituitary gland is there. Now, here is the adrenal gland. Here is the adrenal gland. Today, what happened? Sir, today the problem is in the pituitary gland. Here is a tumor. What this tumor is doing? Sir, this tumor is releasing excessive amount of ACTH. Stupid tumor. This is releasing excessive amount of what? ACTH. This excessive amount of ACTH is stimulating the adrenal gland. So, adrenal gland is producing too much amount of cortisol. So, whenever the too much amount of cortisol in the body is there, that is called as Cushing syndrome. Cushing syndrome, where the female is going to have lemon-shaped body. Okay, lemon-shaped body, buffalo hump, moon faces is going to be there with matchstick up, like lemon on matchstick appearance is going to be there. Okay, that's okay, fine. But tell me, for the Cushing syndrome, what is the cause? Sir, for this Cushing syndrome, the cause is here in the pituitary gland. So, this tumor producing excessive ACTH, this is the problem. This is the disease. This disease is going to cause the symptoms. That is called as the Cushing syndrome. Sorry. So, what is the name of this disease called as? This is called as Cushing disease. Cushing disease. Sorry. Cushing disease. So, Cushing disease is one of the cause of Cushing syndrome. Cushing disease is one of the cause of Cushing syndrome. Okay, you have already studied in your pathology. The most common cause of Cushing syndrome, is iatrogenic. Iatrogenic, that is the doctor prescribing the too much amount of steroid tablets. Okay, so the most common cause of Cushing syndrome is, right, level, right, different causes. One is iatrogenic Cushing's. One more cause is tumor secreting the ACTH secreting the tumor, that is small cell carcinoma of lung. So, lung cancer, certain lung cancers also produces the ACTH. So, there are different causes of ACTH. But tell me, what is the Cushing disease? Cushing disease is a condition where there is a tumor in the pituitary gland that is producing the ACTH, that is leading to Cushing syndrome. So, this is also very important. Cushing disease problem in the pituitary gland. Okay, done. So these are some important things that I want you to know. These are some important conditions that I want you to know in the endocrine physiology. Yeah, we took some time, but these are very important. We never know how many questions are going to come. Maybe in this upcoming FMGE exam, what if you get 5 questions from endocrine physiology, from Edison's, from Cushing's, from Korn syndrome? Okay, yeah, possibilities. And one more thing, last and final thing I'm explaining here. Students, imagine here, this is your adrenal gland. Okay, here is your adrenal gland. Sir, here is your adrenal medulla. Here is the adrenal medulla. Sir, today you are having a tumor here in the adrenal medulla. What is the name of this tumor called as? The name of this tumor is called as a pheochromocytoma. Pheochromocytoma. So, tell me, pheochromocytoma is a tumor of adrenal medulla or the adrenal cortex? So, the pheochromocytoma is the tumor of the adrenal medulla, or you can say it is a tumor arising from which cells? Tumor arising to chromaffin cells. Tumor to chromaffin cells. You already know from your classes, local classes, that adrenal medulla contains cells called as the chromaffin cells. Chromaffin cells are present in adrenal medulla. So, if you are having tumor to those chromaffin cells, that is called as a pheochromocytoma. But what is something important about the pheochromocytoma? So, these pheochromocytomas, these stupid tumors, they release epinephrine, or you can say adrenaline, noradrenaline episodically. Episodically means not continuously. They will release this epinephrine, norepinephrine episodically, means for every 1 day, for every 2 days, one times this tumor is releasing the adrenaline. So, whenever the adrenaline is getting released, that is going to cause the palpitations, that is going to increase the BP, that is going to cause the headaches, that is going to cause the nausea. So, all the symptoms are going to be episodic symptoms: episodic palpitation, episodic sweating, episodic hypertension, episodic tachycardia. So, whenever you see these words episodic, think about pheochromocytoma. So, pheochromocytoma, the keyword to identify the MCQ is episodic symptoms. Okay, so symptoms are going to be episodic symptoms. Now I am asking you, tell me, what is the investigation of choice for this pheochromocytoma? Tell me, what is the investigation of choice? Okay, screening investigation of choice. First of all, the screening investigation of choice, screening for pheochromocytoma, the screening investigation of choice. Screening IOC, screening investigation of choice for pheochromocytoma. Okay, metanephrine levels. Okay, metanephrine levels. Metanephrine levels. Okay, in urine metanephrine levels. Okay, screening investigation of choice. If they use the word screening investigation of choice, then the answer will be metanephrine levels or vinyl mandelic acid levels. Vinyl mandelic acid levels in the urine 24-hour urine. But if they simply ask you what is the investigation of choice, the investigation of choice is going to be fractionated metanephrine levels in the plasma metanephrine levels. Plasma metanephrine levels, the plasma metanephrine levels. The plasma metanephrine levels, fractionated plasma metanephrine levels are the investigation of choice. But if they ask the word screening test is going to be metanephrine levels in the urine. Okay, but see, the most important thing is episodic for your FMGE exam. Episodic symptoms. Symptoms are going to be episodic, and the tumors are arising from the adrenal medulla chromaffin cells. Okay, and in medicine you will study before the surgery. Okay, before operating the pheochromocytoma, you have to use alpha blocker as well as a beta blocker, that is a phenoxybenzamine, as well as the propranolol or esmolol before surgery. Before doing the surgery, 1 week before the surgery, you have to start the you have to start the phenoxybenzamine, that is the alpha blocker, and 3 days before the surgery, you will start to give the beta blockers also. Alpha blockers and beta blockers are administered pre-operatively. That you will study in your medicine. Okay, so with this successfully, what we have completed? We have completed the endocrine physiology. After endocrine physiology, in very short time we will be doing the GIT physiology. But now I am giving you the a break of exactly 10 minutes. 10 minutes. I hope 10 minutes break is enough. In this 10 minutes, it's up to you whether you want to revise the topics in the endocrine physiology or you want to have a tea break. It's up to you. After the break, we will do the GIT physiology. Okay, endocrine takes little time, but don't worry. The next things will go easily. Okay, chalo, take 10 minutes break. Okay, now let's continue, guys. Break is completed. Now let's do the JIT physiology. The JIT is going to be very small topic. Okay, you can expect like hardly 1-2 questions from this chapter. Okay, so in JIT physiology, what you should know, in our JIT there are 4 layers present: mucosa, submucosa, muscularis, serosa. Okay, see in our JIT, okay, there are 2 types of nerve plexus present. Okay, let me put it this way. Our JIT is made up of what? Our JIT is made up of 4 layers. 4 layers. That is the innermost mucosa. There is a submucosa surrounding it, and there is a muscularis layer, and last one is the serosa. There are 4 layers. No, there are 4 layers of the JIT. First MCQ is, sir, which layer is the strongest layer? Submucosa is the strongest layer. Okay, let me write it here. Sir, submucosa is the strongest layer. Okay, let me write it here. Strongest layer is the submucosa. Submucosa is the strongest layer. Then which layer is absent in the esophagus? Serosa. Serosa absent in. Serosa absent in esophagus. Serosa is absent in where? Esophagus. This is one thing. Then mesenteric plexus. Sir, in our JIT there are 2 types of plexus present. One is the mesenteric plexus, other is the myenteric plexus. What is the function of this mesenteric plexus neurons? The neurons which are present in the mesenteric plexus, they helps in GIT secretions के लिए. GIT secretions के लिए. Like the mucus secretion within the stomach, intestine, okay, something like that. So secretions के लिए which plexus? Mesenteric plexus. And what is the function of the myenteric plexus? Myenteric plexus, these neurons helps in the contraction of the muscles. So myenteric plexus helps in GIT contractions के लिए. So one helps in the secretions, other helps in the contractions. Now my question to you, sir, how this 100 million neurons, that is the mesenteric plexus along with the myenteric plexus, both mesenteric as well as the myenteric plexus combined together, 100 million neurons are there in our JIT. Sir, how this 100 million neurons came into our JIT? How they came into our JIT, sir? So let me write that here. Okay, let me write that here. Okay, let me add a new page and let me write. Okay, I'm taking a new page. Both mesenteric plexus and myenteric plexus, both mesenteric plexus and myenteric plexus developed due to, and developed from which cells? So both the mesenteric plexus and myenteric plexus, they develop due to neural crest cell migration. Okay, neural crest cell migration. So the neural crest cells, they will migrate to different organs and they will become different parts. For example, the neural crest cells, they will migrate into the adrenal gland and they will form the adrenal medulla. Okay, and the same neural crest cells, they will come into the GIT. They will come into the GIT and they will become the mesenteric plexus and the myenteric plexus. So this mesenteric plexus and myenteric plexus, they are developed from which cells? The neural crest cells. Okay, they are developed from the neural crest cells. Now, if this process is defective, that is a defect in neural crest cell migration. Neural crest cell migration. So tell me, that is going to cause a disease. Now tell me, what is the disease? The neural crest cells are not migrating to the GIT normally. The neural crest cells which were supposed to come to the GIT, now they are not coming. So defect in neural crest cell migration will lead to which disease? Hirschsprung disease. Hirschsprung disease. So not only in Hirschsprung disease, what is the problem? The problem is with the neural crest cell migration. So in Hirschsprung disease, imagine I am the baby with the Hirschsprung disease. In Hirschsprung disease, in baby's GIT, there is no mesenteric plexus, there is no myenteric plexus. The mesenteric plexus and the myenteric plexus are not developed. So tell me, do you think the GIT of the baby will contract? No. So there is difficulty in passing the feces. So that's why in Hirschsprung disease, the babies who are suffering with the Hirschsprung disease, there is failure to pass meconium. There is failure to pass the meconium. Means actually meconium is the first feces that should be passed after the birth. Okay, immediately after the birth, the baby will pass the first feces, that is called the meconium. But here in this case, maybe the meconium is going to be passed after 1 day or 2 days, that too while during the examination, while doing the parectal examination, there is going to be passing the feces, not automatically, because the myenteric plexus not developed, mesoid plexus not developed. Without that, the GIT is not going to contract. Without contraction, the baby cannot able to pass the feces. Okay, failure to pass the meconium. Okay, so these are some things which you have already studied in your medicine, that this Hirschsprung disease is associated with the Downs babies due to RET oncogene mutation. Okay, there is going to be a ganglionic segment, that is the distal colon is going to be the most common site for the ganglionic segment. You have already studied. So in physiology, mesoid plexus, myenteric plexus developed due to neural crystal migration. If there is a defect in this process, that will lead to Hirschsprung disease. Hirschsprung disease is associated with which disease? Down syndrome. Hirschsprung disease is associated with Down syndrome. Okay, that is the trisomy 21. Okay, who will develop this Hirschsprung disease? It is associated with Down syndrome. What are the clinical features? Failure to pass meconium. Which gene mutation is going to cause this Hirschsprung disease? Which gene mutation? RET oncogene mutation. RET gene mutations. RET gene mutation. Very, very important. RET gene mutations. Okay. Chalo. Next. After this, what else you should know? What else you should know? Sir, in our GIT, especially in stomach, this is all about the stomach. Now I am going to talk about the stomach. Sir, in your stomach, there are gastric glands present. Stomach mein kya hai, sir? Gastric glands. So these gastric glands, they contains different types of cells. In a gastric gland, in one gland, there are different types of cells. Different types of cells produce different types of secretions. No? So now tell me, sir, this mucus and egg cells, what do they produce? Sir, in our stomach, this mucus and egg cells, one more cell is there, I am writing here, it's missing here, foveolar cell. Foveolar / surface mucus cell. So now tell me, the foveolar cells and the mucus and egg cells, what do they produce? Sir, they are going to produce mucus in our stomach. So tell me, who produces the mucus in the stomach? Goblet cells? No, goblet cells are never ever seen. Goblet cells are never ever seen in our stomach. Goblet cells are never ever going to be seen in the stomach. So who produces the mucus in the stomach? The mucus and egg cells and the foveolar cells. Then parietal cells produce what? So the parietal cells in our stomach produces acid and intrinsic factor. Intrinsic factor helps in the absorption of vitamin B12. Next, enterochromaffin-like cells. So these enterochromaffin-like cells are going to produce histamine. Okay, from the stomach. Yes, histamine is produced in our stomach. Next, chief cells. What do these chief cells produce, sir? Chief cells produce pepsinogen and gastric lipase. Okay, gastric lipase. Then D cells. So D cells produce somatostatin. And G cells produce, the G cells in our stomach produce hormone called as gastrin. G cells produce what? Gastrin. Now you are having a question. Sir, what is the function of this histamine? Histamine का काम क्या है sir? हमारे body में, stomach में especially. And gastrin का काम क्या है sir? What is the function of this gastrin and histamine? Sir, gastrin and histamine, see these two. Gastrin and histamine, they will go and stimulate the parietal cell. To release acid. Acid release में मदद करेगा sir. So histamine increase the acid release and gastrin also increase the acid release. Okay, so these are the different types of cells produce different types of secretions. So tell me, pepsinogen, chief cell, gastric lipase, chief cell, somatostatin, D cell, gastrin, G cell, parietal cells, acid and intrinsic factor, mucus and egg cell produces the mucus. And one important thing about the B12 को absorb करने के लिए, sir, B12 को absorb करने के लिए what is required? Intrinsic factor. So B12 is absorbed only in the presence of intrinsic factor. In which area? In terminal ileum. Okay, B12 is absorbed where? In terminal ileum only along with intrinsic factor. Okay, chalo next. Sir, what are the stimulus for acid release? Wait, here is a parietal cell. In the stomach. It is having proton pump. So this pump is called as what? Proton pump. With the help of proton pump, he is releasing acid. He is producing the acid. But इस acid को release करने के लिए, in order to produce this acid, It requires 3 stimulus. What are the 3 stimulus for the release of acid? One you already know, that is gastrin from G cell. Second one also you know, that is histamine, that is from enterochromaffin like cell. Okay, last one is acetylcholine from the vagus nerve, the parasympathetic cranial of the vagus nerve. Vagus nerve releases acetylcholine that will also stimulate the parietal cells to release acid. So acid को release करने के लिए how many stimulus are there? 3 stimulus. One is gastrin, histamine, acetylcholine. Okay, gastrin, histamine, acetylcholine. These are the 3 stimulus for the release of acid. Okay, for the release of acid. Now, if you want to know the name of the receptor, the name of the receptors here, histamine acts on H2 receptor, acetylcholine acts on M3 receptor, gastrin acts on cholecystokinin B receptor. Cholecystokinin B receptor. So repeat again, histamine is acting on H2 receptors, acetylcholine is acting on M3, not M1. Some of the students will think M1. No, it's not M1, it is M3 receptors. Okay, so acetylcholine act on M3 receptor, gastrin acts on CCKB, cholecystokinin B receptors. So there are 3 stimulus for the release of acid. Acid को release करने के लिए 3 stimulus are there. Okay, 3 stimulus are there. Next, fine sir. After this, what else you should know? What else you should know? Sir, now write important substances and sites of absorption. The sites of absorption. Important substances and the sites of absorption. Now tell me iron. Okay, iron in which form? Only in Fe2 plus form, that is called as a ferrous. Where will absorb the iron? Sir, iron only in Fe2 plus form, that is a ferrous form, we will absorb in duodenum. We will absorb where? We will absorb it in duodenum, sir. Okay, we will absorb it in duodenum. Next, vitamin B9, that is a folic acid. Vitamin B9 is mainly absorbed in jejunum. Okay, in other parts also, but mainly jejunum. And vitamin B12, that is a cyanocobalamin. Okay, vitamin B12, that is a cyanocobalamin. Where is it absorbed? Vitamin B12, it is absorbed in terminal ileum. Okay, terminal ileum. So how you can expect an MCQ is that complete ileal resection. Okay, complete ileal resection. So now tell me, whenever the ileum is removed, okay, whenever the ileum is removed, will you be able to absorb vitamin B12? No, complete ileal resection is going to cause vitamin B12 deficiency. Vitamin B12 deficiency is going to cause what? Megaloblastic anemia. Okay, megaloblastic anemia. That's the number one thing. But only megaloblastic anemia? No. Vitamin B12, whenever it is deficient, your methyl malanoic acid levels, methyl malanoic acid levels are MMA. Methyl malanoic acid levels are going to be elevated. Tell me how to know whether the person is having vitamin B12 deficiency, yes or no. The patient is going to have the megaloblastic anemia with the hypersegmented neutrophils. In pathology you have studied megaloblastic anemia is due to vitamin B9 as well as B12 deficiency. If it is due to B12 deficiency, megaloblastic anemia, along with the methyl malanoic acid levels in the blood is going to be elevated. Along with that, there will be CNS manifestations. Okay, there's going to be involvement of the the dorsal column tracts. Okay, there's going to be damage to the dorsal column tracts. So these patients are going to have the neurological symptoms. Neurological symptoms are going to be present. So that is all. Okay, due to vitamin B12 deficiency. So tell me, when a patient can get vitamin B12 deficient, the patient can get vitamin B12 deficiency if you remove the complete ileum. Means because of some Crohn's disease or because of some reason, because of some cancer, you have removed the ileum. When you remove the ileum, no vitamin B12. Without vitamin B12, megaloblastic anemia. So similar condition, one more thing I will tell you. So that is called as pernicious anemia. Pernicious anemia. Sir, what is pernicious anemia? It's autoimmune disease. Autoimmune disease. Okay, autoimmune disease. So what is happening here? So autoimmune disease are destruction of autoimmune destruction means your own antibodies are destroying destruction of parietal cells. Autoimmune destruction of the parietal cells. So today the parietal cells in your body are dead. There is no more parietal cell. The parietal cells in your stomach, the parietal cells मर गया. So now tell me, there is no acid. Acid नहीं है body में. And there is no intrinsic factor. Intrinsic factor भी नहीं है. So now you tell me, without intrinsic factor, whenever the intrinsic factor is not going to be there, so what will happen to the vitamin B12 absorption? The vitamin B12 absorption is going to decrease. So that is going to cause megaloblastic anemia, numbness, neurological symptoms, and serum methylmalonic acid levels are going to be elevated again. So remember this. Okay. So there is a condition called as pernicious anemia. Pernicious anemia, where there is a destruction of the parietal cells, which will lead to severe B12 deficiency, that is going to cause anemia, megaloblastic anemia with neurological symptoms, and methylmalonic acid levels and the homocysteine levels in the body will be elevated. You have studied this in your biochemistry as well as medicine also. Okay. Now I am asking you from your medicine, tell me, pernicious anemia, it's an autoimmune disease, no? So there will be presence of which antibodies? Anti-intrinsic factor antibodies are positive in the blood. Anti-parietal cell antibodies. Anti-parietal cell antibodies are positive in the blood. So anti-intrinsic factor antibodies, anti-parietal cell antibodies are going to be seen in which disease? Pernicious anemia. Which cells are going to be targeted? Parietal cells are going to be targeted. Parietal cells produce what? Acid and intrinsic factor. Intrinsic factor helps in absorption of vitamin B12. You will get only vitamin B12 from the animal foods, animal sources like milk, tea, ghee, curd or meat. Okay. So you will only get the vitamin B12 only from animal sources. Okay, only from the animal sources, not from the plant sources. Okay. Chalo. So with this successfully what we have completed? With this successfully we have completed the important points about the pernicious anemia. Chalo, let's continue. Let's continue with the iron absorption. See what you should know regarding the iron absorption, guys. Very, very important area in exam, iron absorption. Wait, students, how many forms of iron are there? Sir, there are two forms of iron. That is Fe2 plus, Fe3 plus. Fe2 plus form of iron, you will get it from animal sources. Okay, animal sources. Fe2 plus form of iron, you will get the Fe2 plus form of iron from the animal sources, animal products. Fe3 plus form of iron, that is a ferric iron. Ferric iron we will get it from the plant sources. We will get it from the plants. Fe2 plus form of iron is absorbed, but Fe3 plus form of iron is not absorbed. Okay, one is absorbed, another is not absorbed. So now tell me, is it the vegetarians going to have the problem or the non-vegetarians going to have the problem? Actually, no one will have the problem because see, even though today you are eating some plant diet, okay, you are eating some palak or something, spinach, something, okay, you are eating some plants, okay. So what form of iron you will get? Fe3 plus form of iron you will get. In your duodenum, so this is all happening in your duodenum, okay, take the duodenum. In your duodenum, the Fe3 plus form of iron automatically converted into Fe2 plus form. Fe3 plus form is converted into Fe2 plus form with the help of this molecule called as duodenal cytochrome B. Duodenal cytochrome B. So this duodenal cytochrome B, this is an enzyme actually, it's an enzyme. It converts Fe3 plus form of iron into the Fe2 plus form So Fe3 plus ferric is converted into ferrous. This duodenal cytochrome B is also called as ferrireductase. Okay, so it is also called as what? Ferrireductase. Now, this Fe2 plus form of iron, you have to absorb. Now you have to absorb it. इसको absorb करने के लिए, sir, in order to absorb this Fe2 plus form of iron, there is a transporter present. What is the name of this transporter? DMT1. Okay, so DMT1 is present in the duodenum. Divalent metal transporter 1 helps in the absorption of iron, Fe2 plus form of iron. Okay, now from here, where is the iron going? Sir, now this iron is coming out of the cell. Look, it is going into the blood. Now it is going to the blood with the help of a different transporter called as ferroportin 1. Okay, so DMT1 absorption ke liye. Now to send into the blood, which transporter? Ferroportin. See, now again, before going to the blood, the Fe2 plus form of iron, is converted back to Fe3 plus form. Now it is again converted back to Fe3 plus form because Fe3 plus form of iron is the most stable form of iron. So सिर्फ absorption के लिए Fe2 plus is required. But once it is absorbed, it is going back to Fe3 plus form. So yes, Fe2 plus form is converted back to Fe3 plus form with the help of this molecule called as F-astin. Hephaestin. So Hephaestin converts Fe3 plus form, Fe2 plus form of iron to Fe3 plus form. Fine. Now you tell me, where is the iron now? Now this iron is in the blood along with a protein called as transferrin, plasma protein called as transferrin. Now this transferrin transfers the iron to liver. So in the liver it is stored. In which form? Fe3 plus form. So this is called as, the stored iron is called as ferritin. The stored iron is called as what? Ferritin. Okay. So now I am asking you, tell me. Sir, when you have sufficient amount of iron, happy or not? Sir, in your liver, iron is stored and you are happy with that. Yes, you are having enough amount of iron, you are happy. So, when you are having sufficient amount of iron in your liver, is there any need for us to absorb iron again? Already sufficient amount of iron is there, sufficient stores are there. So now I am asking you, should you have to absorb iron now? No, we don't want the iron now. So now when you have sufficient amount of iron in the liver is going to produce something called as hepcidin. This hepcidin क्या करेगा sir? This hepcidin inhibits this transporter. Hepcidin inhibits the ferroportin. So iron absorption stops. Iron absorption to the blood stops. Okay. Now, so tell me, how iron is absorbed? Only Fe2 plus form of iron is absorbed with the help of DMT1. Where is located? Duodenum पे. Iron is stored where? Liver में. In which form? Fe3 plus. That is called as ferritin. In the blood, iron is with transferrin. Transferrin transport the iron to liver. Once you have sufficient amount of iron in the liver produces hepcidin. Hepcidin inhibits ferroportin. Okay na? So now, questions to you. See, have you ever heard about an iron overloaded state called as? Have you ever heard about a condition where there is iron overload? Iron overload. What is the name of that condition? Iron overloaded state means the too much amount of iron deposition in the body. That is called as a hemochromatosis. There is too much amount of iron depositing in your liver, in your heart, in your skin, that will lead to bronze, diabetes and all. Okay, so that is called as hemochromatosis. Now, this is not the MCQ which will come in your exam. This is due to which gene mutation? Sir, iron overloaded state, that is called as a hemochromatosis. I think it's a autosomal recessive disorder. You check it from patho. Sir, iron overloaded state, hemochromatosis, it is due to which gene mutation? This is what I want you to answer. Come on, tell me. It is due to which gene mutation? Excellent, Reshma. HFE gene mutation. H for high, Fe stands for iron in the body. HFE gene mutation. Okay, HFE gene mutation. The HFE gene mutation, very, very important for your exam. HFE gene mutation will lead to iron overloaded state. So now you tell me, if there is too much amount of iron in the body, so you have to use some chelating agents. What is the iron chelator? What is the drug of choice for hemochromatosis? Drug of choice for hemochromatosis, too much amount of iron. You have to remove the iron out of the body. So you have to use some chelating agent. What is that chelating agent? Excellent, ASIC. Excellent, that is a deferoxamine. Okay, the drug of choice in this condition, the drug of choice for hemochromatosis is deferoxamine. Okay? Deferoxamine. Okay, deferoxamine. Amit, yes, deferoxamine, remember. Can you tell me what is a copper chelating agent? Sir, there is a condition called as a Wilson disease where there is too much amount of copper in the body with the Kaiser-Fleischer rings and all, with the panda sign on the MRI, okay, in the midbrain. That is the Wilson disease. What is a copper chelating agent? Penicillamine. Okay, D-penicillamine. Excellent, Mickey. So that is the penicillamine, is the D-penicillamine is a copper chelating agent. Deferoxamine is the iron chelating agent. So now, sir, what else you should know from this page? What else you should know? Write one by one MCQs here. MCQs. Number one MCQ is, sir, substances decreasing the iron absorption. Substances, number one, substances decreasing iron absorption and substances increasing iron absorption. Who increase the iron absorption? Who decrease the iron absorption? Tell me. Substances decreasing the iron absorption, substances increasing the iron absorption. So I will tell you the increasing iron absorption first. That is acid in the stomach and vitamin C. So the acid and vitamin C, what they will do? They will convert the Fe3 plus form of iron, Fe3 plus form of iron into Fe2 plus form. They will convert the Fe3 plus into Fe2 plus form. So it helps in iron absorption. They help in iron absorption. But tell me, who decreases the iron absorption? Bad substances. Bad. For the iron. For the iron. So what is that? Remember, milk, tea, antacids. You know, antacid tablets like omeprazole, pantoprazole. Acid is good. Acid is good. Antacid is bad for iron. So milk, tea, antacids, chemicals like phytates, okay, tannates. These are all chemicals. Okay, milk, tea, antacids, phytates, tannates, calcium tablets. Okay, calcium tablets. Okay, so calcium, it interfere with iron absorption. Calcium is a rowdy, sir. Calcium is like a rowdy. So what calcium will do? Sir, whenever you take calcium tablet along with iron tablet, see, calcium will compete for the absorption of, like calcium will compete with iron for its absorption. So see, it is Fe2 plus, this is Ca2 plus, both are divalent ions. So divalent metal transport, it's the same transporter, iron absorption ke liye, calcium absorption ke liye. So whenever you are taking iron along with calcium, calcium will say, I will go first. So iron is not absorbed. So remember, the substances who increase the iron absorption, substances who decrease the iron absorption. Milk bad, tea bad, antacids bad, phytates, tannates and calcium tablets, they are all bad. They are all bad things. Okay? Chalo. Next. Sir, what else you should know in the GAT physiology which are very important? See, take 5-star marks to this area because this area is one of the most important areas in the GAT physiology. Okay, the most important area in the GAT physiology. What is this, sir? Tell me, do we absorb glucose, yes or no? Yes, we do absorb the glucose, sir. Where? Duodenum में. So glucose को absorb करने के लिए, see, so glucose को absorb करने के लिए, there is a transporter. Okay, but the glucose is absorbed along with sodium. Okay, so glucose को absorb करने के लिए, which ions are required? Sodium ions are required. So it is, the name of the transporter is sodium. The name of the transporter is sodium glucose linked transporter. Sodium glucose linked transporter. So now I am giving you the golden rule. When two substances are getting absorbed together, when two substances are moving together, so always remember, it's an example of secondary active transport. Blindly trust me, wherever you see co-transporter or symporters, that is SGLTs, co-transporters, symporters, if two substances are moving, all of two substances, 2 means what? Secondary. 2 means secondary active transport. Okay, all gluts are examples of facilitated diffusion, but all co-transporters and symporters are examples of secondary active transport. So tell me, glucose को absorb करने के लिए, duodenum में glucose को absorb करने के लिए, which transporter is helping? SGLT1. Okay, glucose came into the cell. So now from here, where is the glucose going? Now from here, the glucose is going into the blood with the help of a different transporter. What is the name of the transporter? GLUT2. Wherever you see the word gluts are examples of facilitated diffusion. Glucose को absorb करने के लिए SGLT1, into the blood GLUT2. Okay, into the cell SGLT1, into the blood GLUT2. One is secondary active transport, other is facilitated diffusion of glucose. Okay, next, in the same way, fructose start with what? Fructose start with F for everything, F only. That is, fructose is, sorry, there is a small typing mistake here. It is GLUT5. Sorry, it's not SGLT1, it's a GLUT5. Okay, it's a typing mistake. So right, so fructose start with the letter F. F for 5. So you tell me, wherever you see the glut 1, 2, 3, 4, 5, 7, doesn't matter. All are examples of facilitated diffusion. And here fructose from the cell is going into the blood with the help of GLUT2. Again, it is also facilitated diffusion. So tell me, everything regarding fructose, F for facilitated diffusion. GLUT5 is a fructose transporter, not the glucose transporter. GLUT5 is fructose transporter. Okay. So finally, make me happy one thing. Glucose को absorb करने के लिए which ions are required? Sodium ions are required. What is the name of the transporter in the intestine? SGLT1. It's an example of what type of transport? Secondary active transport. Now FMGE question. What is FMGE question? Why glucose is added into glucose? Why glucose is added into? Why glucose is added to ORS packets? Why the glucose is added to ORS packets? First of all, tell me, to which people will give the ORS? ORS means oral dehydration salts. We are using in the treatment of dehydration. Okay, we will use it in the treatment of the dehydration. For the dehydrated fellows, you will give the ORS packets. But my question to you, sir, then why there is glucose in that packet? Okay, because tell me, glucose को absorb करने के लिए, see if I take ORS, see I am drinking ORS. ORS में क्या है sir? Glucose. Glucose को absorb करने के लिए which ions are must? Sodium ions are must. So sodium will go into the cell. Sodium will go into the cell. Wherever sodium goes, water will follow. So body will absorb the fluids. Body will better absorb the fluids. So why glucose is added to the ORS packets? Because the glucose enhances the sodium absorption, salts absorption in the body, as well as water absorption in the body. So right, glucose facilitate sodium and water absorption. Okay, so increases the absorption of this glucose, increases the absorption of sodium as well as water. Okay, done. Next, from the same slide, recently in one of the I think NEET PG exam, this question was there. Sir, who is stored in the liver? Yeah, iron is stored in the liver, sir. But not only iron, vitamin A in your liver. This is a recent question, sir. Vitamin A is also stored in liver in a special cell called as Ito cells of the liver. You know, you have studied in your surgery and medicine also, in your liver there are Ito cells, also called as stellate cells, which will store the iron. These stellate cells are the one which is responsible for the cirrhosis of the liver. They will cause the fibrosis of the liver. Okay, this question was asked. Iron is stored in, sorry, not iron, vitamin A is stored in liver. Which cells of the liver? Ito cells. Okay, Ito cells. Ito cells are stellate cells. Done? Next. What else you should know? Guys, take the heading duodenum. So what is happening in the duodenum? This is also important. You should know this from your GIT physiology. Okay, at the end of the day, sir, it doesn't matter physiology, medicine, surgery, it doesn't matter. We have to get that 150. Okay, so to get that 150, you have to know certain concepts, important concepts. Okay, chalo, let me explain you in this page. You don't need to write. Just listen carefully. Here is your esophagus. Down to the esophagus, what do we have? Stomach. And what is this one? Duodenum. Okay, na? Next. Here is your pancreas. Here is your lovely pancreas. Okay, let me show the pancreas in the blue color. Okay, here is your pancreas. Anatomy, important point. The tail of the pancreas, they will ask you always they will ask you, the tail of the pancreas is present in which ligament? Tail of the pancreas is present in lienorenal ligament, also called as splenorenal ligament. Anatomy important, MCQ. The tail of the pancreas is in the which ligament? Okay, no, lienorenal ligament or the splenorenal ligament. Because here, you know, here there will be spleen. Okay. Chalo, anyway, let me come back to my physiology. Let me draw two diagrams. Let me explain you. Today, sir, what are you eating? You are going to eat some nice biryani, let's say. You are going to have some nice biryani or some nice food today, delicacy today. So whenever you are going to eat food, acid is produced in the stomach. Yes or no? Acid is going to produce in the stomach. Sir, now this acid, where it will go? Sir, now this acid, it will come into the duodenum. Here is the pyloric sphincter. Now acid is coming into duodenum. Now tell me, acid in the stomach, okay, no problem, because in the stomach there is proper amount of mucus production is there, too much amount of mucus is there, so no problem. Acid in the stomach, okay. But tell me, do you want the acid in the duodenum? No, we don't want the acid in the duodenum. इस acid को क्या करना sir? We have to neutralize it. What we have to do is acid को neutralize करना जरूरी है sir. You have to neutralize this acid. So now how we will neutralize it? Listen carefully. Sir, this acid, it will stimulate a cell called as S cell. Acid stimulate which cell? S cell. S cell releases a hormone called as secretin. S cell releases what? Secretin. Do you know what the secretin will do? Secretin, it will come and decrease the acid production in the stomach. First of all, it will stop the acid production in the stomach, and the same secretin, it will also stimulate the pancreas. It will stimulate the pancreas to release bicarbonate rich pancreatic juices. So now tell me what these bicarbonates are going to do. So now these bicarbonates which are coming from the pancreas, the bicarbonates will go and neutralize the acid. Acid को क्या करेगा sir? न्यूट्रलाइज करेगा सर, न्यूट्रलाइज करेगा. एसिड न्यूट्रलाइजेशन के लिए विच हार्मोन इज हेल्पिंग? सेक्रेटिन. एसिड को न्यूट्रलाइज करने के लिए विच हार्मोन इज हेल्पिंग? सेक्रेटिन. सो दैट्स व्हाई सेक्रेटिन इज कॉल्ड एज, इन फिजियोलॉजी सेक्रेटिन इज कॉल्ड एज नेचर्स एंटासिड. ओके, सेक्रेटिन इज द नेचर्स एंटासिड. ओके, सेक्रेटिन इज द नेचर्स antacid hormone. Nature's antacid hormone. Okay, na? So now tell me, what is the stimulus for the release of secretin? Acid. Entry into duodenum. Secretin is coming from which cell? S cells of the duodenum. What secretin will do? Secretin decreases the acid production in the stomach, and secretin increases the bicarbonate production from the pancreatic juices. Secretin increases the bicarbonate levels in the pancreatic juices, so bicarbonate will come and neutralize the acid. Done. 50% of the topic completed. Next. So today you are eating fats. Which food you are eating? Today you are going out and you are eating a fat. Let's say fat rich food, means full of a pizza full of cheese. Okay, so you are going to eat a fat rich food today. Now where do you think these fats are going to go? So now these fats, Ravi, should I have to wait? Okay, chalo. Now where do you think these fats are going to go? Now these fats will enter into duodenum. Okay, they will enter into duodenum. Okay, now you already know, sir, fats को digest करने के लिए क्या चाहिए sir? Bile चाहिए sir. So now what these fats are going to do? So the fats are going to stimulate the eye cells of the duodenum. Now these eye cells will release a hormone called as a cholecystokinin. Now do you know what this cholecystokinin will do? So the cholecystokinin is going to cause the contraction of gallbladder. Okay, let me draw the gallbladder here. It's missing. Okay, just for easy understanding purpose, I am showing the gallbladder which contains bile. So this cholecystokinin, it will come and cause the contraction of gallbladder. So now you tell me, whenever the gallbladder is getting contracted, the contraction of the gallbladder will release the bile. Bile helps in the digestion of the fats. I should say the better word is emulsification of the fats. Fats emulsify ho gaya. But completely not digested, just emulsified. Let's say just smoothened. The same cholecystokinin now, it will go and act on the pancreas. It will stimulate the pancreas to release enzyme-rich pancreatic juices. Pancreas will release lipase. You already know pancreatic colipase, pancreatic lipases. Now what these lipases will do? The lipases will come and digest the fats. First emulsify ho gaya. Bile ke wajah se emulsify ho gaya. After the emulsification, there is going to be digestion of the fats. So tell me, cholecystokinin is coming from which cells? Eye cells of the duodenum. What is the stimulus for the release of cholecystokinin? Fat-rich food. What is the function of cholecystokinin? Cause the contraction of the gallbladder, helps in release of the bile. What is the function of the bile? Emulsification of the fats. When cholecystokinin acts on pancreas, pancreas releases bicarbonates. No, pancreas is not going to release the bicarbonates. Pancreas is going to release the enzyme-rich pancreatic juices for the digestion of fats. Okay, chalo, done. Topic completed. Let me highlight the points. Okay, duodenum. Sir, in your duodenum, how many types of cells are there? S cell is there, I cell is there. First, let's start. Acidic chyme. Acid is the stimulus for S cell. S cell will release secretin. Secretin acts on pancreas. Pancreas क्या करेगा sir? Pancreas releases bicarbonate rich pancreatic juices. किसके लिए? Acid को neutralize करने के लिए. Next, what the eye cell is doing? Sir, the eye cell will release cholecystokinin pancreozymin. Full name, cholecystokinin pancreozymin. So this cholecystokinin acts on the gallbladder. cause the contraction of the gallbladder, helps in release of bile. Bile को release करेगा. The same cholecystokin pancreozymin also act on the pancreas. Now see, now the pancreas is going to release enzyme-rich pancreatic juices. Done. With this, the two important hormones from your duodenum, that is the secretin and the cholecystokinin topics completed. What is the function of secretin in your body? Acid neutralization. Cholecystokinin, gallbladder contraction, release of the bile, emulsification of the fats. Khatam. Done, sir. Okay. Next, what else you should know in the GIT physiology for your FMGE exam? Let me tell you. One more small topic is there. See, guys, listen carefully. What is this one? Esophagus, stomach and duodenum. Now I am asking you, today you are eating carbs. You are eating carbohydrate rich food. Tell me, when you are eating carbohydrate rich food, the carbohydrates eventually will go into the duodenum. Definitely they have to go into the duodenum. In how many hours? In 2 to 3 or maybe maximum 3 to 4 hours. In 3 to 4 hours, there is going to be gastric emptying. What is this process called? The movement of food from the stomach into duodenum. The movement of food from the stomach into the duodenum. This process को क्या बोलते हैं? Gastric emptying. So, gastric emptying. What is the gastric emptying time of the carbohydrates? 3 to 4 hours. Okay. Then what about the proteins? Today you are eating proteins. So if you take proteins, in how many hours the proteins will go into the duodenum? Immediately, do you think the proteins will go into the duodenum? No. Proteins will take 6 to 7 hours. So after 6 to 7 hours, they will go into the duodenum. Then what about the fats? Today you are eating fats. Okay. Whenever you are eating fats, sir, the fats will take even more time. That is, let's say 9 to 12 hours. Okay, 9 to 11, 12 hours. For the fats to move from the stomach into the duodenum. So tell me, which foods has fast gastric emptying? Carbohydrates. They will give you instant energy. So carbohydrates followed by proteins followed by fats. So tell me, what is the order of gastric emptying? Carbs followed by proteins followed by fats. So which foods has fast gastric emptying? Carbohydrates followed by proteins followed by fats. Okay, followed by fats. Next, sir, from the same topic, just take the heading gastric emptying. Sir, who promotes the gastric emptying and who inhibits the gastric emptying? Gastric emptying is promoted by, means who increases the gastric emptying, means movement of food from the stomach into duodenum. Promotes, and who inhibits it? Who promotes the gastric emptying? Okay, let me use the word promote. Who promote gastric emptying? Who inhibit gastric emptying? Which hormones promote and which hormones inhibit? Promoted by only one hormone, that is gastrin. Gastrin promotes the gastric emptying, movement from stomach into duodenum. Then who inhibits it? Secretin stops the gastric emptying. Cholecystokinin stops the gastric emptying, and especially lipids. Okay, lipids stop the gastric emptying. I have taught you just now lipids. When you take the lipids, gastric emptying is going to be very long time. It will take almost 9 to 12 hours for the gastric emptying to happen. Okay, food will stay in your stomach for a long time. So this is the topic where we are discussing who promotes the hormones which promote the gastric emptying and the hormones which inhibits the gastric emptying, and foods which have the fast gastric emptying and the foods which have the slow gastric emptying. That's the carbohydrates, proteins, fats. That's the order. Okay, chalo, done. The last thing in the JD physiology, image based questions which you have to know. Image based questions, that's the peristalsis. Okay, only one image. Segmentation, even the segmentation is not needed for you. Only peristalsis image based question is required. Sir, what is peristalsis? Today you are eating food. Okay, na? Today what are you eating? Food. Tell me, do you want the food to go away from the mouth or the food to come back to the mouth? No, always the food should be moving ab-oral, means away from the mouth. The food should be always ab-oral. So tell me, to prevent the regurgitation, the proximal segment is contracting. Okay, and the distal segment will undergo relaxation. Proximal segment contract हो गया और distal segment relax हो गया, sir. So now right here, relax. The proximal segment contraction. So the food is moving forward. The food is always moving in the forward direction. So peristalsis किसके लिए sir? Peristalsis forward movement के लिए, food को move करने के लिए, digestion के लिए नहीं, food को move करने के लिए, push करने के लिए. So next I am asking you, tell me, when this area is getting contracted, who will contract it? Some chemicals, some neurotransmitters. Who? Right, acetylcholine, acetylcholine, acetylcholine and substance P. So these two. The contraction of the proximal segment, the contractions in the peristalsis, the contractions are due to acetylcholine and substance P. Then what about this anterograde relaxation, this anterograde relaxation, this relaxation, that is due to nitric oxide. Excellent, excellent Reshma. Nitric oxide. Okay, let me write the full form. Nitric oxide and one more thing, VIP. You know VIP? Vasoactive intestinal peptide. VIP, vasoactive intestinal peptide. Okay, vasoactive intestinal peptide. Okay, vasoactive intestinal peptide. So, image based question. The proximal segment contraction, distal segment relaxation. Food is moving forward. So, this is one of the important image based question which I want you to know in the GIT physiology. So, these are very, very important things that I want you to know in the GIT physiology, especially this iron absorption and why glucose is added to ORS. SGLT1 in the duodenum. Glucose is always absorbed along with sodium. Okay, these are some basic things that I want you to know. Okay, now? Okay, after this, let's begin with the cardiac physiology. Guys, is everything okay? Is everything going good? Now, let me check the chat. Is everything okay, or should I go a little slow, or should I change anything? Please let me know in the chat box. Come on, now it's the time for the interaction. Okay, after two systems we are interacting now. Okay, so all well. Okay, let me ask some questions from the GIT physiology. Okay, now tell me, first, in which part of the GIT maximum water is reabsorbed? Come on, answer this. In which part of the GIT maximum water is reabsorbed? Some single liner questions I am asking you. Okay, these are important. Maximum water is reabsorbed in. Important MCQs. Single error questions. Maximum water reabsorbed in. Someone is only one student is correct. Vedant is correct. Others are saying small intestine, but which part of the small intestine? Is it duodenum, jejunum, or ileum? It is a jejunum. It's a jejunum. This is the PYQ. Maximum water is reabsorbed in jejunum. Next, bile acids are reabsorbed in. Bile acids. You know, bile contains bile acids. Bile acids are reabsorbed in. Bile acids are reabsorbed in terminal ileum. We reabsorb the bile acids. Next, mucus in duodenum is produced by. Mucus in duodenum is produced by which glands? Mucus in duodenum is produced by which glands? Mucus in the duodenum is produced by which glands? Who produce the mucus? Excellent creator, MBBS creator, Keval, Vaishnavi. Yes, it's a Brunner glands. Brunner glands. So Brunner glands are the mucus producing glands. Brunner glands are the mucus producing glands in the duodenum. They produce the mucus. Next, sir. Next one is major salivary gland. Major salivary gland. So you already know there is parotid, submandibular, sublingual. Parotid, submandibular, sublingual. So which of the following is a major salivary gland? That is a submandibular. Salivary gland. Submandibular salivary gland. Okay. Sir, saliva, our saliva is hypertonica, hypotonica, or having same osmolarity as a plasma? Saliva, okay, saliva, hypertonica, hypotonica. Saliva contains very less amount of sodium and more potassium. As the sodium levels are less, it's a hypotonic solution. Okay, saliva is always hypotonic. Saliva contains less sodium, more potassium. Both are questions. Saliva में sodium कम है और potassium ज़्यादा है. Okay, next. Sir, saliva contains which antibodies? Saliva में कौन से antibodies are there, sir? Which antibody is present? Saliva contains which antibodies? Anyone? Come on, Ig. Saliva contains which antibodies? IgA antibody. अरे IgA antibodies is present in every secretion. No, tears में, saliva में, breast milk में, GIT secretions, urogenital secretion. Every secretion in the body contains which antibodies? IgA antibodies. You should know this. Come on, why no one answered? Huh? IgA antibodies are secretory antibodies. See, they are present in secretion, so they are also called as secretory antibody. IgA is also called as a secretory antibody. Usually, IgA antibodies exist as what? Two antibodies are attached to each other. Two antibodies. This is one IgA antibody. Here is the other IgA antibody. Two antibodies are attached to each other. So, IgA antibodies are existing as dimers. IgA is a dimeric antibody where two antibodies are attached to each other. So, IgA is a dimeric antibody. It's a secretory antibody. Okay, na? So, yeah, these are some important things which I want you to know. Okay, let me ask you last and final thing. Parotid. Oh, so wait. One important thing is there. That is, saliva contains which enzymes? Tell me. Saliva contains which enzymes? In our saliva, which enzyme is there? Carbohydrates को digest करने के लिए, carbs को digest करने के लिए, in order to digest the carbohydrates, which enzyme is there? That is salivary amylase, also called as thiolene. Okay, thiolene और salivary amylase किसके लिए सर? कार्बोहाइड्रेट्स को डाइजेस्ट करने के लिए, लिपिड्स को डाइजेस्ट करने के लिए. Okay, salivary lipase is there. Sorry, lingual lipase, not salivary, lingual lipase is there. Okay, in our saliva only two types of enzymes are there. One is thiolene and lingual lipase. Protein को digest करने के लिए कोई enzyme नहीं है sir. There is no protease in the saliva. Saliva contains less sodium but more potassium. The important thing, saliva is a hypotonic solution. Saliva contains IgA antibodies. Okay, so these are IgA is a dimeric antibody. Okay, so just know them. Tell me, what is the salivary gland which is present over here at the angle of the this area? Okay, here in this area, which salivary gland will be present? Parotid. Here is a parotid. Here is a submandibular. Here is submandibular. So tell me, parotid. One question to you: parotid, salivary gland, and submandibular. Innervated by, sir, parotid salivary gland, it is getting the stimulus from which cranial nerve? Parotid salivary gland is stimulated by, parotid is stimulated by which cranial nerve? Sir, P, just flip the P. Sir, if you flip the P, the P will become 9. If you flip the P, the P will become 9. That is the ninth cranial nerve. That is the glossopharyngeal nerve. And submandibular and sublingual. Submandibular as well as sublingual. Submandibular and sublingual innervated by 7th cranial nerve. So S for 7, remember, like S for 7, submandibular, sublingual. If you say 6th, I can't help you. So both submandibular and sublingual, sir, that is 7th. Okay, 7th cranial nerve. So that's it. If you can remember these many points, okay, that's enough for your exam. Chalo, after this, shall we begin the cardiac physiology? If you want, after the cardiac physiology, I will give the break. Okay, once we are done with the cardiac physiology, it's going to take some good amount of time, like let's say 1.5 hour time we have to spend for the cardiac physiology. After the cardiac physiology, okay, we'll take a small break. Okay, chalo, sir, in cardiac physiology, the most important thing which I want you to know is regarding the heart sounds. Okay, First, sir, let me write here cardiac cycle. Cardiac cycle. What you should know for your FMGE exam, cardiac cycle. Sir, in cardiac cycle, two phases are there. One is systole, other is diastole. Cardiac cycle में one systole, one contraction and relaxation. Contraction of the ventricle, relaxation of the ventricle. Contraction of the ventricle, relaxation of the ventricle. That's the systole as well as the diastole. Now, look here. Systole में how many subphases are there? Sir, in systole, there are three subphases. That is isovolumetric contraction, rapid ejection phase, and slow ejection phase. Means systole में three subphases are there. Isovolumetric contraction, rapid ejection, and slow ejection. But look, in diastole, how many subphases are there? 5. That is protodiastole. Let me highlight with a different color. Protodiastole, isovolumetric relaxation, rapid ventricular filling, diastasis, and atrial contraction. Atrial contraction. So tell me, systole में 3 subphases are there. Systole में 3 subphases are there. Diastole में 5 subphases are there. Systole is for how much time? Systole is for 0.3 seconds. And diastole is for 0.5 seconds. Total cardiac cycle is 0.8 seconds. Okay, 0.8 seconds. Now questions. Sir, in cardiac cycle, you know heart sounds are there. S1, S2, S3, S4. Now, where we will hear this heart sound, sir? When S1 heart sound is heard. Listen, S1 heart sound, listen, here itself, these are the MCQs. S1 heart sound is heard in the beginning of isovolumetric contraction. S1 heart sound. Aha, okay. So, in the beginning of the systole, which heart sound will come? S1. In the beginning of the diastole, which heart sound will come? S2. Okay. So, tell me, S1 is in the beginning of the systole. S2 is in the beginning of the diastole. So, right. S1 is due to the closure of mitral valve and tricuspid valve. Mitral valve and tricuspid valve. You know, mitral valve, tricuspid valve, they are atrioventricular valves. So, because of the closure of mitral valve, tricuspid valve, it causes S1. Then what about the S2, sir? S2 is due to the closure of the semilunar valves like aortic valve and pulmonic valve. Aortic valve and pulmonic valve को close करने वजह से S2. S1 in the beginning of systole, S2 is in the beginning of the diastole. Then what about S3 and S4, sir? Right. So this S3 and S4, they are heard in which phases of the cardiac cycle? Systole or diastole? Look, diastole mein. Sir, during diastole, S3 is heard. And during the same diastole, S4 is also heard. Okay. S3 is heard during rapid ventricular filling. S4 is heard during atrial contraction. S4 is heard during atrial contraction or atrial systole, you can say. Okay. So, right. Sir, S3 also called as a ventricular gallop rhythm, aka also called as what? Aka ventricular gallop rhythm is heard during rapid ventricular filling. S4, it is heard during atrial contraction. Atrial contraction, or you can say atrial kick or atrial contraction. But wait, so totally how many heart sounds are there? S1, S2, S3, S4. S1, isovolumetric contraction, the beginning of isovolumetric contraction. S2 in the beginning of diastole, that is protodiastole. Then what about S3? Sir, S3, it is heard during rapid ventricular filling, and S4 is heard during atrial contraction. But out of all, who is the pathological heart sound? Which sound is always pathological, sir? So always remember, right, let me write here, S4 is always pathological. S4 is always pathological. S4 is always pathological. Okay. S3 can be physiological. S1, S2 normal. S3 can be physiological. S4 is always pathological heart sound. S4. Okay. Next. Sir, what else you should know? Sir, isovolumetric contraction and isovolumetric relaxation. See, they begin with, look at this diagram. Sir, isovolumetric contraction, IVC. Isovolumetric contraction के पहले, sir, in the beginning of the isovolumetric contraction, which heart sound is heard? S1. In the beginning of isovolumetric relaxation, which heart sound is heard? S2. So tell me, isovolumetric contraction begins with S1 heart sound. Isovolumetric relaxation begins with S2 heart sound. Or you can say systole begins with S1 heart sound. Relaxation diastole begins with S2 heart sound. So that is what? So right, isovolumetric contraction begins with S1 heart sound. Isovolumetric contraction begins with S1 heart sound. Isovolumetric relaxation begins with S2 heart sound. So what I want you to know from here, from this area, I want you to know only one thing. Heart sounds S1, S2, S3, S4. Beginning of the systole, S1. Beginning of the diastole, S2. Rapid ventricular filling में S3. Atrial contraction के time में S4. Who is always pathological? S4. Okay, done. Now, closure of mitral valve and tricuspid valve, the closure of mitral and tricuspid valve, S1 heart sound. Closure of aortic valve, pulmonic valve, S2 heart sound. S2 heart sounds. Okay. Now, after this, heart sounds. Next, sir, which heart sounds are considered as low pitch heart sounds? Let me write here. Which heart sounds are considered as low pitch heart sounds? Low pitch heart sounds. Sir, in the entire medicine, only 3 heart sounds are considered as the low pitch heart sounds. Which heart sounds are considered as the low pitch heart sounds? That is S3, S4, and one more sound called as a tumor plop sound. Tumor plop sound. S3, S4 and tumor plop sound, they are the low pitch heart sounds which can be heard with the which side of the stethoscope? Bell side of the stethoscope. You know, stethoscope have how many sides? One big side called as a diaphragm, one chota side small as a called as a bell. So there are only 3 low pitch heart sounds, that is S3 heart sound, S4 heart sound and tumor plop sound. Only these 3 heart sounds are considered as what? Low pitch heart sounds. Low pitch heart sound. Okay, now fine. Now you are having a doubt, sir, where in kaun se conditions mein this S3, S4 and tumor plop sounds are heard? See, S3, can you hear S3 in me? In me, can you hear S3? No, S3 is usually not heard in adults. For example, in a person of 40 years old, let's say a 40-year-old patient, can you hear S3 heart sound? No, S3 heart sound can be physiological in children and pregnancy. It is physiological in children and pregnancy. Okay, in children mein, in pregnancy mein, you can hear S3. That is normal, not normal. But S3 is pathological in which condition? Sir, can you hear S3 in an adult of elder person of 40 years old? No, you cannot hear. You cannot hear it, S3, in adult of 40 years old. Okay, so tell me, if you can hear S3 in a 40-year-old, normal, abnormal? Definitely abnormal. So tell me, in which pathological conditions S3 is heard? S3 is a heart sound. S3 heart sound is seen in conditions where there is dilated ventricles. Whenever there is dilated ventricles. Whenever the ventricles are getting dilated, whenever the ventricular size, whenever the ventricles are getting dilated, so those dilated ventricles will cause which heart sound? S3 heart sound. S3 heart sound. Okay, for example, where you tell me dilated ventricles are seen? Congestive heart failure. Congestive heart failure, or you can say dilated cardiomyopathy. Dilated cardiomyopathy. Okay, myocarditis leading to the heart failure. So any condition, or MI leading to the heart failure. For example, the patient had a myocardial infarction, successfully resuscitated. Okay, but slowly, dhire se, because of this myocardial infarction, his heart become weak and that will lead to the heart failure. So any condition which is going to cause the dilated ventricles, this dilated ventricles will cause what? S3 heart sound. So S3 heart sound is seen in the cases of congestive heart failure or dilated ventricles. Then what about the S4? Can you hear S4 heart sound in me? No, S4 is always pathological. So S4 heart sound is seen in ventricular hypertrophy. Ventricular hypertrophy means any condition which is causing the hypertrophy of the ventricles, not the dilation of the ventricles. Hypertrophy means thick ventricular wall. So those thick ventricular wall, stiff ventricles are going to cause S4 heart sounds. You tell me, where will be ventricular hypertrophy? Kaun se conditions mein? Hypertension, left ventricular hypertrophy will occur. Hypertension. Hypertrophic obstructive cardiomyopathy. Aortic stenosis. So in sare conditions mein, that is aortic stenosis, hypertension, okay, long-standing hypertension, hypertrophic obstructive cardiomyopathy, in sare conditions mein, there is going to be ventricular hypertrophy. So the stiffer ventricles, when they contract, they can cause S4 heart sound. Okay, so S4 heart sound is seen with the ventricular hypertrophy, and S3 heart sound is going to be seen with the Dilated ventricles, not the hypertrophied ventricles. Dilated ventricles S3, hypertrophied ventricles S4. S4. And come on, you guys have to tell me now, sir, then tumor plop sound, it is seen with which condition? Am I going to have tumor plop sound? No. Then कौन से condition में एक tumor, sir, one tumor in the heart is going to cause this tumor plop sound. What is the name of the tumor? What is the name of the tumor? Bharat, thank you. That is atrial myxoma. Tumor plop sound is seen with atrial myxoma. Okay, tumor plop sound is seen with the atrial myxoma. So those persons you have already studied. So those persons who have atrial myxoma in the left side, left atria, it will move and it will make sound. That is called as a tumor plop sound. Okay, done. Now, after this, what else I have to teach you? Let me teach you one more important thing that you should know for your exam. Can anyone tell me? See, imagine this is the ventricle. Okay, this is the, okay, let me draw in a simple diagram. This is your heart. Here is your heart. Here is the left ventricle. This is the LV. Left ventricle. This is the RV, right ventricle. From here, what is this blood vessel that is coming out? Can you tell me what is this blood vessel that I am showing you? This is the aorta. Here is the aorta. That is coming out of the left ventricle. Now, I am asking you, sir, will you fill the blood here? Yes or no? Will you fill the blood into the ventricle? Yes, I will fill the blood into the ventricle. How much I will fill? 120 ml blood I will keep here. Here also 120 ml blood I will keep. Here 120 I am keeping. Here also 120 ml blood I am keeping. So this 120 को क्या बोलते हैं sir? It is called as end diastolic volume. End diastolic volume, also called as preload. End diastolic volume or preload. Next, sir, when heart contracts, whenever the heart is going to contract, do you think all this 120 ml, do you think all the 120 ml will go into aorta? No. Only how much will go? Sir, only 70 ml is ejected. So this 70 ml को क्या बोलते हैं sir? Stroke volume. We call it as a stroke volume. But tell me, out of 120, 70 ml is ejected. 70 ml is ejected. How much is left over? Sir, ejection होने के बाद, how much is left over? 50 ml. 50 ml. So that 50 ml left over is called as end systolic volume. End systolic volume. So tell me how much is the end diastolic volume? 120 ml. Stroke volume 70 ml. End systolic volume 50 ml. 50 ml. So can I say out of 120 only 70 ml is ejected? So how much is this? That is stroke volume divided by end diastolic volume. End diastolic volume. So this is called as ejection fraction. Ejection fraction. What is the formula for the ejection fraction? So okay, ejection fraction meaning stroke volume divided by end diastolic volume. And always in a healthy individual, always the ejection fraction should be greater than 55%. Usually in you and me, it will be somewhere around like 65 to 70% in you and me. But at least the ejection fraction should be more than 55%. Okay, in a normal individual. Okay, that is what is the formula for the ejection fraction? The ejection should be, the heart ejection should be at least 70 ml. Out of 120, 70 should be ejected. Okay, that's it. Next. So why I am teaching you this is because, wait, now in normal individual, end diastolic volume is how much? 120 ml, sir. Out of this 120 ml, how much stroke volume is ejected? 70 ml is ejected. 70 ml is ejected. So 120 mein 70 is ejected. But today, wait, instead of 120 ml, I am keeping, let's say 240 ml blood. 240 ml blood into the ventricles. I am loading more. I am giving more blood in the ventricle. Do you think only 70 will come out now? Do you think 70 will come out, or more will come out, or less will come out? Sir, now more is going to come out. Now, let's say maybe 140 ml is ejected. So more you keep, the more the blood you keep, the more is getting ejected. You keep more blood in the ventricle will push more blood. So can I say end diastolic volume or preload is directly proportional to what? Stroke volume. Whenever end diastolic volume is increased, stroke volume also directly increased. So yes, this law is called as, come on, what is this law? This law is called as Frank-Starling's law. Frank-Starling's law, that is end diastolic volume is directly proportional to the stroke volume. If you increase the end diastolic volume, proportionately stroke volume also increases. Okay, so that is a Frank-Starling's law. Frank-Starling's law. Okay, na? Fine. Na? Next, apart from this, what else I want to teach you? Okay, what else I have to teach you? Guys, look carefully. Here I am drawing the ECG. P wave, QRS, P wave, array. QRS and T wave. P, QRS and T. Now, you have to tell me, sir, here is a P, this is Q, R, S, T, P, Q, R, S and T. Now, you have to tell me during this part of the ECG, see I am highlighting these areas. During this part of the ECG, which cardiac event is happening? Sir, this is after P wave, no? So, this is the place where P wave started, means the atrial cells are going to depolarize. P wave means what? P wave means atrial cells are getting depolarized, means electrically activated, positive charges. Sir, depolarization. After depolarization, the atria will contract. So, exactly during this period, there is atrial contraction. Sir, during this period of the ECG, इस समय में who is contracting? Atria contraction. Okay, atria is getting contracted. After P wave, atria is getting contracted. Next, sir, what is this one? This is QRS. QRS means what? Ventricular depolarization, means the ventricular cells are getting activated. Ventricular depolarization. After depolarization, there will be contraction. So, here, sir, you know, usually students will think, what do they think, you know, sir, during P wave, atria is contracting. No. Sir, it is after the P wave, atria is contracting. Do you know where the ventricle will contract? Sir, ventricular contraction actually begins at the peak of the R wave. This is the place where the ventricular contraction will begin. So, ventricle is contracting. Even during this period, ventricle is contracting. Even during this T wave also, ventricle is contracting. Okay. So, let me draw it here. Sir, from the middle of the R to the end of the T wave, this is all systole. This is all systole. Usually what student will think? Student will think, sir, during QRS the ventricle is contracting. No. Sir, QRS means ventricular depolarization, means the ventricular cells are getting the electricity, means they are depolarized. Once they got the depolarization, they will contract. So, QRS होने के बाद, sir, actually from the middle of the R wave, yes, ventricular contraction begins. Isovolumetric contraction, rapid ejection phase, slow ejection phase. So, during all this period, yes, ventricle is contracting, systole. Wait, now. Tell me, what is the meaning of the word T wave? Sir, T wave. T wave meaning ventricle repolarized. Sir, ventricle is undergoing repolarization, means going back to negative charge. Once it is the repolarized, later it will relax. So, after the T wave, what will happen? Sir, after the T wave, what will happen is diastole. Okay, again one more QRS will begin. Okay, just wait. Let me make it clear for you. Okay, let me draw one more QRS. Okay, so now till one more middle of the R wave, there is going to be diastole. So, this whole area is the diastole, and here it is the systole. So, in your exam, you might get a question asking, sir, in ECG, systole is from where to where? Sir, systole is from middle of the R to the end of the T wave. This is the area where the ventricle is contracting. And diastole is from where to where? Sir, diastole is from end of the T wave. See, end of the T wave to one more R wave, to one more middle of the R wave. So, this area is the diastole. Sir, in systole, how many phases are there? In systole, there is isovolumetric contraction. First, there is isovolumetric contraction, rapid ejection phase and slow ejection phase. You already know this. In diastole, how many phases are there? 5 subphases are there. That is protodiastole, isovolumetric relaxation, rapid ventricular filling, slow filling, that is diastasis, slow filling or diastasis, and again atrial contraction. So these are the 5 phases of the diastole. Okay. So never from today, never say P wave means atrial contraction, QRS means ventricular contraction. So after the QRS, or actually after the QRS, the systole is going to happen. If you want to know in specific, systole, the ventricular contraction begins from the middle of the R and ends at T wave. At the end of the T wave, at the end of the T wave, systole will end. Now, you might be thinking, sir, why I should know this for my FMGE exam? Okay, now I understood. But why I should know this? Have I taught you? Sir, during atrial contraction, which heart sound will come? Sir, atrial contraction ke samay mein, which heart sound will come? Now tell me, what is the heart sound that is heard right after P wave? Sir, after the P wave, which heart sound is going to be heard? Sir, atrial contraction ke wajah se, which heart sound will come? S4. Always pathological. In a normal person, can you hear it? No. But S4 heart sound is heard during atrial contraction. Next, sir, in the beginning of isovolumetric contraction, which heart sound will come? The beginning of the systole, which heart sound will come? S1. Sir, in the beginning of the diastole, which heart sound will come? In the beginning of the diastole, S2. During rapid ventricular filling, which heart sound will come? That is S3. Now, you might be thinking, sir, how question will come in my exam? You know, tell me, which heart sound comes after P wave? Tell me, after P wave? After P wave, it is S4. After R, sometimes they will say QRS. After R or after QRS. Sir, after R, it is S1 heart sound. After T, it is diastole going to begin. So S2, that is before P, that is S3 heart sound. So before the P wave, see, before the P wave, which heart sound is coming? S3 heart sound. Tell me, S3, S4 is seen in normal individuals? No. S4 is always pathological, seen in hypertrophied ventricles. S3 is seen in dilated ventricles. In which conditions where the ventricles will undergo dilation? Congestive heart failure. Maybe because of myocarditis or maybe because of dilated cardiomyopathy. Okay. So now I have taught you the heart sounds integrated with ECG. When which heart sound is heard? Here what I have taught you? Here I have taught you Frank-Starling's law. What is Frank-Starling's law? The more you fill the heart, the more it will pump. If there is more endostolic volume, more the stroke volume will be. Okay. Chalo. So these are enough. I hope these are enough for FMGE exam. Okay. Chalo. Next, after this, the next topic that I am going to teach you in the cardiovascular physiology is a pressure volume loop. Simple, sir. In your exam, they will give you this diagram, and they will ask you, identify the areas. So, if you have already know this, that it will become easy. But if you don't know, sir, see, if you don't know, at this point of time, just before the exams, okay, we don't have enough time to discuss in detail. Trust me, okay? Sir, whenever you see, they will ask you to identify this blue color line that I am representing here. Are what is this blue color line representing? It is ventricular filling from 50 ml, that is end systolic volume, to 120 ml end diastolic volume. So this line represents what? This blue color line represents, right, in your book, ventricular filling, VF. A ventricular filling. Okay, na? Next. So once the ventricles are filled, that is 120 ml, ventricles are filled. Now what will happen, sir? Ventricles are filled with 120 ml of blood. Now what is the next phase of the cardiac cycle? See, the next phase where the pressure is rising, in the ventricle up to 81 mmHg. So this phase is called as isovolumetric relaxation. Okay, isovolumetric relaxation. Done. Next, this phase which I am highlighting you, this is isovolumetric relaxation. After isovolumetric relaxation, this phase which I am highlighting, this is called as a rapid ejection phase. The blood is ejected into the aorta rapidly, rapid ejection phase. Later, the blood will be ejected into the aorta slowly. So, slow ejection phase. Rapid ejection phase, slow ejection phase. After that, the pressure inside the ventricles is going down. From 80, it is going down to 4 again. So, what is this? This is isovolumetric relaxation. Isovolumetric relaxation. This is downgoing pressure. This upgoing pressure is the isovolumetric contraction. So, tell me, sir, this is all about the one cardiac cycle. This is whole thing is the one cardiac cycle. Now, what is this bottom line representing? Ventricular filling. What is this one? Isovolumetric. Hey, sorry. Here I made a small mistake. This is isovolumetric contraction. Isovolumetric contraction. Okay, now. So this is isovolumetric. Yeah, this is isovolumetric contraction. Now, after isovolumetric contraction, okay, after isovolumetric contraction, there is a rapid ejection phase followed by slow ejection phase, isovolumetric relaxation, and ventricular filling. Ventricular filling. Next, what else you should know for your FMG exam, sir? From this diagram, what else you should know is areas. Look, this point, what happening? Sir, this is a place where isovolumetric contraction is beginning. So this is a place where isovolumetric contraction begins. So tell me, when in the beginning of the isovolumetric contraction, which heart sound will come? S1. S1 is due to what? S1 is due to the closure of mitral valve and tricuspid valve. Mitral and tricuspid valve. So that's why this place, mitral valve is closing. This is the left ventricle. No, this is left ventricle. I am talking only about the left sided valves because this is about left ventricle ka pressure volume loops. The diagram is called as left ventricular. Sorry, left ventricular pressure volume loop. Left ventricular pressure volume loop. So tell me which valve on the left side? Mitral valve. Mitral valve closes, giving rise to which heart sound? S1 heart sound. S1 heart sound. Next, sir, once the pressure is 81, tell me in your left ventricle, once the pressure is 81, which valve will open? Aortic valve will open. Aortic valve will open. So tell me once the aortic valve is open, it will cause which heart sound? Ejection click. Ejection click. Ejection click is due to the opening of aortic valve. Done. Next, tell me, once the pressure goes less than 80, this area, once the pressure goes less than 80, aortic valve is going to close. So which heart sound will come? S2. S2. Okay. Next, sir, at the end of isovolumetric relaxation, see, this is the end of isovolumetric relaxation where the pressure is decreasing inside the ventricle. The pressure is decreasing inside the ventricle. Now, once the pressure is totally, the ventricle is relaxed. Once the pressure is decreased, now the mitral valve will open because mitral valve closed. No, here mitral valve closed. So mitral valve will open again. So that opening of the mitral valve will cause which heart sound? Opening snap. Opening snap. So these are the 4 areas which I want you to remember for your exam. Sir, bottom line, ventricular filling, isovolumetric contraction, rapid ejection, slow ejection, isovolumetric relaxation. Where, sir, now I am going to discuss about the heart sounds. S1, ejection click, S2, opening snap. These are the 4 heart sounds. Okay, these are the 4 heart sounds. Now, how you can expect an MCQ, sir? How you can expect an MCQ in your FMG exam? See, if your examiner wants to give the simple paper. So this is how you are going to get a question. X-axis, Y-axis. Here is the left ventricular pressure volume loop. Okay, here is the left ventricular pressure volume loop diagram. Okay. They will ask you, identify this marked area. Tell me what is this marked area which I am showing here? Sir, this is a ventricular filling, marked area, isovolumetric contraction, rapid ejection phase, slow ejection phase, isovolumetric relaxation. Done. These are the phases. Okay, these are the 4 phases in the graph. Now they will ask you, identify the heart sound that is heard here. Sir, here is the S1 heart sound heard. Here is the ejection click. Here is the S2 heart sound heard. Here is the opening snap. Here is the opening snap. Okay, fine. Next, tell me, what is this area which I am highlighting in the yellow color? So this area which I am highlighting in yellow color, that is the phase from S1 to S2. So the area between S1 and S2, the area between S1 and S2 heart sounds. So this yellow color area is what? Is the systole. Excellent, excellent. Systole. And this area which I am highlighting in the light green color. So this area which I am highlighting in the light green color, what is this area, sir? Okay, this area which I am highlighting, sorry, in the light green color, this area. What is this area? Between S2 and S1, this is the diastole. Okay. Systole and diastole. Systole and diastole. So that's it. This is how you can get a question if the examiner is not a psycho. Okay, so simple. These are the simple questions. Now, little bit more info from this diagram. Tell me, what is the starting point called as? The starting point is called as end systolic volume. What is this ending point called as? End diastolic volume. End diastolic volume we already know, 120 ml. End systolic volume is how much? 50 ml. 50 ml. Okay. So now tell me, what is the difference between these two areas? Sir, the difference between these two areas are that is end diastolic volume minus end systolic volume. End diastolic volume minus end systolic volume. That is 120 minus 50. How much? 120 minus 50. 120 minus 50 is how much? 70 ml. So that 70 ml is your stroke volume. This is the difference between these 2 points. The difference between these 2 points, how much is this? This is the stroke volume. The stroke volume. Okay, so understood? 70 ml stroke volume. You know already 70 ml stroke volume. Now, see, imagine now you are sitting in your exam hall. Okay, you are sitting in your exam hall. I am asking you to calculate cardiac output. I am asking you to calculate cardiac output from this image. Tell me, what is the cardiac output? Imagining he is a healthy person and his heart rate is 72 times. His heart rate is 72 times. You know the formula for the cardiac output? Cardiac output is equal to stroke volume into heart rate. In this diagram, how much is the stroke volume? The stroke volume is the difference between end diastolic volume and end systolic volume. How much is that? 70 ml. So 70 ml into 72 times. 70 ml into 72 times. How much? 70 ml into 72 times? 5040 ml per minute. So this is the cardiac output. What is the formula for the cardiac output? The formula for the cardiac output is stroke volume into heart rate. Stroke volume into heart rate, that is 70 into 72 times. 70 into 72 times. Okay na? 5 liters. 5 liters. Now, sir, you already know what is the formula to calculate the cardiac output. The formula to calculate the cardiac output is equal to stroke volume into heart rate. But there is also one more method to calculate the cardiac output. What is that one more method to calculate the cardiac output? FMGE question only. FMGE important question only. FMGE as well as NEET PG question. That is fixed principle. Fixed principle. Not fixed law of diffusion. The fixed law of diffusion is different. This is fixed principle. Fixed principle is used to calculate cardiac output. It is used to calculate the cardiac output. So what is the formula? The formula is volume of oxygen consumed per minute. 1 minute mein how much oxygen you are taking. I will check whether you are taking 100 ml oxygen or 200 ml oxygen or 300 ml oxygen. How much oxygen you are taking from the cylinder. From the cylinder, how much oxygen you are breathing. Volume of oxygen consumed per minute by arterio, means arterial blood. Arterio, venous blood. Arterio, venous oxygen difference. Arteriovenous oxygen difference. Can you tell me how much amount of oxygen I will take every minute? Normal, you and me, sir. How much oxygen we will take every minute for our survival? We will take some oxygen. No, how much oxygen we will take from the environment? Or from the cylinder? How much oxygen we will take? 250 ml of oxygen we will take for every minute. 1 minute mein this much amount of oxygen we will use. And how much is the oxygen in the arterial blood? And how much is the oxygen in the venous blood? Arterio-venous oxygen difference. That is 1 liter arterial blood में 190 ml oxygen है and 1 liter venous blood में 150 ml oxygen है. 150 ml. So tell me 190 ml minus 150 ml. Arterial blood में oxygen है, ज़्यादा oxygen है 190 ml. Venous blood में कम oxygen है only 150 ml. So now tell me 250 divided by 50. How much? 250 divided by 50. How much, sir? 5 liters. So this is the cardiac output. Okay, this is the cardiac output. So cardiac output can be calculated by using a principle called as fixed principle. Fixed principle. What is the formula to calculate the fixed principle? Volume of oxygen consumed by minute by arteriovenous oxygen difference. Arteriovenous oxygen difference. Okay. So you might get a question asking that which of the following is used to calculate the cardiac output. Cardiac output को calculate करने के लिए which of the following method can be used? Fixed principle can be used. Okay, fixed principle can be used. Sorry, 190 by 140 here, not 150, sorry, 140. Okay, yeah, 190 minus 140 is how much? The difference 50, no, 50. So yeah, okay. Done. Next, after this, guys, now let me discuss about the pulse. Okay, let me discuss about the pulse topic. See, in your arteries, how the pressure is going to change. Okay, how the pressure is going to change, guys. Okay, let me discuss about the pulse later. After some time I will discuss about the pulse. First let me explain you the jugular venous pulses. It will become easy for you. Okay, first let me explain you the jugular venous pulses. Just turn 2 pages, just turn 2 pages. You will get the clarity easily. First open this topic called as the jugular venous pulses, JVP, jugular venous pressure changes, which means the pressure in your internal jugular vein sometimes increase, sometimes decrease. The pressure in your internal jugular vein sometimes increases during the cardiac cycle, sometimes decreases. Wait, with one contraction, one relaxation. See, your ventricle is going to contract, your ventricle will relax. You know, one contraction, one relaxation. Cardiac cycle, no. But during this one cardiac cycle, the pressure in your internal jugular vein, look, the pressure is increasing, decreasing, increasing, decreasing, increasing, decreasing. So 3 times it is increasing, 1, 2, 3. 3 times it is increasing, and 1, 2, 3. 3 times it is decreasing. So sometimes increasing, sometimes decreasing. Why? The pressure in the internal jugular vein, it is dependent on the right atrium, because the internal jugular vein is connected to the superior vena cava, and the superior vena cava is connected to the right atria. So the internal jugular venous pressures are determined by the right atrium, right atrial pressures. Okay, so now here, if the wave is going up, means it's a pressure in the internal jugular vein is increasing. If the wave is coming down, means the pressure in the internal jugular vein is decreasing. So why, sir? We are not going to the details, but for your FMGE exam, let me tell you. This A wave, see, the pressure in the internal jugular vein is increasing. Why the pressure in the internal jugular vein is rising? The pressure in the internal jugular vein is rising. Why? A wave is due to right atrial contraction. Okay. So A wave, yes sir, A wave is due to atrial contraction. Whenever the right atria is contracting, the pressure in the right atria increases, the pressure in the internal jugular vein also increases. So A wave in the JVP, the jugular venous pressure, the A wave is seen during atrial contraction. Okay. Then what about the X wave? Sir, you can see A wave is high pressure. What is X wave? X wave means the pressure is decreasing. At X wave, the pressure in the internal jugular vein is decreasing during atrial relaxation. Atrial relaxation. A wave is seen during atrial contraction, X wave is seen during atrial relaxation. Okay, but can you see the small C wave? They will ask you in your exam. C wave. C wave is due to what? Why the pressure in the internal jugular vein is again increasing? C wave. The C wave is due to the contraction of the ventricle now. Now, it is the ventricular contraction leading to the bulging of what? Leading to the bulging of tricuspid valve on the right side. When the right ventricle is contracting, that will cause the bulging of tricuspid valve into right atria. Right atrial pressure increases, internal jugular venous pressure also increases. Okay, so the small little deflection, the C wave is due to right ventricular contraction leading to the bulging of the tricuspid valve into the right atria, leading to the increase in the internal jugular venous pressure. Okay, C wave completed. Next, what about this X descent? X descent wise. Now the tricuspid valve, whatever has bulged, it will go down. Internal jugular venous pressure also decreases. So it's a downward movement of the tricuspid valve. Upward movement of the tricuspid valve causes a C wave. Downward movement of the tricuspid valve will cause this X dash, X descent. Next, sir, what about this V wave and Y wave? You tell me, right atria will receive the venous blood, yes or no? Right atria will receive the venous blood. Right atria from the superior vena cava, from the inferior vena cava, it will receive the venous blood. So venous filling, When right atria is filling with the venous blood, right atrial pressure increases, internal jugular venous pressure also increases. So V wave is due to this V wave, again see pressure is increasing. V wave is due to atrial filling with which blood? Atrial filling with venous blood. Okay, venous filling of the atria. Now tell me, from the atria, where the blood will go? The blood will go down into the ventricles. With the opening of the tricuspid valve, when the tricuspid valve opens, blood from the atria will fall down. Right atrial pressure increases, JVP also decreases. So that Y wave or this Y descent, sir, this Y descent is due to what? Sorry, the Y descent. It is due to atrial emptying into the atria is emptying into the ventricle with the opening of which valve? With the opening of tricuspid valve. So what I am trying to say, students, simple, listen. The pressure in the internal jugular vein, the pressure, normal individual mean you and me, the pressure in our internal jugular vein sometimes increases, sometimes decreases based on the event of the cardiac cycle. Sometimes it increases, sometimes it decreases. This is absolutely normal. Why you should know this, sir? Now you might be thinking, sir, why I should know this? This A wave, when A wave will occur, when X wave will occur, when C wave will occur, when Y wave will occur, when V wave will occur. Why I should know this? Because if you know normal, in diseases, this JVP, jugular venous waveform, it will change. Different diseases may, the waves will become differently. So as a doctor, as a good doctor, just by looking at the monitor, in the monitor you are seeing this JVP waveforms. Just by looking at the JVP waveforms, you can say what is something wrong with the heart. Okay. So if you know what is normal, then you can also know what is abnormal. Now for example, see, sir, this is normal. A wave is due to atrial contraction, X wave is due to atrial relaxation, C wave is due to the bulging of tricuspid valve, and X descent is due to downward movement of the tricuspid valve. V wave is due to venous filling of the atria, Y wave is due to atrial emptying with the opening of tricuspid valve. This is normal. Now abnormal JVPs. Sir, atrial fibrillation ke time mein, how the JVP will change? Sir, atrial fibrillation means, you know, atria is not contracting. Hey, atrial contraction causes A wave. Here atria not contracting, so absent A waves, right? So what JVP change will be seen? Absent A wave. Absent A wave. A wave is going to be completely absent. Next, in patients with tricuspid stenosis, pulmonic stenosis, pulmonary artery hypertension, in तीनों conditions में, do you know how the JVP will change? There's going to be large A wave. In a patient with atrioventricular dissociation, or you can, examples of atrioventricular dissociation are, means atria and ventricle contracting at the same time. The atria, ventricle contracting at the same time they are contracting. Okay, so seen in third degree heart block or ventricular tachycardia or junctional tachycardia. Is conditions में wherever there is atrioventricular dissociation, where atria and ventricle contracting at the same time, do you know what will happen to the JVP? There's going to be super large A waves called as cannon A waves. So just by looking at the pattern of this JVP waveform, I can say what is something wrong with the heart. If I say cannon A waves, I can think that this patient may be having third degree heart block or maybe ventricular tachycardia. If I see large A waves, I will think that maybe the patient is having the right-sided valve stenosis like tricuspid stenosis, pulmonary artery hypertension or pulmonic stenosis. If I don't see any A wave, I will think about the atrial fibrillation. Okay. Next, in tricuspid regurgitation, guys, this is little important. Tricuspid regurgitation, 3 changes will be seen. 3 changes. 3 JVP changes are going to be seen. One is absent X. Okay, absent X wave. That X descent is going to be absent. Large, or you can say tall T waves, absent X, prominent Y. Prominent ka meaning sharp, prominent meaning sharp. Sharp Y wave and tall V waves. Tall V waves. Now, some of the students might be thinking like, you know, sir, what is this absent X, prominent or sharp Y, or tall V wave? Let me tell you what is normal. See, in a normal you and me, in a normal person like you and me, this is how the JVP waveforms are going to be. For example, like A wave, X wave, C wave, A wave, X, C, X dash, V and Y. This is normal. A, C, Okay, V, Y, here is X. Okay, this is normal. But in a patient with a tricuspid stenosis, do you know how it is going to change? In a patient with a not tricuspid stenosis, sorry, tricuspid regurgitation, the wave pattern is going to become something like this. A, as usual, A, C, after C, there is no X descent. There is going to be tall V wave followed by sharp Y wave. So this is how it is going to be. So immediately after the C wave, see, immediately after C wave, there is V wave. There is no X descent. So these waves are also called as CV waves. CV waves. Okay, very important for your FMGE exam. CV waves in the JVP are seen with the CV waves. The CV wave pattern is going to be seen with the tricuspid regurgitation. Atrial fibrillation may absent. A. Tricuspid stenosis, pulmonic stenosis, pulmonary artery hypertension, large A waves. Third-degree heart block, junctional tachycardia, ventricular tachycardia. There is going to be canon A waves. In tricuspid regurgitation, there is going to be absent X descent. Sharp Y with the tall V waves. Tricuspid regurgitation. Next, in the same way, in a patient with constrictive pericarditis because of the TB infection, you know, TB to the lungs, it will spread to the heart and leading to the constrictive pericarditis, especially during the recovery stage it will cause. Okay, so constrictive pericarditis, two changes are going to be seen. That is both very simple, prominent X and prominent Y. Both are prominent. That is sharp or prominent X as well as prominent Y wave. Prominent X as well as prominent Y. Both are going to be prominent. X is going to be prominent. Both X dash both are going to be prominent. Prominent X as well as the prominent Y waves. Next, cardiac tamponade. So this is my favorite. If I am the examiner, definitely I will give this. If I am the examiner, definitely I will give this. Cardiac tamponade. So it's up to you. You have to tell me, if I am the one with the cardiac tamponade, what kind of JVP change I will see. That is going to be the very important with big letters, absent Y. Absent Y wave. Prominent X can be prominent, but main important thing is absent Y wave. Y waves are not going to be seen. Okay, so cardiac tamponade, absent Y wave. So if a good doctor, just by looking at the JVP waveforms, he can actually say what is something wrong with me. If you cannot see A wave, atrial fibrillation. If you cannot see Y wave, cardiac tamponade. Both prominent X, prominent Y, constrictive pericarditis. CV waves, tricuspid regurgitation. Large A waves, tricuspid stenosis, pulmonic stenosis, pulmonary artery hypertension, one of them. Okay, if you see canon A waves, ventricular tachycardia, junctional tachycardia, third-degree heart block. Okay, done. So this is these are all abnormal JVPs. These are all what? Abnormal JVPs. These are all abnormal JVPs. Sir, when are you going to come to Isikul? Most probably in December. I will be coming to Isikul most probably in December. I think from December 1st till December 10th, I will be in Kyrgyzstan, Isikul. Then we can have the slowly for 10 days we can have the physiology. Okay, slowly important topics like with more and more integrations we can do. Now we are doing the entire physiology in let's say 6.5 hours, 7.5 hours. In school we will be doing the same thing slowly in detail because you guys are having a lot of time. Still 1.5 year time is there for the juniors. Keval is asking, sir, can you draw the JVP waveform of a cardiac tamponade? In cardiac tamponade, Y wave is not going to be there. That's it. Normal person may A, C, X, V, but here there is not going to be Y wave. The Y wave is not going to be there. Okay, Y wave is not going to be there. It's a blunted Y. Okay, that's it. Okay, normally Y wave should be there. There should be a Y wave, but here there is there's no Y wave. Immediately after that, again A is going to come. Okay, again A, C, X, again normal. Okay, Keval, normally Y wave should be there, but here in the cardiac tamponade, Y wave is not going to be there. Okay, after this again A wave, X, C, okay, X dash, V, again something like that. Okay, done. Now after this, what else I have to teach you? Students, listen carefully, listen carefully. In normal you and me, whenever I do the inspiration, listen carefully. Whenever I do, this is normal, take the heading normal. In you and me, whenever I do the inspiration, usually our JVP should decrease. Why? Look at me. What am I doing? Inspiration. Whenever I do inspiration, my thoracic volume increases. Whenever the volume increases, the pressure in the thorax will decrease. Right atrial pressure will decrease. Whenever the right atrial pressure decreases, automatically JVP, the jugular veins which are connected to the right side of the heart, so their pressure also decreases. So upon doing inspiration, the right atrial pressure decreases. So try to understand simultaneously the jugular venous pressures also decreases. That's normal. But if you are doing inspiration and your JVP, rather than decreasing, it is increasing, then that is called as, that is abnormal, sir. Then that is called as Kusumal sign. So tell me, what is Kusumal sign? Kusumal sign means absolutely abnormal, pathological. It's always pathological. It's absolutely pathological. So what is Kusumal sign? Kusumal sign means upon doing inspiration, rather than decreasing in the jugular venous pressure, if it increases, then it is called as Kusumal sign, pathological. Now question to you, tell me, this Kusumal sign is seen in which conditions? If it is pathology, seen in which conditions? I gave you a mnemonic also. Kusumal sign is going to be seen with the three conditions. What is that mnemonic I gave you? My mnemonic. Yes, Nitish, yes, KCR. Okay, KCR. That is what? Kusumal sign is seen in constrictive pericarditis. R for, actually two R's are there. One is right heart failure and restrictive cardiomyopathy. So in तीनों conditions में, that is a KCR. Kusumal sign seen in constrictive pericarditis, right-sided heart failure and restrictive cardiomyopathy. So in तीनों conditions में, the JVP rather than decreasing, the JVP will increase. Okay now? Now here itself, I want you to know one more thing, sir. Look, very important for your clinicals also, for your future also. So just listen carefully. Okay, don't draw this with me. Just listen. Imagine this is your 4-chambered heart. Here I am showing only 3 chambers, 4-chambered heart. Look what am I doing? I am doing inspiration. Whenever I do inspiration, thoracic volume increases. Here the pressure decreases. So the pressure in the thorax decreases. Actually, there is going to be a negative intrathoracic pressure. Actually, there is a negative pressure here in the thorax. That is a vacuum is there. Do you know what this vacuum will do? It will suck the blood. It will suck the blood from the superior vena cava and from the inferior vena cava. It will suck the blood towards the heart. So to the right side of the heart, from the superior vena cava and from the inferior vena cava, more blood will come. More venous blood will come. Increase venous return. More blood is coming. From the superior as well as inferior vena cava, more blood will come to the right side of the heart. Okay now? Now you tell me, now where this blood will go? Now this more blood, where it will go? Now it will eventually go into the right ventricle. So now right ventricle will fill more. Now the right ventricle is going to fill more. Okay? So because of the filling of the right ventricle, it will actually deviate the interventricular septum. It will push, this extra blood is going to push the interventricular septum towards the left side. It's pushing. So now tell me, here left ventricular cavity size. Okay, left ventricular cavity size decreases. Okay. Left ventricular filling decreases. So now in the left side, more blood do you think will fill or less blood do you think will fill? Less blood will fill. So whenever you do Inspiration, left side will fill less. Now, whenever there is less filling, that is, can I say, end diastolic volume on the left side, end diastolic volume decreases. So automatically what will happen to the stroke volume? Decreases. Means the blood coming out of the left ventricle, decreases. So automatically blood pressure decreases. So always remember, whenever I do the inspiration, the blood pressure will go down, the blood pressure will decrease. Okay na? So whenever I do inspiration, the blood pressure will decrease. Normally jugular venous pressure decreases. I have taught you jugular venous pressure will decrease, as well as my blood pressure also decreases upon doing the inspiration. How much decrease? It will decrease a little bit only. But if the decrease is more than 10 mmHg, if the blood pressure falls, okay, if the BP falls more than 10 mmHg, okay, yeah, normally whenever I do inspiration, my BP will slightly fall. But if the fall is more than 10 mmHg, then that is called as, come on, tell me, FMGE exam question. Then that is called as, if the fall in the BP is more than 10 mmHg, then this condition is called as. Excellent, Ali Mansuri, excellent. That is pulses, money, also, yes, you are true. Pulses, paradoxes. This condition ko kya bolte sir? Pulses, paradoxes. Can you tell me in which condition you will see the pulses, paradoxes? Kaun se condition mein sir? In which condition you are going to see these pulses, paradoxes? Can you tell me from your medicine? Okay. Can you tell me from your medicine, pulses, paradoxes we are going to be seen with? Excellent. Cardiac tamponade. Excellent. Okay. Pulses, paradoxes is going to be seen with, it's abnormal condition. No, normally BP will fall by slightly somewhere around like 3 to 5 mmHg, the BP will fall. But if the fall is more than 10 mmHg, when compared to normal, when the fall in the BP is more than 10 mmHg, then that is called as the pulses, paradoxes, seen with, right? Pulses, paradoxes is seen with cardiac tamponade, and constrictive pericarditis. Cardiac tamponade and constrictive pericarditis. Even if you forget about the constrictive pericarditis, no issue, but never forget about the cardiac tamponade, because cardiac tamponade is very important for your exam. You know, there is going to be Beck's triad going to be seen with low JVP, muffled heart sounds, low BP, hypotension. You know, Beck's triad. You anyway know it. So, done. Clear? And done? Next. Sir, after this, what else I should teach you? Okay, what else I should teach you? Now, come back to this topic, murmurs. Very, very important for your FMGE exam, murmurs. Okay, murmurs. See, a good doctor, just by auscultating, okay, just by looking at the JVP wave patterns, you can say what is something wrong with the heart. In the same way, just by looking at the ECG, you can say what is something wrong with the heart. Just by feeling the pulse, is it normal pulse, anacrotic pulse, pulses, paradoxes, is it dicrotic pulse? Just by feeling the pulse, you can say what is something wrong with the heart. In the same way, just by doing the auscultation, okay, aortic area, pulmonic area, Erb's point, tricuspid area, mitral area, just by doing the auscultation in these certain areas, you can say what is something wrong with the heart. Because if you see any murmurs, that murmurs will tell you whether there is any valvular abnormality or not. So now look at here, sir. Now in the topic of murmurs, I am going to explain you certain murmurs and associated heart conditions. For example, see the diagram I am showing you here. This is called as a phonocardiogram. Okay, phonocardiographic image. Here, number 1. Look, this one, the murmur. See this murmur. Wait, stop. Have I taught you from the middle of the R wave to the end of the T wave? What is this event called as? Systole. Okay. From the end of the T wave, from the end of the T to one more R, to one more middle of the R. What is this one, sir? This is the diastole. So systole and diastole. So tell me, what is this first murmur? Sir, this is the first murmur. It is there throughout the systole, but not during the diastole. Again, throughout the systole. So what type of murmur is this? The first type of the first murmur. So this murmur is called as pansystolic or holosystolic murmur. Stop. Now tell me, pansystolic or holosystolic murmur, sir? It is seen in which conditions? Tell me for your FMG exam. Pansystolic murmurs or the holosystolic murmurs are seen with which valvular abnormalities? Pansystolic or holosystolic murmurs, right? That is MR, mitral regurgitation, tricuspid regurgitation, ventricular septal defect, MR, TR, VSD. In तीनों conditions में, okay, you will be having holosystolic or pansystolic murmur. This is regurgitant murmurs. That's a mitral regurgitation, tricuspid regurgitation. If these valves are regurgitating, the AV valves, atrioventricular valves, when they regurgitate, they will cause what type of murmur? Holosystolic or pansystolic murmur. Systole, the murmur is seen during the systole. Next, second type of murmur is also seen during the systole. It is also seen during the systole, but the intensity of the murmur is increasing, decreasing. Increasing and decreasing, increasing, decreasing. Okay, so the second type of murmur is also called as crescendo, decrescendo murmur. Sometimes in your medicine, this murmur is also called as what? This murmur is also called as ejection, systolic murmur, ejection, systolic murmur. Come on, students, tell me, this ejection systolic murmur is seen in which conditions? Sir, ejection systolic murmur. Ejection systolic murmur is seen in ejection systolic murmur or crescendo decrescendo murmur is seen with aortic stenosis, pulmonic stenosis, HOCM, hypertrophic obstructive cardiomyopathy, ASPS, HOCM, aortic stenosis, pulmonic stenosis, hypertrophic obstructive cardiomyopathy. In तीनों conditions, especially for your FMG exam, this is important. Hypertrophic obstructive cardiomyopathy is going to present with what? Crescendo decrescendo murmur. Okay, done. Next, this murmur is not needed for you. This murmur, the third murmur. Sir, tell me, this third murmur, it is seen during the diastole, that too the intensity of the murmur is decreasing. It is early decrescendo diastolic murmur. Early decrescendo diastolic murmur. Early blowing decrescendo diastolic murmur. Okay, so this murmur, right, the third murmur is early diastolic murmur. Okay, sometimes they will write early decrescendo diastolic murmur. It's the same thing, early diastolic murmur. Okay, early diastolic murmur. So tell me, early diastolic murmur is seen with which condition, sir? Early diastolic murmur. The early diastolic murmur is going to be seen with aortic regurgitation, pulmonic regurgitation. But never ever forget aortic regurgitation for your exam. This is 99% of the time they will ask you this. Early blowing decrescendo diastolic murmur, dancing carotids, Corrigan's pulse. They're all seen with the aortic regurgitation. Very famous. Oh, dancing carotid is going to be seen. Okay, Corrigan's pulse is going to be seen. Water hammer pulse is going to be seen. Early decrescendo diastolic murmur, aortic regurgitation. Okay, next, the fourth type of murmur. Okay, where the murmur is going to be seen during the systole as well as during the diastole. Systolic as well as diastolic. So it's a continuous machine-like murmur. Continuous or machine-like murmur seen with patent ductus arteriosus. Am I going to have patent ductus arteriosus right now? No, I am not going to have PDA right now. A child is going to have the PDA. So which child will have the PDA? Patent ductus arteriosus is seen in a child with congenital rubella syndrome, or you can say rubella infection with rubella. Okay, so if a baby is suffering with a congenital rubella infection in utero, so in the intrauterine life, if the baby gets the rubella from the mother to the baby, okay, so that is going to cause the patent ductus arteriosus, and the patent ductus arteriosus always going to present with continuous machinery like murmur due to the right to left shunting. The blood will shunt from right to left side, from the aorta into the pulmonary blood vessels. That is going to cause the continuous machinery like murmur. So repeat, if you see holosystolic murmur or pansystolic murmur, holosystolic or pansystolic murmurs are going to be seen with MR, TR, VSD. Crescendo decrescendo murmur, aortic stenosis, pulmonic stenosis, HOCM. Next, early blowing decrescendo diastolic murmur, early diastolic murmur, aortic regurgitation. Continuous machinery like murmur, patent ductus arteriosus seen with the congenital rubella syndrome. Next, sir, in different heart diseases, there will be different types of murmurs with a special names. For example, look at here, Carey-Coombs murmur. If you see this word Carey-Coombs murmur, Which heart condition? Acute rheumatic fever. You know, acute rheumatic fever due to beta hemolytic streptococci, that Jones criteria is going to be there. Okay, that molecular mimicry, M protein, you already know that. Okay, most commonly the mitral valve will be affected. Initially there will be mitral regurgitation followed by mitral stenosis. Okay, that one. Next, Austin Flint murmur. Sir, Austin Flint murmur is a murmur seen with aortic regurgitation. Next, Gibson's murmur. Gibson's murmur is nothing but the continuous machinery like murmur seen in patent ductus arteriosus. Just other name, PDA. So in PDA, you already know, no, continuous machinery like murmur is there. The same murmur is given a different name, that's it. These are special names, that's it, okay. Next, Graham-Still's murmur. Sir, Graham-Still's murmur is seen with the, Graham-Still's murmur is seen with pulmonary regurgitation. Graham-Still's murmur is seen with the pulmonary regurgitation. Okay. Next, Gallavadian phenomena. What is this Gallavadian phenomena? Come on, guys. What is this Gallavadian phenomena? Can anyone tell me? Gallavadian phenomena is seen with what? Come on, you have to tell me. Gallavadian phenomena is seen in which condition? First of all, you tell me in which condition it is seen. Later, I will tell you what is Gallavadian phenomena. Gallavadian phenomena is seen with, okay, aortic stenosis. What is this Gallavadian phenomena? What is this Gallavadian phenomena, sir? What is this Gallavadian phenomena? Gallavadian phenomena means it's a murmur radiating towards the apex of the heart. The murmur that is coming in the aortic stenosis, that will radiate towards the apex of the heart, and sometimes the murmur will also go to the axilla, towards the axilla. The murmur radiating towards one side, the murmur will radiate towards the apex as well as the axilla. Okay, so that is called as a Gallavadian phenomena. Gallavadian phenomena seen with aortic stenosis, where the murmur will radiate. Usually mitral murmurs, like, you know, the murmurs which are coming from the mitral valve will also radiate. But in aortic stenosis, the murmur will radiate towards the apex of the heart as well as the axilla. So that is called as a Gallavadian phenomena. Okay, murmur radiating towards axilla and apex. Okay, next, sir, where we have to hear this murmur? So you cannot keep the stethoscope here, right? When a patient comes, you have to keep the stethoscope in certain areas. Murmurs को auscultate करने के लिए, heart sounds को auscultate करने के लिए, you have to keep that stethoscope in certain areas. Which areas? So these are the areas. Sir, this is the right side of your body. Here is the left side of the body. What is this bone? Sternum. What is this imaginary line? Parasternal line. Right-sided parasternal line. Here is the left-sided parasternal line. And what is this bone? Clavicle. This one is the mid-clavicular line. Here is the mid-clavicular line. Okay, na? So tell me, what is this area? Right side, located in the second intercostal space. This is the first intercostal space. Here is the second intercostal space. So this area is the aortic valve area. Aortic valve area. Opposite to it, pulmonic valve area. Down to it, Erb's point. It is called as the Erb's point. Down to it, tricuspid area. And what is this area? Fifth intercostal space. So this is the fifth intercostal space. On the midclavicular line, on the left side, this is mitral area. Mitral area. So these are the different areas for the auscultation. These are the different areas for the auscultation. On the right side of the body, there is only aortic area. On the left side, 4 different areas are there. What are the 4 different areas? Pulmonic, Erb's point, tricuspid, mitral. So you can remember like PET-M or PTM. Okay, PTM is the no PTM. So PET, PET-M. Okay, so they will ask you to write the order from the top to the bottom, So pulmonic, Erb's point, tricuspid, mitral. Top to bottom on the left side. So here the areas are given. First area number 1 is aortic. Left side, PET, PET-M. Done. Okay. Next, what else you should know regarding these murmurs? See, all these murmurs, whenever you do Valsalva, you know Valsalva maneuver already. In medicine, you have studied Valsalva maneuver. And upon Valsalva maneuver and upon standing, all the murmurs in the physiology, all the murmurs in the medicine, they will go down. Okay, all murmurs have to decrease. Except two murmurs. What are these 2 murmurs, sir? HOCM murmur. Hey, tell me, HOCM murmur. Hypertrophic obstructive cardiomyopathy. What type of murmur is seen? HOCM crescendo, decrescendo murmur, CD murmur. That is right. Crescendo, decrescendo murmur. Have I taught you? Stop. Here I have taught you. Important also. HOCM murmur is a crescendo decrescendo murmur. Will it decrease upon standing? No, it will not decrease upon standing. It will not decrease upon Valsalva. It will decrease on squatting position. It will decrease on squatting position. Okay. So normally all the murmurs have to decrease upon standing. All the murmurs have to decrease upon doing the Valsalva murmur, except two murmurs. The murmur that is seen in the HOCM and the murmur that is seen in the mitral valve prolapse. In dono conditions mein, whatever the murmur that is there, whatever the murmur that is there, they will not decrease upon standing and Valsalva. Actually, they will increase. Tell me, HOCM murmur is a CD murmur, crescendo decrescendo murmur. What type of murmur is seen in the mitral valve prolapse? In a patient with a mitral valve prolapse, there is going to be a late systolic murmur. Rather than decreasing, they will increase. Done. Murmurs topic also completed. Okay. So here I have taught you important murmurs for your exam. Pansystolic, holosystolic murmur, crescendo decrescendo murmur, early decrescendo blowing. Okay, early diastolic murmur, blowing diastolic murmur, continuous machinery like murmur. Here are the different named murmurs, sir. Okay, here I have taught you important named murmurs, and these are the areas of the auscultation and exception. Okay, sir, can you tell me, am I going to get the mitral valve prolapse? Am I going to get mitral valve prolapse now? No. It is usually seen in diseases where there is connective tissue disorders. It is seen with the connective tissue disorders. For example, like mitral valve prolapse is going to be seen with Marfan syndrome. Okay, now Marfan syndrome. In Marfan syndrome, I always ask you to remember about the F. Marfan, F for fibrillin 1, FBN, fibrillin 1 gene defect. In Marfan syndrome, the fibrillin 1 gene is defective. Okay, autosomal dominant disorder. The recent NEET PG exam, this question was there. In Marfan syndrome, the fibrillin gene, FBN1 gene is defective, connective tissue disorder that will lead to mitral valve prolapse. Mitral valve prolapse is going to present with a late systolic murmur. Okay, done. Not only Marfan syndrome, even Ehlers-Danlos syndrome also going to present with the mitral valve prolapse. Done. So, what is the time right now? Sorry guys. So after discussing about the murmurs, okay, after discussing about the murmurs, now I will explain you the pulses also. Okay, see here, first let me explain you the pulses. After that, I will give you a small break. After explaining the pulses, I will give you the break. Okay, even I want the break. See, let me tell you, this is your arterial pulse. Let's say arterial pulse. In your blood vessels, see, this is basic. Sir, in your blood vessels, during systole, whenever the heart contracts, the blood pressure reaches to how much? Sir, 120 mmHg, you already know this, 120 mmHg. And during diastole, how much blood pressure is maintained in blood vessels? 80. So yes, in our arteries, the blood pressure during systole will be 120, during diastole will be 80. So blood pressure increases and later decreases to 80. 120, 80. Systole के time में 120 pressure, diastole के time में 80 pressure. Okay, so this is the normal pulse. So whenever 120 is coming, pressure is more or less. Yes, the pressure is more, then you can feel the pulse. Okay, so with every systole, with every contraction, the pressure in your radial artery increases to 120. So whenever the pressure is increasing, that you can feel it as a pulse. So this is normal, sir. This is how the wave is going to be. Pressure increases, during diastole decreases, during systole increases, and during diastole decreases. Okay, now look here. Okay, sir, it is increasing, okay, and it is decreasing, okay. But while decreasing, there is going to be a little notch. While decreasing, there is a little notch here. What is the name of this notch called as? Sir, the name of this notch, it is called as dicrotic notch. I can't go into the details why it will occur, but let me tell you, in your exam, if they ask you, the dicrotic notch is due to, why this dicrotic notch is happening? That dicrotic notch, it is due to the closure of which wall? That is due to the closure of aortic wall. Just this one thing you by heart. Okay, no? So dicrotic notch, the dicrotic notch that you see, that is due to what? That is due to the closure of the aortic wall. Aortic wall. Okay. Now, why you should know this for your exam is because this is the normal pulsar. Look, during systole pressure increases, later decreases. 120, 80. During systole 120, 80. During the diastole increases, decreases, increases, decreases, and usually there is a small notch called as what? Dicrotic notch, and that is normal. Sir, a good doctor, just by feeling the pulse, you can actually say what is something wrong with the heart. Okay, sir, here it is a normal pulse. Okay, but in some diseases there is going to be dicrotic pulse. Sir, what is this dicrotic pulse? Dicrotic means, see, normally with in one cardiac cycle, how many pulses will be there? One pulse you have to feel. But here, see, how many pulses you will feel? Sir, now you are going to feel twice beating pulse. You can feel the pulse 2 times within one cardiac cycle. So twice beating pulse, you can say. So dicrotic pulse. So tell me, dicrotic pulse is going to be seen with which condition? Sir, dicrotic pulse, just trust me. So dicrotic pulse is going to be seen with dilated cardiomyopathy. D for D. Dicrotic pulse, dilated cardiomyopathy. Okay, dilated cardiomyopathy. Next, bounding pulse. Sir, bounding pulse. What is the meaning of the bounding pulse? The bounding pulse meaning, see, bounding pulse meaning sharp rise in the pressure, sharp fall in the pressure. Sharp rise in the pressure, sharp fall in the pressure. So that sharp rise and sharp fall, sharp rise, sharp fall, that is called as the bounding pulse. That is seen with aortic regurgitation. Aortic regurgitation. Okay, aortic regurgitation. Next, then what is pulsus bisferiens, sir? Pulsus bisferiens. Pulsus bisferiens, okay, that is, look, again, 2 peaks are coming, 2 systolic peaks are coming with a dicrotic notch. 2 systolic peaks are coming with a dicrotic notch. But here, see, only 2 peaks without any dicrotic notch, or you can say, okay, here only you are seeing the 2 peaks, but here 2 systolic peaks are coming. Actually, here also, wait. This one is one systolic peak. Actually, to be frank, this is one systolic peak. Dicrotic notch, here this is the dicrotic notch, and this is the diastolic peak. Systolic peak, diastolic peak. Systolic peak, diastolic peak. But wait, here in the pulsus bisferiens, look, how many systolic peaks are coming? 2 systolic peaks are coming. See, 2 systolic peaks are there. So that pulsus bisferiens is going to be seen with HOCM, hypertrophic obstructive cardiomyopathy. Hypertrophic obstructive cardiomyopathy, pulsus bisferiens. Next, pulsus alternans. Pulsus alternans, not needed for you, just leave it. Next, pulsus paradoxus. Have I taught you? Sir, pulsus paradoxus. Sir, pulsus paradoxus means what? Pulsus paradoxus means the fall in the BP upon doing the inspiration. See, upon doing the inspiration, stop. Sir, upon doing the inspiration, see, the blood pressure is decreasing. Expiration ke time mein more blood pressure. Again, during the inspiration, there is fall in the BP. BP is falling. So the blood pressure is changing with inspiration, expiration. That too, during inspiration, blood pressure is falling more than 10 mmHg. Yes, that is pulsus paradoxus, seen with cardiac tamponade and constrictive pericarditis. Next, pulsus tardus et parvus. Sir, pulsus tardus et parvus. So this is also called as weak pulse or anacrotic pulse, also called as anacrotic pulse or slow pulse. Weak pulses, sir, cannot able to feel the pulse. So slow rising, slow falling pulse, slow rising, slow falling pulse. That is going to be seen with aortic stenosis. And last and final but important, the water hammer pulse also called as a Corrigan's pulse. Okay, Corrigan's pulse. That is, sir, a rapid pulse and there is a collapse. Okay, so here boundful, forceful, rapidly increasing and subsequently collapsing. Okay, rapidly increasing and subsequent collapse. Rapid increase, subsequent collapse. Rapid increase, subsequent collapse. So such type of pulse is called as Corrigan's pulse, seen with aortic regurgitation. So in different heart conditions, our pulses will change. Different heart conditions, our JVP will change. In different heart conditions, our auscultation, our murmurs will change. in different heart conditions, the EEG patterns will change. So if you know what is normal and abnormal, done for the exam. Okay, so that's it. Now if I am the examiner, do you know what I will give you? If I am the examiner, I will give this as an image based question, Corrigan's pulse. Okay, if I am the examiner, I will give this pulses bispherians as an image based question, means 2 systolic peaks with a dicrotic notch, 2 systolic peaks with a dicrotic notch, that's the pulses bispherians. Image based questions I will give you. Okay, because why? Because this is a PYQ. Previously also this questions has been asked. Okay, previously also this questions has been asked. They will give you this pattern and they will ask you what type of pulse, seen in which conditions. Okay, so that's it guys. So with this we have completed the abnormal pulses seen in which conditions. Okay, chalo, I hope the session is going good. You guys are able to like connect with me. If there is something which I need to change, please let me know. Okay, if you want me to change anything, please let me know. Let me also take a small break of 10 minutes. After that we will continue with the cardiac reflexes and remaining topics in the vascular physiology. Okay, mostly cardiac physiology important topics are completed. Later we will discuss the vascular physiology topics. Okay, okay, chalo, let's take 10 minutes break. 10 minutes break. Okay, guys, we are live again. Now let's continue with the cardiac reflexes. See, the importance of this rapid revision classes is, for example, okay, you guys haven't done your medicine. Okay, most of the students, they will leave the medicine big subjects, no, out of fear. Let's say, for example, okay, after a few days, Priyansar is going to take the medicine classes. For example, medicine rapid revision. Example, if it is 10 hours, 10 hours of rapid revision of medicine. So tell me, you still have almost 55 days, I think still 55 days is left. Okay, even if you do 2 hours of rapid revision every day, 2 hours of rapid revision of medicine every day, in how many days you can complete? Aram say you can complete the entire medicine in 5 days, 5 to 10 hours. Okay, in the same way, for example, gynae rapid revision. If gynae rapid revision, ops and gynae, if it is 10 hours, you can complete the entire, okay, gynae within 5 days. So that is the importance of this rapid revision classes. The entire subject with the important MCQs and PYQs will be completed in less amount of time. Okay, so if I am doing the entire physiology, it will take me 4-5 days of time to do the physiology in regular classes, 5 days of regular classes. But here we are doing it in somewhere around 7:30 to 8 hours. Okay, so that's the importance. If you haven't done physiology, if your friends haven't done their physiology, you can't do the entire video in one go. It is hard sitting here and like going through the entire 7 hours or 8 hours of video in one time. It is little hard. If you cannot do it at one stretch, do it in bits and pieces, like 2 hours in a day, 2 hours in a day, 2 hours in the morning, 2 hours in the evening. So done. 2 hours in the morning is very easy, 2 hours in the night easy. So in one day you can complete 4 hours. So in 2 days you can complete the entire rapid revision of physiology. See how easy it is. So follow those tricks. Don't try to sit and do the entire 10 hours of video in one stretch. It is a little hard. Okay, chalo. Anyway, now let's discuss about the cardiac reflexes. Cardiac reflexes. Now, what about the cardiac reflexes? See, there are 3 important cardiac reflexes which I want you to remember. 3 important cardiac reflexes which I want you to remember. The first one is called as the Cushing reflex. You have already studied this in your patho also. Cushing reflex and the Cushing reflex in your patho as well as medicine also. What is this Cushing reflex? Because of any reason, maybe because of some hematoma or maybe because of epidural hemorrhage or hydrocephalus, because of some reason, if your intracranial pressure increases, ICP, intracranial pressure increases. Whenever your intracranial pressure increases, ultimately because of multiple subsequent steps, intracranial pressure increases, less blood will go to the brain. Okay, a lot of things will occur. But at the end of the day, this rise in intracranial pressure ultimately activates the vagus nerve at the end. Vagus nerve will be activated. Okay, vagus nerve will be activated. Okay. Now when the vagus nerve is activated, okay, let me tell you the reason why the vagus nerve is activated. Here it's as it is important, let me tell you. Whenever your intracranial pressure increases, you tell me there is high pressure in the brain. Let's say in your skull there is high pressure. So tell me, do you think more blood will go or less blood will go? Less blood will go, sir. Your less blood is going. Because already here high pressure is there. Blood will always go from high pressure areas to low pressure areas. But whenever there is already high intracranial pressure, what will happen to the cerebral perfusion? Decreased cerebral perfusion. Decreased cerebral perfusion. Cerebral perfusion decrease ho gaya. Now you tell me, whenever there is a decreased cerebral perfusion, in order to supply the blood to the brain, what will happen to your BP? Sir, now your blood pressure increases. Now you are going to do the vasoconstriction and you are going to increase your BP. You are just increasing your BP, sir. Why? To supply the blood, to forcefully, if you are trying to increase the blood pressure, to send the blood to the brain. So now tell me, whenever your BP increases, the BP will be detected by the baroreceptors. So baroreceptors are activated. The baroreceptors are activated. Now you know baroreceptors are located in the arch of aorta and carotid sinus. Baroreceptors are there. What baroreceptors will do? Now baroreceptors will think, hey, there is so much BP in the body. The blood pressure increases, bad. So immediately as a reflex, now these baroreceptors, they will activate the vagus. The baroreceptors, they will activate the vagus now. Now the vagus nerve kya karega? Vagus nerve immediately decreases the heart rate. So in this patient, there is hypertension with bradycardia. hypertension with the bradycardia. So this is called as Cushing reflex. So Cushing reflex is going to be seen. Cushing reflex is going to be seen in a patient. Is going to be seen in a patient with high intracranial pressure. How the Cushing reflex is going to be the hypertension with the bradycardia. The word is important. Hypertension with bradycardia. Okay, this is called as a Cushing reflex. Okay, so next, after Cushing reflex, tell me, Cushing reflex, is it a bradycardic reflex or tachycardic reflex? BR stands for bradycardic reflex. It's a bradycardic reflex. Okay. Live में ads बंद कर सकते क्या? Like I don't know. Like even I don't know. Even see, while I'm playing here, even I'm getting the ads. Continuously ads are coming. But yeah. So next, sir. Next reflex is Bain-Bridge reflex. Sir, what is this Bain-Bridge reflex? In the bracket say I have written here TR. TR for what? It's the only tachycardic reflex. Bain-Bridge reflex is the only tachycardic reflex. Tachycardiac reflex. It's the only tachycardic reflex. Okay, only tachycardic reflex. All others are bradycardic. It's the only tachycardic reflex is the Bain-Bridge reflex. Stimulus. What is the stimulus, sir? See, whenever your blood volume increases, increase in your blood volume. See, let me make it easy for you. Whenever your blood volume increases, okay, na? Whenever your blood volume increases, tell me now there is more blood in the body, so more venous blood will come to the heart. So there is increased venous return. There is increased venous return to the heart. Whenever more blood is coming to the heart, there is going to be right atrial distension. Right atrial. This is important. Right atrial distension. Right atrial distension. So tell me, sir, whenever your blood volume increases, maybe because of, let's say, maybe because of high sodium chloride diet, you are eating more and more salt, so water will come from the cells into the blood. Okay, whatever might be the reason, maybe you are taking normal saline infusion, whatever might be the reason, whenever your blood volume is more, or you can say whenever the venous return to the heart increases, that is going to cause the right atrial distension. I am asking you tell me logically, whenever there is more blood in the body, the heart has to work more or less. Simple logic, no? Whenever there is more blood in the body, the heart has to work more. So I am just skipping all these things. So tell me, whenever the blood volume increases or whenever there is a right atrial distension, it meaning that there is more blood in the heart. So that is going to cause the tachycardia. The heart rate will be increased. So more the blood in the heart, whenever you stress your right atrium, whenever there is right atrial distension, okay. So actually there are receptors in the right atria. The receptors are there in the atria, sir, right atria. Okay. So in the right atria, the receptors will detect that, oh my God, there is right atrial distension, which means the more blood is there. Now from the atria, the information from the atria, this information will go to the brain with the help of the vagus nerve. The vagus nerve will take the information to the brain, which means there is more blood volume. Your brain will understand, okay, more blood volume. So brain is going to activate what? Sympathetic nerves to heart. So the sympathetic cardiac nerves are activated. So the sympathetic nerves releases epinephrine and heart rate is going to increase. So simple logic. The day you are having more blood, your heart has to beat more number of times. The more the blood in the body, the heart has to beat more number of times to keep the blood in the circulation. So that is called the Bain-Bridge reflex. Okay. So tell me, in Bain-Bridge reflex, what is the stimulus? Right atrial distension or increase in blood volume. What is the response? Increase in heart rate. Bradycardia na tachycardia na? It's a tachycardic reflex. Okay, the heart rate is increasing. Okay. Next, what is Basal-Jarris reflex? Sir, Basal-Jarris reflex is whenever the person is having myocardial infarction. Okay, myocardial infarction, or if you use certain chemicals like serotonin, veratridine. Okay, these chemicals. Now I am asking you, you think logically and tell me, whenever a person is having myocardial infarction, okay, this will become more easy for you. Your heart has to beat more number of times or less number of times. But sir, myocardial infarction, the heart is dying. Okay, you should not increase the work on the heart. You should not ask the heart to beat more number of times. So whenever there is myocardial infarction, or whenever you keep certain chemicals, whenever you use certain chemicals like serotonin, veratridine, your heart rate actually decreases. Okay, so that's why in MI patients always the heart rate is going to be less. Okay, so in a patient with myocardial infarction, you inject saline, heart rate increases. In a patient with MI, the heart rate is going to be less. So that reflex is going to be called as basal gyrus reflex because that's the body's protective mechanism. If there is MI, the heart rate should be less, not more. Okay, so yes, using chemicals like serotonin, veratridine or myocardial infarction is going to cause decrease in heart rate. How? See, whenever there is myocardial infarction in your heart, the vagus nerve will give this information to the brain. Okay, actually the vagus nerve afferent is vagus. Okay, not only afferent, if you want to know, afferent as well as efferent. That afferent nerve, the sensory nerve, as well as the motor nerve, efferent nerve is going to be vagus. Because you know vagus is a mixed cranial nerve. So vagus will take the information from the heart to brain. The heart is dying, there is something problem with the heart. There is something problem with the heart. So brain will understand, and brain is going to activate what? Brain is also again activating the motor vagal fibers, the efferent vagus. What vagus will do? Vagus is going to decrease the heart rate. So that is called as a basal gyrus reflex. So heart rate decreases and your BP will also decrease. Heart rate decreases, BP decreases. So this is called as basal gyrus reflex. Which of the following reflex is seen in the patient of MI? Basal gyrus reflex. Which of the following reflex is seen in a patient with the right atrial distension? Bain bridge reflex. Which of the following reflex is seen in a patient with a high intracranial pressure? Cushing reflex. In Cushing reflex, there is going to be hypertension with the bradycardia. Hypertension with the bradycardia is seen in Cushing reflex. Which of the following is a tachycardic reflex? The only tachycardic reflex, Bain bridge reflex. Which of the following reflex is seen in MI patient? Basal gyrus reflex. Heart is dying, give it work, bradycardia. More blood in the body, more work. That is a tachycardia. Bain bridge reflex. Okay, so chalo, done. With this successfully what we have completed, cardiac reflexes topic is completed. Now just worth telling you from your local classes. Okay, anyway your teachers would have already taught you. Just go through the baroreceptor reflex also. The baroreceptor reflex, where are the baroreceptors located? Baroreceptor reflex is an example of negative feedback reflex. Okay, so that and all you can go through your local notes, like the note your regular notes. I have taught you what is most important for your exam. Okay, chalo, done. After this, now let's discuss about some vascular physiology topics. Vascular physiology. Sir, Poiseuille-Higgins formula. Okay, Poiseuille-Higgins formula. So what is this Poiseuille-Higgins formula? Okay, what is the Poiseuille-Higgins formula? Sir, Poiseuille-Higgins formula is telling me that the blood flow means what? Blood flow means Q. Blood flow is dependent on what? The flow of blood within the blood vessel is dependent on four things. It is dependent on pressure difference and radius to the power of 4, but inversely proportional to what? Inversely proportional to length and viscosity. The blood flow within a blood vessel, there is going to be a streamlined flow, also called as a laminar flow. The flow of a blood is dependent on four things. How much blood is going? More blood, less blood. It is dependent on 4 parameters. Blood flow is directly proportional to the radius and pressure difference, but inversely proportional to length and viscosity. For example, look at the questions. If the radius of the blood vessel is doubled, means the radius of the blood vessel is doubled. Now, if the radius of the blood vessel is doubled, what do you think? More blood will go or less blood can go? More blood can go. How much more blood can go? Sir, look, blood flow is directly proportional to radius to the power of 4. Now, what I have done with the radius? 2 to the power of 4, double the radius. 2 to the power of 4 means 16 times. 16 times. When the radius of the blood vessel is doubled, 16 times more blood will go. Not double times. Usually what students will think, sir, double the radius, double the blood flow. No. When you double the radius, the blood flow is not doubled. Blood flow increases by 16 times. In the same way, when the radius of the blood vessel triples, so that is blood flow directly proportional to 3 to the power of 4. 3 to the power of 4 means triple the radius. So 3 to the power of 4, how much? 81 times. 81 times. So doubling the radius, 16 times blood flow. Tripling the radius, 81 times more blood will go. 81 times more blood will go. Okay. So this is what I want you to know. Next, apart from this, what else you should know for your exam, sir, is when you donate an organ, for example, what happens to vascular resistance, and what happens to vascular resistance and cardiac output in patient with donated kidney. Imagine you have donated your kidney for your girlfriend. Okay, you have donated your kidney for the girlfriend. Okay, your girlfriend is having some trouble. You have donated her kidney. Okay, or maybe she asked you for iPhone 17 Pro Max. So, being a good, okay, boyfriend, you have donated your kidney. So now tell me, whenever you donate your kidney, what happened to your cardiac output? Increase or decrease? And what happened to your vascular resistance? Increase or decrease? Come on, tell me. What do you think will happen to your cardiac output and vascular resistance? Okay, chalo. Now try to understand like this. This is the left ventricle. Here is the left ventricle. Now from the left ventricle, what is coming? Sir, here is the aorta. Okay, here is the aorta. So from the aorta, these are the multiple blood vessels, different arteries coming. Okay, these are the different arteries coming. So some like one is a carotid artery, one is a radial artery, one is ulnar artery, one is a renal artery, one is different arteries. Different arteries are there. Now let me put it this way. Let me make it easy for you. Imagine this is your college. Here is your college. We are all studying in the college. Okay, let's say this is our college. Now, once the class is completed, once the college is completed, where we will go? We will go on to the road. Okay, we will come on to the road, and from this road, we will take different streets. We will take different streets to go to our destination. We will go to our homes. We will all go to our homes. Yes or no? So today, what happened is, in one of the road there is an accident. So tell me, whenever there is an accident, now what will happen to the traffic in the other roads? Now tell me, what will happen to the traffic in the other roads? So the traffic in the other roads will increase. Yes or no? Because now even these people, they will take different roads to go to their homes. So now tell me, whenever there is an accident, the students which were supposed to go through this road, the students who were supposed to use this road, now they will be diverted. So now tell me, what happened to the traffic in the other roads? Now the traffic in the other roads is going to increase. Yes or no? So now tell me. Sir, I am asking you, whenever there is congestion here, whenever there is traffic jam, for you, is it easy to go through these roads or is it difficult for you to go through these roads? It is very difficult for you to use these roads because already there is a traffic jam. The traffic is going very slowly. So can I say the resistance here increases or decreases? Sir, here there is more resistance. Resistance is going to be more. There is going to be more resistance because the whole students are using only these two roads to go to their destination. So in the same way, apply the same logic. Sir, what are we doing? We are removing a kidney. We have removed the kidney. So when I have removed the kidney, I have ligated the renal vasculature. The renal blood vessels are ligated. So tell me, in our body, whenever the renal blood vessels are ligated, so the blood which was supposed to go to this kidney, now the blood is using a different route. Now the blood is going through the different blood vessels. So yes, vascular resistance also going to be more. Now more blood, but less number of blood vessels. Now more blood is there, but number of blood vessels decreased. So vascular resistance, there is more resistance for the flow of blood. So tell me, whenever there is more the resistance, do you think the heart can pump the blood easily? No, because there is more resistance, more back pressures are there. So the cardiac output also decreases. So tell me, in a patient who has donated imagine you are the one, you have donated your kidney. So your vascular resistance increases, cardiac output decreases. So this was a famous question which was asked many times in the exams. Okay, so just know it. Done. With this, what we have completed? We have completed the vascular physiology important points also. Chalo, I'm not going to the details of the clotting cascade, because anyway you will do that clotting cascade in the pathology, that intrinsic pathway, extrinsic pathway, common pathway, what is PT, PTT, INR. Okay, you will do that in your pathology. Chalo, let's continue. Next, respiratory physiology. Sir, let's try to complete the respiratory physiology in as fast as possible. Only I will be discussing about the important points. Sir, in respiratory physiology, I will be discussing first about the surfactant. First take the heading surfactant, because surfactant is the most important topic. Surfactant. Okay, surfactant. Now, surfactant is produced from where? Sir, surfactant, it is produced from the type 2 pneumocytes. Repeatedly asked MCQ. Surfactant is produced from Type 2 pneumocytes. When from 20 weeks of period of gestation, means even before the birth, surfactant production started, and maximum levels of surfactant reaches by somewhere around 20 weeks of period of 34 weeks of period of gestation. Surfactant is good. Why surfactant is good? Because this chemical called as a surfactant, it decreases the surface tension in our lungs. क्या करेगा sir? It decreases the surface tension in our lungs. Surface tension is a bad force. It is a collapsing force. It will try to collapse my lungs. तो surfactant क्या करेगा sir? Surfactant surface tension को decrease करेगा, lung collapse को prevent करेगा. It prevents the lung collapse. Okay, but I want to know whether the fetal lungs are matured or not. So what are the tests? Right. Assessment for fetal lung maturity. I want to know whether the fetal lungs are matured or not. So what I have to do? I have to check the surfactant levels in the fetal lung. Can I directly check the surfactant levels in the fetal lungs? No, I cannot do that. Then what I have to do? I have to perform amniocentesis. Now what am I doing? Now I am doing amniocentesis. Amniocentesis, why? Because you have already studied amniotic fluid goes into the fetal lungs, comes out of the fetal lungs. Amniotic fluid goes into the fetal lungs, comes out of the fetal lungs. So in the amniotic fluid, now I am going to check for the levels of lecithin and sphingomyelin. See, what are these, sir? Lecithin and sphingomyelin, these are nothing but the surfactant lipids. So if the lecithin to sphingomyelin ratio, if it is more than 2, it indicates fetal lung maturity. So tell me, what indicates the fetal lung maturity? If the lecithin sphingomyelin ratio, if the value is greater than 2, it indicates fetal lungs are matured. Okay, this is the only thing which I want you to know for your exam. Lecithin sphingomyelin ratio greater than 2 indicates fetal lung maturity. Other tests also there, not needed for you. Next, sir, what is the best test for the fetal lung maturity? Sir, best test for fetal lung maturity, not the lecithin sphingomyelin ratio. You already know lecithin sphingomyelin ratio greater than 2 indicates the fetal lung maturity. But what is the best test for the fetal lung maturity? The best test is checking the levels of phosphatidylglycerol in the amniotic fluid. The levels of the phosphatidylglycerol in the amniotic fluid is the best test for the fetal lung maturity. Next, surfactant is stimulated by. Sir, surfactant production is stimulated by. Who increases the surfactant? Glucocorticoids, thyroid hormones. Instead of glucocorticoids, you can write here steroids. Steroid hormones increases the surfactant production. Thyroid hormones are good. Thyroid hormones also increase the surfactant production. But who decreases the surfactant production? Surfactant production is inhibited by. Sir, inhibited by means bad. Someone is trying to decrease. Inhibited by. Surfactant production is inhibited by. The answer is insulin. Insulin. So insulin is bad because insulin always decreases the surfactant. Insulin decreases the surfactant. So imagine, sir, here there is a mother. Look, here there is a mother. Happy mother. Why she is happy? Because she is pregnant. Okay. She is pregnant. Now, but she got one problem. What is her problem? Is she developed gestational diabetes mellitus. Gestational diabetes mellitus. She is getting the GDM during her pregnancy. Now tell me, whenever she is getting the gestational diabetes mellitus, what happened to her blood glucose levels? Sir, her blood glucose levels are going to become more. Now tell me, where do you think this extra glucose is going to go? This extra glucose is going to the baby. Now I am asking you, whenever the baby is getting this extra glucose, you already know the baby is going to grow big. There is going to be macrosomia of the baby. I am not concerned about that right now. I am concerned about when extra glucose going to this baby. Sir, this baby is going to produce more insulin. Now you tell me, whenever there is more insulin production, insulin क्या करेगा? Insulin is going to decrease surfactant production. Insulin क्या करेगा, sir? Insulin is going to decrease the surfactant production. So the insulin will decrease the surfactant production in this baby. So now tell me, there is no surfactant in the fetal lungs. Without the surfactant, the baby's fetal lungs are matured. No, then the baby's fetal lungs are not going to be matured. So that will lead to respiratory distress syndrome. So that condition is called as, see, the mothers who suffer with the gestational diabetes mellitus, they will give birth to the baby who will suffer with respiratory distress syndrome, also called as hyaline membrane disease. So tell me, respiratory distress syndrome, also called as what? Hyaline membrane disease. It is due to less amount of surfactant. And which hormone is the culprit here? The culprit hormone here in this condition is insulin. Insulin is always bad. More insulin, less surfactant. Surfactant नहीं है तो more surface tension. Surface tension क्या करेगा? Fetal lungs को collapse करेगा. Okay, so surfactant topic is very important for your exams. Okay, so if I ask you, what is the major cause of respiratory distress syndrome? The major cause of the respiratory distress syndrome is deficiency of surfactant. Which hormone is responsible for that? Insulin. Insulin always bad for the fetal lungs. Okay, chalo done. Next, in the respiratory physiology, the next most important topic which I want you to know is this lung volumes and capacities. Lung volumes and capacities. Lung volumes and capacities. Sir, in the lung volumes and capacities, they will show you this spirometry graph. Okay, many times this question has been asked. They will show you this spirometry graph and they will ask you, sir, what is this area that I am highlighting here? This area, sir, that is inspiration, expiration, inspiration, expiration, inspiration, expiration. So these are your tidal volumes. Tidal volumes. Usually it is somewhere around how much ml, sir? 500 ml. 500 ml. And what is this area which I am highlighting right now in the blue color? Sir, ye kya hai, sir? What is this area which I am highlighting? So this is inspiratory reserve volume. That means the extra air that you can take. Normally 500 in, 500 out. 500 in, 500 out. But that extra air that you can take in with a deep inspiration, that is called as inspiratory reserve volume. It is somewhere around 3000 ml. 3000 ml. And the extra air that you can take out, this is called as what? This is called as expiratory reserve volume. It is somewhere around 1200 ml. 1200 ml. Okay, 1200 ml. And whatever you do, how much ever you try, some air will never come out of the lungs. Some air will never leave the lungs. That is called as residual volume. That is called as what? Residual volume. How much is the residual volume? 1300 ml. 1300 ml. Okay, 1300 ml. So these are the different volumes. Different volumes I have highlighted here. Repeat again. Tidal volume, inspiratory reserve volume, expiratory reserve volume, residual volume. These are the 4 volumes. Now tell me, then what is this line that I am drawing here? This area which I am drawing. Tell me, what is this area that I am drawing here? What is this line, sir? So it includes, see, this line includes tidal volume plus inspiratory reserve volume. Tidal volume plus inspiratory reserve volume. This blue color. This includes the inspiratory capacity. So this one is your inspiratory capacity. Means the capacity of your inspiration. First tidal volume, inspiratory reserve volume. How much is the inspiratory capacity? Inspiratory capacity is somewhere around 3500 ml. 3500 ml. Next, sir, after quiet expiration, see, after quiet expiration, you know, this is a quiet expiratory point. After doing normal expiration, how much air is left over in your lungs? This is the amount of air that is left over in your lungs, including expiratory reserve volume plus residual volume. After normal expiration, how much air is left over in your lungs? That is including residual volume plus expiratory reserve volume. How much is that? That is called as functional residual capacity. Somewhere around 2500 ml. So this was a famous FMGE question. So this question, they will draw this line, and they will ask you, what is this line representing? Functional residual capacity 2500 ml. Okay, functional residual capacity of 2500 ml. Next, chalo. Next, sir, after taking the maximum inspiration, this is the maximum inspiratory point, no? After doing the maximum inspiration, how much air you can take out? See, I am the doctor, you are my patient, I am asking you, take as much air as possible. Maximum. After doing the maximum inspiration, how much air you can take out? Sir, you can take out inspiratory reserve volume, you can take out tidal volume, even you can remove expiratory reserve volume. So from the top till here, what is this red color line representing? So this is the maximum air that you can take out of your lung. This is the maximum air that you can take out of your lung. So this one is called as your vital capacity. Okay, this is your vital capacity, which will be somewhere around 4700 ml. Vital capacity. Okay, vital capacity. This red color line is representing what? So here this red color line is representing the vital capacity, somewhere around 4700 ml. If you add all the volumes together from the top till to the bottom, that is called as total lung capacity. Total lung capacity. How much is the total lung capacity? So the total lung capacity is somewhere around 6 liters. 6 liters. So, sir, if the examiner is a good person, let's say, if they don't want to trouble you, they will simply ask, okay, they will give you this diagram and they will mark the areas and they will ask you to identify tidal volume, inspiratory reserve volume, expiratory reserve volume, residual volume, functional residual capacity, total lung capacity, vital capacity, inspiratory capacity. They will ask and they will mark and they will ask you which of the following is shown. Okay, simple. Now, from this topic, some single liner questions are also there. What are they, sir? Which lung volumes and capacities cannot be measured. Which lung volumes and capacities cannot be measured with spirometry? With a spirometry study, with a normal typical spirometry study, you know the spirometry study, which lung volumes and capacity cannot be measured? Say you can never calculate the residual volume because it will never come out. Residual volume cannot be calculated because residual volume will never leave the lungs, it will never come out. If it is not coming out, then how will you know how much is the residual volume? Next one, functional residual capacity. Because I have taught you functional residual capacity. See, functional residual capacity, it is the sum of residual volume plus expiratory reserve volume. Without knowing the residual volume, you cannot calculate the functional residual capacity. So yes, functional residual capacity. And last one, total lung capacity. Total lung capacity is the sum of all the volumes. Without knowing the residual volume, even you cannot calculate the total lung capacity. So these two capacities and one volume cannot be measured with the spirometry. Then how to measure them? There is a technique. What is that? The gold standard technique is called as body plethysmography. Body plethysmography. The gold standard technique for the measurement of this functional residual capacity or the total lung capacity is body plethysmography. Already asked in the exam. Gold standard technique. The gold standard method for the measurement of this functional residual capacity. This question was asked. Body plethysmography. Done? Chalo. Next, after this, let's discuss about the flow volume loops. Sir, in this diagram, I am showing you the normal flow volume loop, right? This is the normal flow volume loop. Sir, what I am showing here in this normal flow volume loop, what you should know is here this bottom, this line which I am highlighting. So this is the inspiration, this is your inspiration. And here is what? Here is your expiration, inspiration, expiration. During your inspiration, see, during your inspiration, you are inspiring up to how much air, sir? Up to total lung capacity, 6 liters. Almost, see, from 1.3 liters, because already 1.3 is already there in your lungs. From 1.3 liters, how much air you are taking? Almost 6 liters. This is the total lung capacity points, 6 liters. And during expiration, how much maximum air you can take out? You are taking out from 6 liters back to 1.3 liters. So this is normal inspiration, expiration. In one graph I am showing you inspiration and expiration. This is normal. But how the question will come in your exam? No, sir, in certain diseases, this flow volume loop, it will change. It will become abnormal. For example, look, sir, in this condition, normal person has to start the inspiration from where? Normal person has to start the inspiration from 1.3 liters. And how much maximum air he will get? 6. But see, in this condition, sir, what happened? He is starting his inspiration from 2.5 liters, which means the residual volume increases in this person. Residual volume increased. And what happened to his total lung capacity? Total lung capacity also increased, sir. So tell me, sir, in this fellow, what happened is the graph is shifting more towards the left side. See the values from 1.3 it is shifting to 2.5. And from 6 liters it is shifting to total 7 liters. So the graph is shifting towards the left side. Residual volume increases, total lung capacity increases. So what is this disease? They will ask you. Image based question. So this is obstructive lung disease. Classical example is emphysema. Okay. So there is going to be which shift? Left shift. So the flow volume loops are going to shift towards the left side in obstructive lung diseases. So how the question will come? Just image based question, and they will ask you to identify. If you see the left shift, okay, see the graph is shifting more towards the left side. You can see normal person it has to start from 1.3 liters and end at 6 liters. But here it is shifting to the values are shifting towards left. But exactly opposite. Look here, normal person inspiration should start from 1.3 liters and end at 6 liters. But here the values are shifting more towards the right side. The values are shifting more towards the right side. So yes, there is a right shift of the flow volume loop. The flow volume loop is shifting towards the right side. So R for R. So right shift is going to be seen with restrictive lung diseases. Classical example, emphysema. So in emphysema, there is going to be right shift. In a not emphysema. It is pulmonary fibrosis. Pulmonary fibrosis. Okay, tell me how the flow volume loops are going to shift. In emphysema, there is going to be left shift of the flow volume loop. In pulmonary fibrosis, the flow volume loops are going to be shift to right side. How to remember this for your exam? R for R. Right shift is seen in restrictive lung diseases. Right shift, restrictive lung diseases. What happened to the residual volume in this condition? Sir, the residual volume decreased. What happened to the total lung capacity? Total lung capacity decreases. See, exactly opposite, no? In obstructive lung diseases, the lung volumes and capacities increases. In restrictive lung diseases, the lung volumes and capacities decreases. Okay, that's the difference. Next, after that, sir, what you are seeing here in this page, what you have to learn, okay, sir, FeV1 by FVC ratios, FeV1 by FVC ratios, okay. Normal person may tell me, sir, first one is normal, take the heading normal, take the heading normal. Sir, in a normal person like you and me, I am asking you to do the expression. Do the expression. See, I am doing the expression. See, maybe I am doing the expression for how many seconds? 5 seconds. Okay, na? So I have done the expression for how many seconds? 5 seconds. In 5 seconds, how much air has came out of my lungs? Sir, almost 5 liters of air came out. 5 seconds, maybe it is 5 seconds or 6 seconds, 7 seconds, doesn't matter. How much air came out? 5 liters of air came out. So this 5 liters is called as forced vital capacity. Forced vital capacity. Array, you already know how much air you can take out of your lungs. 4700 ml, that is the vital capacity. If you are taking it out forcefully, that is called as a forced vital capacity, approximately 5 liters. If you want to know exactly 4700 ml. Okay, so tell me how much maximum air you can take out of the lungs? 5 liters. Specifically 4700 ml. Okay. But in the first second, see, in the first second, how much air came out? Sorry, in a normal individual, in 1 second, almost 4 liters air came out. 4 liters air came out. That is called as FeV1. Aha, okay. So FVC in this condition is 5 liters. FeV1 is 4 liters. So 4 divided by 5, that is FeV1 by FVC. 4 out of 5, that is 0.8, which means I can say, sir, I will take out 80% of the air within 1 second. Healthy individual like me and you, we can take out 80% of the air out of the lungs within 1 second. That is 0.8, the ratio. Out of 5 liters, 4 liters is coming out within 1 second. 1 second. Okay. That is normal FeV1 by FVC ratio. But what about obstructive lung diseases? Sir, obstructive lung disease / smoker / emphysema. Emphysema. Sir, in this emphysema fellows, what happens? This is OLD, obstructive lung disease. Now, when I ask him to do the expiration, take the air out. Sir, normal FVC is how much? 5 liters. But in this fellow, FVC almost 5 liters. No, almost normal or maybe reduced. Normal or maybe reduced. Now I am not happy. Sir, my FVC is 5 liters. The smoker fellow FVC is also 5 liters. How it can be like fair, sir? This is unfair. I can take out 5 liters of air. Even the smoker fellow also taking out almost normal 5 liters of air out. I am not happy. There is a difference. There is a difference where the FVC is not much different, but look at the FeV1. Normal individual is taking out how many liters of air? 4 liters of air within 1 second. But in obstructive lung diseases, he is only taking out 1.5 liters of air. Means air is not coming out easily. Expiratory problem. Sir, here his FeV1, right? FeV1 in this condition is only 1.5 liters. So tell me 1.5 divided by 5. Definitely value will be less than 0.8. Normal is 0.8. Here definitely the value will be less than 0.8. If the value becomes less than 0.7, if the value becomes less than 0.7, I can 100% say this is the diagnosis for 100% the diagnosis for obstructive lung disease. So tell me, what is the criteria to say that you are having obstructive lung disease? Your FeV1 by FVC ratio should be less than 0.7. FeV1 by FVC ratio less than 0.7 is indicative of obstructive lung diseases or emphysema. Okay. Next, what about, just make a small correction here, make it 2.5, just make a small correction, 2.5. Next, restrictive lung disease, RLD, restrictive lung disease. So here, sir, this one, restrictive lung disease. Now, when I take this patient with restrictive lung disease or pulmonary fibrosis, look carefully, pulmonary fibrosis. Okay. I am asking him to do the expiration, this fellow, pulmonary fibrosis fellow, to do the expiration. expiration. See, this is how the graph is going to be. This is how the pink color graph is coming. Tell me, normal FVC is how many liters? 5. Normal FEV1 is how many liters? 4. That is normal. That is normal. But see, in RLD patient, FVC is how much? FVC is decreased to 3 liters. What about the FEV1? FEV1 is 2.5 liters. So yes, FVC is reduced as well as FEV1 also reduced. Both FVC as well as FEV1 both are reduced proportionately. So right, FVC reduced. Okay, FEV1 also reduced. So now tell me the FEV1 by FVC ratio. FEV1 by FVC ratio, that is 2.5 divided by 3. 2.5 divided by 3, how much? Approximately 0.8. 0.8 something it will come, 0.83 something it will come. So this is normal. This is normal, or maybe slightly increased, slightly increased. So now my question to you, tell me, what is the normal FEV1 by FVC ratio? So the normal FEV1 by FVC ratio in a normal individual like you and me is going to be 0.8. But in obstructive lung diseases, to say that you are having obstructive lung disease, your FEV1 by FVC ratio should be less than 0.7. And how it will change in the restrictive lung diseases? In restrictive lung diseases, the FEV1 by FVC ratio is going to be normal or slightly increased. Normal or slightly increased. Okay. So this is how to put the diagnosis for FEV1 by FVC ratios, like obstructive versus restrictive lung diseases. Now let me ask you a question which was already asked in the FMGE exam. Now you tell me, sir, here is your patient whose FVC is decreased, FEV1 also decreased. So tell me, is he suffering with obstructive or restrictive? Sir, FVC is reduced as well as FEV1 is also reduced. FVC is reduced as well as FEV1 also reduced. So tell me, is he suffering with obstructive or restrictive? Is it obstructive lung disease or restrictive lung disease? You have to say cannot be determined. Because you know FVC is reduced, FEV1 is reduced. Yes, FVC can be decreased in obstructive lung diseases as well as restrictive lung diseases. FEV1, it is decreased in obstructive as well as restrictive lung diseases. See, you should never ever say obstructive versus restrictive based on FVC and FEV1. You have to check, always calculate FEV1 by FVC ratio. If the ratio is less than 0.7, obstructive lung disease. Okay. So always check for what? Always check for the FEV1 by FVC ratios. Just by looking at the FVC and FEV1, you can never say that whether the patient is having obstructive pattern or restrictive pattern. Okay, clear? So this is what I want you to know for your exam. Guys, my phone got switched off, so I cannot able to read your comments from now. So we'll go, I will try to keep it charged. Okay, keep it charged. Started? Chalo. Guys, after discussing the FEV1 by FVC ratios, the next important topic that you should know in your respiratory physiology is this ventilation perfusion ratios. Okay, the ventilation perfusion ratios. Now I am asking you, see, ventilation is going into your alveolus, air is going into the alveolus. Yes sir, air is going to our alveolus. How much? Let me tell you, you don't know. 4 liters of air will go into our alveolus every minute. 1 minute में how much air do you know will go into our alveolus? 4 liters will go. And do you know how much blood will go to the alveolus every minute? 5 liters. You already know cardiac output from the right side of the heart, 5 liters of blood will go to the lungs. So tell me, how much is the ventilation? 4 liters. How much is the blood flow? 5 liters. 4 liters of air will go and 5 liters of blood will go. Ventilation by perfusion. So tell me, what is the normal ventilation perfusion ratio in our lungs? So the normal ventilation perfusion ratio in our lungs is again 0.8. FE1 by FEC ratio 0.8, ventilation perfusion ratio also 0.8. Okay, that is a different topic, this is a different topic, but anyway, ventilation perfusion ratio in our lung is 0.8. Now, in this topic, sir, ventilation perfusion ratios, what are we going to study actually? No, you know what are we going to study actually? See, we are going to discuss about the differences between the apex of the lung, how the apex of the lung is different from the base of the lung. What are the differences between apical lobes of the lung and the basal lobes of the lung? Apex of the lung and base of the lung, are they same? No, some differences are there. What are the differences, sir? Let me tell you. See, for example, look here, what is the size of the alveoli? Big alveoli, the size of the alveoli is very big. And what is the size of the alveoli here in the base of the lung? The size of the alveoli are very small. So yes, some differences are there. First look at the apex. Take the heading, apex. Sir, in the apex of the lung, look at the blood flow, look at the perfusion. Sir, in the apex, the blood vessels are these alveoli, you know what they will do? Sir, these alveoli, big alveoli, they will compress the blood vessels. So the blood vessels have maximum resistance. There is more vascular resistance. So there less blood will go to the apex of the lung. Okay. So to the apex of the lung, more blood do you think will go or less blood do you think will go? Less blood will go. Okay. So right, in the apex of the lung, there is a maximum resistance, higher resistance for the blood flow. So less blood is going to the apex of the lung. Okay. Then what about the ventilation? How it is different? Sir, ventilation, the alveoli are larger, very big alveoli are there. See, but they are less compliant. Compliant meaning stretchability. Compliance meaning stretch. Sir, alveoli are large, okay, but they do not expand. Sir, the more they expand, the more air they will get. But if they are static just like that, they don't get any ventilation. They have to expand to get more air. So they are less compliant, non-stretchable, so less ventilation. To the apex of the lung, ventilation ही नहीं है. So now tell me, in the apex of the lung में ventilation is less as well as perfusion is less. Both are less. So right, in the apex of the lung, both ventilation and perfusion, V and Q, both ventilation and perfusion are least. Both are least. Ventilation is less as well as the perfusion is less. Tell me, to the apex of the lung, any blood is going? Sir, to the apex of the lung, any blood is going? No, blood is not going. There is maximum resistance, so less blood flow. So now I am asking you, do you think whatever the oxygen that is present over here, will it be ever exchanged? No, oxygen is not going to be exchanged. Okay, so there is less gas exchange, so there is more oxygen availability. So there is high oxygen available. Here the blood is not coming, so carbon dioxide is not coming to this area. Actually, the blood will release the carbon dioxide, no? So in the apex of the lung, zyada oxygen hai, carbon dioxide nahi hai. So right, sir, in the apex of the lung, in the upper lobes, there is more availability of the oxygen. So who loves the oxygen? TB infection. TB, Mycobacterium tuberculosis, loves oxygen. So TB mainly affects the upper lobes of the lung. Because there is more oxygen availability. Okay. So yes. So tell me, apex, large alveoli, non-compliant alveoli, less ventilation, less perfusion, less gas exchange, more oxygen availability, low carbon dioxide levels. The apex. Then what about the base of the lung? Then the base of the lung, look carefully. Perfusion. The blood vessels are having less resistance. Wide blood vessels are there. So more blood will go to the base. To the base of the lung, more blood will go. Okay, because of the gravity, because of the less resistance, more blood will go to the base of the lung. Then what about the ventilation? Sir, alveoli, first of all, they are smaller in size. Alveoli smaller. But sir, they are more compliant, more stretchable alveoli. They will stretch more. They will get more air. So more ventilation. Stop. So now tell me, in the base of the lung, ventilation is more as well as perfusion is more. Both ventilation, perfusion are maximum in the base of the lung. Okay. So right, in the base of the lung, both ventilation and perfusion are maximum. Both are maximum. Okay. Both are maximum in the base. Next. Sir, as more blood is going here to the base of the lung, as more blood will go, so there is more gas exchange. More gases will be exchanged. So these are some important differences between apex of the lung to the base of the lung. Okay, ventilation wise, perfusion wise, the apex of the lung is different from the base of the lung. Now tell me, what is the normal ventilation perfusion ratio of the entire lungs, both the lungs together? Sir, the ventilation perfusion ratio, 4 liters of air is going, 4 liters of air will go, and 5 liters of blood will go to our lungs. So normal ventilation perfusion ratio is 0.8. But apex mein thoda difference hai, sir. Base mein some differences are there. So that's why there sorry. So that's why the ventilation perfusion ratios in the apex of the lung and base of the lung are also different, not 0.8. If they specifically ask you, the ventilation perfusion ratio in the apex of the lung is 3.2, the base of the lung, the value is 0.6. Just by heart this value. Okay, ventilation perfusion ratio of the normal lung is 0.8. In the apex of the lung it is 3.2. In the base of the lung it is 0.6. Okay. Now, in some conditions, the ventilation perfusion ratio V by Q, ventilation perfusion ratio becomes infinitive. In some conditions, the ventilation perfusion ratio becomes 0. Which conditions, sir? In kaun se conditions mein, in which conditions mein the ventilation perfusion ratio is going to be infinitive? Infinitive in 2 conditions. 2 conditions you have to remember for your exam, that is pulmonary embolism, dead space, anatomical dead space. In dono conditions mein, that is a pulmonary embolism and anatomical dead space, in these 2 conditions, okay, in these 2 conditions, the ventilation perfusion ratio is going to be infinitive. Okay, I hope you have already studied this because I can't go into the details why it is infinitive. If you want me to go, just I will explain under 1 minute. For example, see, for example, pulmonary embolism. Try to understand like this. Pulmonary embolism. First of all, have I taught you? Look at here. Imagine this is your alveolus. Okay, here is your lung. Here is a blood vessel, pulmonary artery, or pulmonary blood vessel, you can say. Normally, tell me how many liters of air should come? 4 liters of air should come. Okay, na? So 4 liters of air should come. And how many liters of blood should go? 5 liters of blood should go. 4 liters of air for gas exchange and 5 liters of blood should go for the gas exchange. Okay. Now you tell me, whenever there is a pulmonary embolism, iska meaning kya hai sir? Pulmonary embolism meaning there is a clot here. There is a clot. Now you tell me, whenever there is a clot, do you think the blood can go to the lung? No, the blood cannot go to the lung, sir. Now there is no chance that the blood can go to the lungs. So wait, 5 liters of blood is not going. So how much blood is going? 0. 0 ho gaya. So now tell me, 4 divided by 0 how much? Sir, 4 divided by 0 is going to be infinitive. So yes, in a patient with a pulmonary embolism, the ventilation perfusion ratio is going to be infinitive because the blood is not going and this air got wasted. Waste ho gaya. Waste ho gaya. This ventilation waste ho gaya, sir, because the blood is not going. So ventilation is wasted. So that's why here I have written infinitive ka meaning kya hai? The word infinitive meaning wasted ventilation. Waste ho gaya because blood is not going. In the same way, in some conditions, the ventilation perfusion ratio will become 0. In which condition? Foreign body obstruction. You know, a child who is playing with a 1 rupee coin or a small toy truck. Okay, accidentally the foreign body got lodged in the respiratory tract where the ventilation cannot happen. Ventilation cannot happen. So in a patient with a foreign body obstruction, okay, just let me make it easy for you. Imagine here is your respiratory tract, here is your airway, here is your alveoli. Okay, in the small child, what happened today? Today there is a foreign body obstruction. Okay, completely this airway got obstructed with a 1 rupee coin, let's say 1 rupee or 1 paisa coin. Okay, so what happened today? Do you think the air can go into the alveolus? No, ventilation 0 ho gaya. What about the blood flow? As usual, blood flow, 5 liters of blood is going. So tell me 0 divided by 5, how much the value will be? 0. So ventilation perfusion ratio, ventilation 0 ho gaya. So tell me who is wasted now? All his blood got wasted because there is no oxygen, nothing. The blood unnecessarily going. So 0 ka meaning kya hai, sir? 0 indicates wasted perfusion. Wasted perfusion. Infinitive indicates wasted ventilation. 0 indicates wasted perfusion. So repeat again. What is the normal ventilation perfusion ratio of the lung? The ventilation perfusion ratio of our lungs is 0.8, apex of the lung may 3.2, base of the lung may 0.6. Infinitive is seen in which condition? Infinitive is seen in pulmonary embolism and anatomical dead space, and 0 is seen in foreign body obstruction. Foreign body obstruction. Okay, apex of the lung is different from the base of the lung. What are the differences? Here is a table showing the differences. Ventilation perfusion are maximum in the base of the lung. Ventilation perfusion are least in the apex of the lung. TB infection, apex. Less ventilation, apex. Less perfusion, apex. Less gas exchange, apex. High oxygen availability, apex. Small alveoli, base. Highly compliant alveoli, base. More ventilation, base. More perfusion, base. More gas exchange, base. Okay, more ventilation perfusion ratio, apex. Apex में ventilation perfusion ratio 3.2. Okay, so yes, apex of the lung is slightly different from the base of the lung. These are the differences which I want you to know. Zero indicates what? Zero indicates wasted perfusion. Infinitive indicates what? This is what is important. Infinitive indicates wasted ventilation. Examples are important, very, very important. Infinitive in pulmonary embolism, anatomical dead space. Zero in foreign body obstruction. Okay, done. Next, after this, what is Bohr's effect and Haldane's effect? So for your FMG exam, you have to know what is Bohr's effect and Haldane's effect. Okay, I will tell you. Bohr's mein, which letter is there? Sir, Bohr's mein O is there. Bohr's effect is the release of oxygen from where? From hemoglobin. From the hemoglobin. What hemoglobin is doing? Hemoglobin, it is the releasing the oxygen. It is the releasing the oxygen to tissues. You already know, no? One hemoglobin molecule. Let's say this is the hemoglobin molecule. Here is the hemoglobin molecule. Hemoglobin molecule can carry what? Hemoglobin molecule can carry 4 molecules of oxygen. Okay, it can carry 4 molecules of oxygen. Now tell me what the hemoglobin is doing. It is releasing one oxygen molecule. It is releasing one oxygen molecule to where? To the tissues. Why? Why it is releasing oxygen to the tissues? Because at the level of tissues, there is decrease the partial pressure of oxygen. At the level of our tissues, in the tissues, inside the tissues, God designed our tissues in such a way, the partial pressure of oxygen is going to be less. So, hemoglobin will release the oxygen. Hemoglobin will know that, okay, here the partial pressure of oxygen is less, means these are the tissues. Now, I need to release the oxygen to the tissues. So, this is called as Bohr's effect. So, Bohr's means, Bohr's mein O is there. Bohr's effect means it's a release of oxygen molecules from the hemoglobin to the tissues due to decrease in what? Due to decrease in partial pressure of oxygen. Due to decrease in the partial pressure of oxygen. That is Bohr's effect. Okay. Now, after this, let me explain Haldane's effect after some time. But first, let me explain you what is this right shift and left shift. Right shift and left shift of oxygen hemoglobin curves. Oxygen hemoglobin curves. Wait, guys. First of all, let me tell you the blue color. First of all, right here, sir, this is not even 5-star marks, 10-star marks. Okay, 10-star marks. Very, very important thing for your FMG exam, from the especially from the respiratory physiology. Okay. Now look, the blue color thing that you are seeing here is a normal curve. This is normal. Sometimes this curve, whatever you are seeing here, this is called as the oxygen hemoglobin association dissociation curve. This curve is called as oxygen hemoglobin association and dissociation curves. Sometimes this curve, it can undergo right shift, sometimes it can undergo left shift. The curve can undergo right shift, it can undergo left shift. So what is this right shift and left shift? Okay, see, according to, wait, normally, let me ask you one thing. Normally, one hemoglobin can carry how many oxygen molecules? One hemoglobin can carry 4 oxygen molecules. Yes or no? Wait. In our blood, hemoglobin can carry how many oxygen molecules? One hemoglobin can carry 4 oxygen molecules. Normally, in you and me, we are not working hard. We are just sitting and we are just listening. No. Every time, hemoglobin will release how many oxygens? Hemoglobin, every time it will release 1 oxygen molecule to the tissue. Hemoglobin will release 1 oxygen molecule to the tissue. Okay, this 1 oxygen molecule is released to the tissues. From here, it is released. This is normal. But imagine, today you are running a marathon race. You are working more. You are running. Okay, imagine a mad dog is behind you. You are running, sir. Today is your FMG exam. Okay, you are getting late for your exam. So what you are doing? With the hall ticket in hand, you are running. So tell me, when you are running, your tissues want more oxygen or less oxygen? More oxygen. So tell me, in this condition, when your metabolism is more, when you are working hard, hemoglobin has to release 1 oxygen or 2 oxygens. Hemoglobin, instead of releasing 1 oxygen, now it will release 2 oxygen molecule to the tissues. Instead of releasing 1 oxygen molecule, now it is releasing 2 oxygen molecules. So yes, according to the metabolism in the body, according to our work, hemoglobin will sometimes release more oxygen. But wait, imagine your friend or your patient is in coma. He is in coma, sir. His metabolism is less. He is not working. He is simply resting. Whenever you are in resting state, hemoglobin should release more oxygen or less oxygen. Your tissues are not working. When your tissues are not working, hemoglobin will say, "Arey, you are not working. I won't release you oxygen. Why should I release the oxygen unnecessarily? Because you are not working." No, you work more, I will release more oxygen. If you don't work, I won't release oxygen. So that is what I am showing here. Sir, according to the metabolism in our body, sometimes this curve can undergo right shift, sometimes this curve can undergo left shift. For example, see, this 40 area is this is the tissue area. Imagine this is the tissues. The partial pressure of oxygen at the level of tissues is, let's say, 40. And your venous blood is also 40. Stop. Let me make it easy for you. In a normal person, in your venous blood, venous blood means already the oxygen is given to the tissues. Already the oxygen is went into the tissues. So look carefully at this line. Sir, in a normal person, see, this is normal. Hemoglobin is how much percent saturated? Sir, 75% saturated. इसका मीनिंग क्या है 75% saturation? इसका मीनिंग 75% saturation meaning, sir, out of 4 molecules, it is still carrying how many molecules? 3 molecules. In a normal person, yes, 1 oxygen molecule is released. So still in the venous blood, hemoglobin is carrying 3 molecules of oxygen. That's 75% saturation. But look at the right shifted curve. Sir, right shifted curve. Look, this is the right shifted curve. In the venous blood, same line. Okay, look. Sir, hemoglobin is how much percent saturated? Sir, now the same hemoglobin is 50% saturated. इसका meaning क्या है sir? 50% saturated का meaning. Sir, 50% saturated का meaning. Sir, now it is carrying only 2 molecules of oxygen. Where the remaining 2 molecules went? Now the remaining 2 molecules are released to the tissues because the tissues are working more. So right shift indicates what? Right shift indicates more oxygen is released to the tissues. Why more oxygen is released to the tissues? Because the tissues are working more. There is high metabolism in the body. Okay, so right shift is going to be seen in which condition? So right shift is going to be seen whenever you are doing exercise. You have to by heart this exercising conditions. Whenever there is hypoxia in the body, hypercarbia means more carbon dioxide is produced in the body. Hypercapnia, hypoxia, hypercapnia. Whenever you are doing exercise, more metabolism in the body produces more acid. Lactic acids are produced. Exercise produces lactic acid. Acidosis is going to decrease the pH. Acids releases the H+ ions. Whenever you are doing exercise, your body temperature increases. Okay, whenever you are doing exercise, 2,3 bisphosphoglycerate is produced inside your RBC. So finally tell me, sir, all these conditions, that is hypoxia, hypercapnia, acidosis, low pH, more temperature, 2,3 bisphosphoglycerate, all of them will tell the hemoglobin, will change the hemoglobin structure in such a way, rather than releasing 1 molecule of oxygen, now it will start to release 2 molecules of oxygen, means more oxygen is released. Hemoglobin is not loving the oxygen. Now hemoglobin is not binding with the oxygen, it is releasing the oxygen. So that's why it is a low loving state. Low affinity means low loving. Hemoglobin is not binding with the oxygen, now it is releasing the oxygen to the tissues. So yes, this is the right shift. So tell me, right shift is seen in which conditions? For your FMGE exam, you have to by heart this one single table, that's it. Right shift is going to be seen in, sir, right shift is going to be seen in high metabolism, exercising conditions, hypoxia, hypercapnia, acidosis, low pH, more acid, more body temperature, 2,3 bisphosphoglycerate. They are all going to cause which shift in the hemoglobin curve? Right shift of the hemoglobin curve. Instead of donating 1 molecule of oxygen, now it will donate more molecules of oxygen or 2 molecules of oxygen. But exactly opposite. When you are not working, whenever there is less metabolism in the body, that is left shift is going to occur. Left shift is going to be seen in conditions of low metabolism. Maybe your patient is in coma, so your patient body temperature decreases. Sir, he's not working, so his carbon dioxide production decreases, his acid production decreases, so he will go into alkalosis, or you can say his pH increases. So these conditions during these conditions, hemoglobin, it won't even release the oxygen because the tissues are not working. Hemoglobin will say, if you are not working, I won't release any oxygen. So that is a left shift. So in a normal person, hemoglobin is how much percent saturated? 75% saturated. But in a in a left shifted curve, hemoglobin is more than 90% saturated, let's say. Okay, more than 90% saturated, which means it is a high affinity. Hemoglobin is not releasing the oxygen. It is not releasing the oxygen. It's an example of high affinity state. So for your FMG exam, just by heart these two tables: the conditions where there is right shift and the conditions where there is left shift. Okay, high metabolism conditions where right shift is going to occur, low metabolic conditions where left shift is going to occur. Okay, now fine. And tell me, what is the shape of these curves? Sir, these oxygen hemoglobin curves, they are in the shape of S, sigmoid shape. So they will ask you, this oxygen hemoglobin curves, they are in sigmoid shape. They are in the shape of sigmoid shape. Okay, so in the recent FMG exam, the question was, acidosis is going to cause which shift? The acidosis is going to cause the right shift in the curves. Okay, hypoxia is going to cause which shift? Right shift. Okay, done. Chalo. Next, after this, Halden's effect is there. Sir, what is Halden's effect? Halden's effect is, let me tell you, Halden's effect, when the venous blood, imagine, here is the venous blood. Okay, here is a venous blood. In the venous blood, hemoglobin, okay, hemoglobin, try to imagine it is carrying carbon dioxide in the venous blood. When the venous blood, where it will come? Venous blood will come to the lungs. Venous blood will come to the lungs. So in the lungs, what will happen? Lungs may, now oxygen is going to come. Now oxygen will come and bind with the hemoglobin. Okay, in the lungs, now oxygen is there. Now whenever the venous blood is going to the lungs, see, in the venous blood, hemoglobin, it is also carrying the carbon dioxide. Whenever the oxygen goes and binds with the hemoglobin, it is the loading of oxygen onto the hemoglobin causes the release of carbon dioxide. So carbon dioxide will be washed out of the lungs. So whenever oxygen is loading to the hemoglobin capacity to carry this carbon dioxide decreases and carbon dioxide is released. So this is called as Halden's effect. So tell me, what is Halden's effect? Bohr's effect is the release of oxygen. Halden's effect is the release of carbon dioxide. So this arterial blood or oxygenated blood, it cannot carry the carbon dioxide. It will release the carbon dioxide to the lungs and the carbon dioxide is going out of the body. So Bohr's is the release of oxygen. Halden's is the release of carbon dioxide. That's it. Okay. So in the FMG exam, see, if you want to study only one topic, before going to the exam from the respiratory physiology, I highly recommend you to go through this right shift and left shift, surfactant topic, FEV1 by FVC ratios, ventilation perfusion ratios. Okay, that's it. If you still have time, if you want to go through, you can go through the high altitude physiology. Okay, high altitude physiology, anyway, you know, because in renal physiology, anyway, I will explain. In high altitudes, when you tell me, okay, let me write here itself. Why to leave that? See, whenever you go to high altitudes, okay, whenever you go to high altitudes, tell me, whenever you are going to high altitudes, you are going to have hypoxia, right? Okay, you are going to have hypoxia. Whenever you are having hypoxia, means you are not able to get the enough amount of oxygen. Okay, sorry. You are not able to get enough amount of oxygen. So to get the oxygen, what you will do? You will do hypoventilation or hyperventilation. When you go to Delhi to Leh Ladakh, when you go from Delhi to Leh Ladakh, okay, when you go from Delhi to Leh Ladakh, the hypoxia is going to be there in Ladakh, high altitudes. Whenever there is a less amount of oxygen availability, that you are going to do the hyperventilation. You are going to do hyperventilation. Okay, you are going to do the hyperventilation. Now you tell me, whenever you are doing the hyperventilation, what happened to your carbon dioxide levels? The carbon dioxide levels in your body will decrease. The carbon dioxide is the acidic gas. Whenever the carbon dioxide level decreases, the acid production in the body decreases. So that will lead to, whenever acid decreases, that will lead to respiratory, because of respiration, no, respiratory alkalosis. So always remember, in a person who is going to the high altitudes, he is going to suffer with which condition? He is going to suffer with the respiratory alkalosis. When you go from Delhi to Ladakh, you are going to have the hypoxia, and the hypoxia, what it will do? Hypoxia is going to cause a hyperventilation. Hyperventilation decreases the carbon dioxide. Carbon dioxide decrease means acid decreases. Acid decrease means respiratory alkalosis. So now, how we are going to treat this condition? Tell me, sir. Treatment? You have to. अरे already alkalosis है body पे. Alkalosis है. So you have to use a drug. You have to use a drug which will decrease the bicarbonate levels. You have to use a drug which will decrease the bicarbonate levels in the body. What is the drug? Acetazolamide. Acetazolamide. You already know it, acetazolamide. Sir, what acetazolamide will do? Acetazolamide causes the bicarbonate excretion into the urine. The bicarbonate level decreases and alkalosis will come back to normal. Okay, the pH will come back to normal. So that is the reason why, what is the drug of choice for this mountain sickness? Mountain sickness means we are going into the high altitudes. Whenever a person is having the high altitude sickness or the mountain sickness, the patient will have respiratory alkalosis. So that's why the drug of choice for this condition is acetazolamide. Acetazolamide decreases the bicarbonates. So whenever the bicarbonate base level decreases, pH will come back to normal. pH will come back to normal. Okay, and one more question which came from the which came in the recent exams is, whenever the patient goes to this high altitudes, he is going to have the hypoxia. You know? So you tell me, whenever there is hypoxia to the brain, means enough amount of oxygen is not going to the brain. Enough amount of oxygen is not going to the brain. So you tell me, if enough amount of oxygen is not going to the brain, cerebral vasculature, the blood vessels will undergo vasoconstriction or vasodilation. Sir, in order to supply more oxygen, the cerebral blood vessels will undergo vasodilation. So whenever there is a cerebral vasodilation, in order to supply the oxygen, whenever there is a cerebral vasodilation, sir, now the fluids, because of this vasodilation, fluids will leak into the brain, that will lead to cerebral edema. Okay, cerebral edema. So yes, this cerebral edema is going to occur because of the hypoxia induced. This hypoxia is going to cause the vasodilation of the cerebral blood vessels, and the vasodilation of the cerebral blood vessels is going to cause the fluid leak into the brain, that will lead to cerebral edema, and that can actually kill the patient. Okay, so this is also recently tested. Next, one more thing which you need to know for your exam is, wait, so today imagine here is your lung, Today in your lung, because of some pathology, the alveoli in this area, that totally collapsed and they are not getting any ventilation. Oxygen nahi hai, is part of the lung mein, or this lobe of the lung mein. For example, you know, okay, one lung have 2 lobes, another lung have 3 lobes. Now in this lung, this lobe is not having any oxygen. Completely gone, completely damaged. This part of the lung is completely damaged and there is no oxygen. Now I am asking you, sorry, first of all, which type of blood will go to the lungs? Is it arterial blood will go to the lungs, or is it the venous blood will go to the lungs? Sir, it's a venous blood. Venous blood is going. See, we give the oxygen to the lungs, or we get the oxygen from the lungs? We get the oxygen from the lungs. Lungs gives us the oxygen. We are not giving the oxygen to the lungs. Lungs gives us the oxygen. So now you tell me, this pulmonary artery of the pulmonary blood vessel, it is taking the blood to the lungs to get this oxygen. But today oxygen nahi hai. Is part mein oxygen nahi hai. So now tell me, whenever the oxygen is not there, what is the point of sending this venous blood to this area? You tell me, what is the point? What is the point of sending venous blood to the area where there is no oxygen? So now immediately this pulmonary blood vessel will undergo vasoconstriction. So tell me, whenever there is a hypoxia in your lungs, the pulmonary blood vessels will undergo vasoconstriction. But what about the cerebral blood vessels? Whenever there is hypoxia in your body, not in the lungs, whenever there is hypoxia in your brain or in other parts of the body, the blood vessels will undergo vasodilation. But with the hypoxia, whenever there is hypoxia in your lungs, the pulmonary blood vessels will undergo vasoconstriction. So that at least the blood will be diverted towards healthy areas. At least the blood will be diverted towards healthy areas to get the oxygen. So tell me, how the systemic blood vessels will respond whenever there is hypoxia here? The systemic blood vessels will undergo vasodilation, but whenever there is hypoxia in your lungs, the pulmonary blood vessels will undergo vasoconstriction. This is a very important difference between the systemic blood vessels and as well as the pulmonary blood vessels. Okay, done. Next, see some topics which are worth mentioning. If you have time, anyway you have studied this in your other subjects also. See, whenever you do the deep sea diving, okay, usually the questions will never come, but when you do the deep sea diving, means you are going into the sea deep and you are having a rapid ascent, what will happen? You know that nitrogen bubbles will form in your blood vessels. Okay, nitrogen bubbles will form and that is going to block the blood vessels. It causes a lot of problems. Okay, that's a deep sea diving topic. If you have time, you go through them, otherwise not needed. So with this successfully what we have completed? We have completed the respiratory physiology topics. Okay, let's start with the next system, that is the renal physiology. Now in renal physiology, what we should know in renal physiology? Okay, how many pages are there? Renal physiology, 1, 2, 3, 4, 5, 6, 7. Yeah, 7 pages are there. We can complete this in the next half an hour. Let's try to complete the entire renal physiology in half an hour, 45 minutes. Chalo. Renal physiology. See, you know, in our kidneys, there are cells called as interstitial cells of peritubular capillaries. There are cells called as interstitial cells of the peritubular capillaries. What do they produce? They produce a hormone called as erythropoietin. They produce what? Erythropoietin. And erythropoietin, what is the function of the erythropoietin? The function of the erythropoietin is to produce RBC. So this is what they will ask you. Sir, erythropoietin is produced from kidneys? Yes. From which cells of the kidneys? Interstitial cells of the peritubular capillaries. What is the function of erythropoietin? RBC. Okay. Next, in our kidneys, what else you should know? Sir, in our kidneys, in the PCT region, that is the proximal convoluted tubules, there is activation of vitamin D. Vitamin D will be activated. Where? The vitamin D is activated in which part of the kidney? In the proximal convoluted tubule. Okay, let me write clearly. PCT mein. PCT. In the proximal convoluted tubules of our nephrons, the vitamin D is activated. Why only in the PCT? Because there is a necessary enzyme present. What is the name of that necessary enzyme? The name of the necessary enzyme is called as alpha-1 hydroxy. OH means hydroxy group. Alpha-1 hydroxylase. Alpha-1 hydroxylase. With the help of this enzyme called as alpha-1 hydroxylase, the vitamin D is activated in the PCT. Okay, sir. What is the active form of vitamin D called as? Sir, the active form of vitamin D is called as 1,25 dihydroxy, 1,25 dihydroxy cholecalciferol. 1,25 dihydroxy cholecalciferol is also called as calcitriol. Where is it activated? PCT mein. With the help of which enzyme? Alpha-1 hydroxylase. Where is this vitamin D going to act? Sir, vitamin D, it acts in your stomach and intestine. Vitamin D acts on our stomach and intestines, increases the absorption of calcium and phosphates from the food that we have taken. So vitamin D का काम क्या है sir? Vitamin D acts on our GIT, increases the calcium absorption as well as phosphate absorption, not reabsorption. Calcium को absorb करेगा, phosphates को gut से, okay, GIT से absorb करेगा. So what is the final result? Final result is increase the calcium and increases the phosphate levels, increase the calcium levels and increase the phosphate levels in our blood. But wait, so this entire activation, see this entire vitamin D activation process. Okay, I haven't taught you the entire activation process, but important things I have taught you. Whenever you expose yourself to the sun, vitamin D is activated, but final activation occurs in PCT. But this entire process, activation, is under the control of a hormone. What is the name of the hormone? The entire activation is controlled by parathyroid hormone. Parathyroid hormone regulates this process. So the parathyroid hormone activates the alpha-1 hydroxylase. So alpha-1 hydroxylase converts this inactive vitamin D into active form. Active vitamin D increases calcium and phosphate absorption. Okay, done. So, important thing for your exam. What is the function of vitamin D? Increase calcium phosphate, increase the calcium phosphate absorption from the gut. Vitamin D activation occurs in PCT with the help of which enzyme? Alpha 1 hydroxylase. Vitamin D activation is under the control of which hormone? Parathyroid hormone. Okay, parathyroid hormone. Imagine you are having a kidney failure. Okay, this is the question, sir. Imagine you are having kidney failure. For example, in a patient with CKD. Here there is a patient with CKD, chronic kidney disease. Now in a patient with CKD, there is going to be hypocalcemia. Hypocalcemia. Can you tell me the reason why? What is the pathway that is impaired? In a patient with CKD, chronic kidney disease, why there is hypocalcemia? Because kidneys are not working. So there is no more vitamin D. Vitamin D nahi hai. Without vitamin D, you cannot absorb the calcium and phosphate from the gut. You cannot absorb the calcium from the gut. When you cannot absorb the calcium from the gut, that is going to cause what? That is going to cause the hypocalcemia. So this was the question already asked. In a patient with a chronic kidney disease, there is going to be hypocalcemia. That is due to what? The hypocalcemia is due to impaired calcium absorption from the gut. Impaired calcium absorption from the gut. Done? Next. What else you should know is this glomerular filtration barrier for your exam. Glomerular filtration barrier. Glomerular filtration barrier means how the substances are filtered. How the substances are filtered into your nephrons. Okay. Let me teach you the glomerular filtration barrier now. See, here there is a blood vessel which is bringing the blood. Here there is a blood vessel which is bringing the blood to the nephron. This is called as what? Afferent arteriole. Afferent arterioles are going to divide into what? Glomerular capillaries. Glomerular capillaries. Glomerular capillaries, again they will fuse and forms what? They will fuse and forms efferent arteriole which will take the blood away. So there is afferent arteriole, glomerular capillaries, efferent arterioles. Now, question to you. Sir, here the glomerular capillaries, listen carefully, the glomerular capillaries, they are lined by these endothelial cells. You can see these cells. So these cells, yes, they are called as what? Endothelial cells. Write in your book, endothelial cells. In between the endothelial cells, can you see these gaps? Sir, what is the name of these gaps called as? Sir, these gaps are called as fenestrations. These gaps ko kya bolte, sir? These gaps are called as what? Fenestrations. Now, sir, these endothelial cells, they are lying on what? The endothelial cells are lying on this basement membrane which I am highlighting right now. Sir, what is the name of this pink color membrane? The name of this pink color membrane is called as a GBM, glomerular basement membrane, which is made up of the type 4 collagen. Glomerular basement membrane. You have already studied that in Goodpasture syndrome, antibodies are produced. In Goodpasture syndrome, antibodies are produced against this type 4 collagen. Goodpasture syndrome, hematuria with the hematemesis will be seen. Okay. Anyway, yeah. Now, sir, you know this is the nephron. This green color thing is the nephron. Here is the Bowman's capsule. Bowman's capsule continues as what? The Bowman's capsule continues as the proximal convoluted tubule. Okay. Here is the PCT. And here is the Bowman's capsule. Stop. Students tell me. Sir, what are these lining cells? Here you can see some epithelial cells lining. These lining epithelial cells are called as, sir, these lining epithelial cells are, they are called as the podocytes. They are called as what? Podocytes. Okay, the lining epithelial cells are called as what? Podocytes. Now, in between the podocytes, can you see these gaps? What are the gaps between the podocytes called as, sir? Is gaps ko kya bolte, sir? These gaps are called as slit pores. Slit pores. Now, within the slit pore, can you see this structure that is that I am highlighting? What is the structure, sir, that I am highlighting? So, this is called as slit diaphragm. This is called as slit diaphragm. Okay, slit diaphragm. So, this is the basic structure of the glomerular filtration barrier. So, now you tell me, here there is a substance X. Okay, here there is a substance X. Sir, we have to filter the substance X from the blood. The substance X have to filter into the nephron. It have to filter into the nephron. So, now tell me, it has to cross how many layers? First, it has to cross the endothelial layer. It has to cross the glomerular filtration membrane. And later, it has to cross the podocytic layer. So, now tell me, the glomerular filtration barrier is made up of what? Sir, this filtration barrier, the glomerular filtration barrier, right? Glomerular filtration barrier made up of 3 structures. What are the three structures? The three structures are endothelial cells, second one is glomerular basement membrane, and the third one is podocytes. Endothelial cells, glomerular basement membrane, and the podocytes. So these three, okay, these three layers are forming the glomerular filtration barrier. They will decide whether a substance will filter or not. Now my next question to you, students, tell me, in order to filter the substance X, the substance should be big size or small size? Only small size substances are filtered. And next question to you, sir, imagine this X substance is having positive charge. Do you think this positive charge substance will be filtered? Yes, the positive charge substances are filtered because this glomerular filtration barrier, the glomerular basement membrane, is having which charge? It is having negative charge. So here there is a negative charge. So the glomerular basement membrane is having which charge? The glomerular basement membrane is having negative charge. So the negative charge will attract these positive charges. The negative charges attract the positive charges. So tell me, filtration is based on what? Filtration is based on the size. First of all, small size substances are filtered. But what about the negative charge substances? So tell me, do you think the negative charge substances will filter? No, the negative charge substances are not filtered. Imagine here, the charge is going to be negative. These substances, sorry, just give me a minute. Yeah, imagine these substances are negatively charged. Do you think the negative charge substances will filter? No, because the negativity will repel the negative charges. So now tell me, filtration is based on two things. What is the filtration based on? The filtration is based on the size as well as the charge. So yes, filtration MCQ, filtration is based on filtration based on size and charge. Which charge substances are easily filtered? Sir, which charges are easily filtered, sir? So the positive charges are better filtered when compared to neutral, when compared to negative charges. That is, in a simple way, I can say, sir, cations are better filtered when compared to anions. Okay, cations are better filtered. Okay, cation substances are better filtered when compared to the anionic substances. Anions means negative charges, the cations means the positive charges. Okay, next, glomerular filtration barrier is having which charge? The glomerular filtration barrier is having negative charge. Don't forget about that. Okay, next thing, sir, this is slit diaphragm here, the slit diaphragm. So the slit diaphragm is made up of two important proteins. What are the names of two important proteins? The slit diaphragm is made up of two important proteins called as a nephrin and podocin. Nephrin and what? Podocin. So the slit diaphragm is a very important structure. It's actually a gate, sir. It's a very important gate which will decide whether to allow the substance or not, whether to filter a substance or not. Who will decide? It's mainly the slit diaphragm. It's mainly the slit diaphragm. Slit diaphragm actually contains pores like this. Slit diaphragm is made up of nephrin and podocin. It have pores like this. So substance has to go through these pores. So slit diaphragm is a very, very important gate. It will decide whether to filter a substance or not. So why I am discussing this? Because see, this nephrin and podocin, these proteins, they are coded by genes. NPHS1 gene, NPHS2 gene. Sometimes they can be mutated. So NPHS1 gene today, let's say, mutated. Okay, and this NPHS2 gene is also mutated. So tell me what will happen, sir? Array, genes are mutated means the protein will be defective. Nephrin and podocin will become defective. When they are defective, slit diaphragm will become weak. There is a defective slit diaphragm. So there is going to be defective slit diaphragm. Now you tell me, whenever your slit diaphragm is defective, slit diaphragm is an important gate. Gate is damaged. Now tell me, whenever the gate is damaged, now the large substances like proteins will start to filter. Now big substances like albumin, globulin, fibrinogen, now they will start to filter and now they are excreting in the urine. Protein loss. So right, NPHS1 gene mutation or the NPHS2 gene mutation, क्या हो जाएगा sir? Defect in the slit diaphragm. Whenever the slit diaphragm is going to be defective, that is going to cause Protein urea. Protein urea. So now you tell me, if you lose proteins in your urine from your medicine you have studied, sir, whenever you are losing protein in the urine, that is more than 3.5 grams per day, more than 3.5 grams per day in the urine, if you lose this much amount of protein, if you lose this much amount of protein in a day in a urine, that is called as what? That is called as nephrotic syndrome. Yes, NPHS1 gene mutation and NPHS2 gene mutation is going to cause the nephrotic syndrome. The names are different, sir. The names are different. The first type of nephrotic syndrome is called as what? NPHS1 gene mutation is going to cause the nephrotic syndrome called as Finnish type of nephrotic syndrome. Finnish nephrotic syndrome. Finnish nephrotic syndrome, because Finnish here stands for what? People of Finland. Okay. It's very commonly seen in the Finns. Finns means like people of the Finland are called as what? Finns. Finland. Okay. So it's called as a Finnish type of nephrotic syndrome. Due to NPHS1 gene mutation, they will lose more protein in their urine. And NPHS2 gene mutation is going to cause a different type of nephrotic syndrome called as steroid resistant nephrotic syndrome. Steroid resistant nephrotic syndrome. Okay, so Finnish type of nephrotic syndrome is due to NPHS1 gene mutation. Steroid resistant nephrotic syndrome is due to NPHS2 gene mutation. Okay, next, apart from this, what else you should know for your FMGE exam? Okay, in the renal physiology, how to calculate the GFR. GFR को calculate करने के लिए, see, you are my patient, I am the doctor. I want to check whether your kidney function is normal or not, whether your kidneys are producing urine or not. Okay, normal person में how much is the GFR? In a normal person, the GFR is 125 ml per minute. This much amount of filtration will happen usually. But I want to check your GFR. So there should be, I should use some formula, I should use some agents. The formula is UV by P. That is urinary concentration of inulin. How much inulin is there in your urine? P for plasma concentration of inulin. How much inulin is there in your plasma? And V stands for what? V stands for volume of urine produced per minute. 1 minute mein how much urine you are producing? I can know. I am just checking the timer. Now I am seeing how much drops of urine is coming into the urobag. I have kept a Foley's catheter and I am checking in a minute how much drops of urine is coming. So if I know these three parameters, that is U, V by P, I can actually calculate your GFR. Okay, I can actually calculate your GFR. Okay, so GFR को calculate करने के लिए what is the formula that I will use? U, V by P. The same formula is also used to calculate the clearance of a drug or substance. Sorry. So to calculate the clearance of a substance out of your body, it's the same formula that I am going to use. Okay. Next. Now, how your GFR is going to change? Okay. According to the vasoconstriction and vasodilation of your renal blood vessels, you can actually change your GFR. How, sir? Look carefully. What am I doing now? See, this is the afferent arteriole. Let's imagine this is the afferent arteriole. Here is the efferent arteriole. First, what am I doing? I am doing the afferent arteriolar vasoconstriction. Means the afferent arteriole is closed. So tell me, when the afferent arteriole is closed, blood is not coming to the glomerulus. Blood is not coming. So GFR will decrease. So simple logic, no? Afferent arteriolar constriction decreases the GFR. Exact opposite. Afferent arteriolar dilation, more blood will come, more will be the GFR. So afferent arteriolar vasodilation is going to increase your GFR. Who will do that? Who will do that? Sir, afferent arteriolar vasoconstriction is done by sympathetic nervous system, norepinephrine. And afferent arteriolar vasodilation is done by prostaglandins. Prostaglandins, our kidneys will produce prostaglandins. Okay. Next, now exactly opposite. Now efferent. Sir, efferent arteriolar vasoconstriction, when you cause the efferent arteriolar vasoconstriction, see, if you do the mild constriction, first what am I doing? First I am doing the mild constriction, little. Sir, when you cause the efferent arteriolar constriction, what will happen to the back pressure? Increases, back pressure increases, more pressure means with more pressure here, more filtration will occur. So, yes, efferent arteriolar constriction, mild, initially increase GFR, initially, yes, GFR will increase, GFR increases. But when you do the severe constriction, no, whenever you do the severe constriction, sir, whenever you are doing the severe constriction, that actually increases the pressure here so much, the blood will stop coming here. The blood will stop coming here because the blood will always come from high pressure to low pressure. But when you are doing the severe constriction, the blood cannot come here because already it's a high pressure area. And that too, whenever you are doing the severe constriction, the proteins will start to accumulate here. Albumin, globulin, fibrinogen, the proteins will start to accumulate here. Proteins will develop oncotic pressure. Oncotic pressure doesn't allow the filtration to happen. So when you do the severe constriction, the GFR actually decreases. First initially increase, but later decreases. Initially increases, later GFR decreases. So this is called as biphasic response. Biphasic response. So tell me, efferent arteriolar constriction, when the efferent arteriole is constricted, initially GFR may increase, but later it will decrease. This is called as the biphasic response. And who will do that? Angiotensin 2. Angiotensin 2, important, angiotensin 2 acts on efferent arterioles. Efferent arteriolar constriction initially may increase the GFR, but later decrease the GFR. Then what about the efferent arteriolar dilation? Sir, efferent arteriolar dilation, now when the efferent arteriole is dilated, the blood will not accumulate here in the glomerular capillaries. The blood is simply escaped because here the resistance is very less. The blood vessels are wide open. So blood will escape. Here the pressures will fall and the GFR will decrease. So if the efferent arteriole is dilated, GFR will actually decrease. That's it. So afferent arteriolar constriction, GFR decreases. Afferent arteriolar dilation, GFR increases. Efferent arteriolar constriction initially increases the GFR, but later it may decrease the GFR. Efferent arteriolar dilation, decrease the GFR. That's it. Next, sir, in the PCT topic, what you should know? Sir, in the PCT, okay, see, imagine here is the Bowman's capsule, here is the PCT. Okay, now here is the PCT. Now my question to you, sir, in the PCT there are different transporters. Different transporters, सोडियम को reabsorb करने के लिए, अमीनो एसिड को, ग्लूकोज को, बाइकार्बोनेट को, okay, phosphates को reabsorb करने के लिए different transporters are there. Today these transporters are not working. So glucose lost in the urine, phosphate lost in the urine, amino acid lost in the urine, bicarbonate lost in the urine, chloride lost in the urine, sodium lost in the urine, everything lost. So sodium, potassium, magnesium, calcium, everything which was supposed to be reabsorbed in the PCT, everything lost ho gaya. So what is the name of this condition? Fanconi syndrome. So tell me, what is Fanconi syndrome, guys? Fanconi syndrome is a defect in PCT, complete PCT transporter defect. Entire PCT transporter mar gaya. So sodium loss, chloride loss, glucose loss, bicarbonate urea, protein urea, everything lost. So that is called as a Fanconi syndrome. Okay, autosomal recessive disorder. Next question to you, sir. In the PCT, how much glucose is reabsorbed? 100% glucose, 100% amino acids reabsorbed in the PCT. 100% glucose, 100% amino acid reabsorbed. Okay. Next, sir, here what is your plasma osmolarity? Tell me. The plasma osmolarity is 300 milliosmoles. Okay, 300 milliosmoles. Now tell me, in the PCT how much water is reabsorbed? Sir, almost 70% water is reabsorbed. 70% water is reabsorbed. Now tell me, you are reabsorbing the water. No, you are reabsorbing the water. So tell me, here the urine will be concentrated or diluted in the PCT. Sir, the osmolarity here will be still 300. Urine is neither concentrated nor diluted because 70% water is reabsorbed as well as 70% sodium, almost 70% chloride also reabsorbed. Both solute and solvents. Sir, both the solutes and the solvent is reabsorbed in same amount, same proportion. So osmolarity or the concentration is unchanged, right? In PCT, urine is isotonic. to plasma, isotonic to plasma, because the urine concentration is not changing. Okay, urine concentration is not changing. Usually students will think, sir, 70% water is reabsorbed, so the urine is getting concentrated. No, urine is neither concentrated nor diluted. Next question, sir, in the PCT, glucose is reabsorbed? Yes, glucose reabsorbed. With the help of which a transporter? With the help of a transporter called as SGLT type 2. SGLT type 2. So, SGLT2 stands for what? S means sodium glucose linked transporter. The glucose is reabsorbed along with the sodium ions with the help of a transporter called as SGLT2. The glucose reabsorption in the PCT is with the help of SGLT2. Fine. Next MCQ. Sir, in PCT, which substance concentration decreases? Which of the following substance concentration decreases in the PCT? Options I am giving you: A, B, C, D. 4 options I am giving you. One is glucose, sodium, chloride, all. Which of the following substance concentration actually decreases in the PCT? Glucose, sodium, chloride, all. What do you think is the answer? What do you think is the answer? Sodium, glucose, chloride, all. So, it's a very simple question. Usually, some of the students will think it is glucose and some of the students will go with the all. But what is the correct answer, sir? The answer is glucose. Glucose concentration actually decreases. The sodium chloride concentration will not change. The sodium chloride concentration will not change because the amount of solute reabsorbed, amount of solvent reabsorbed is same. 70% water is reabsorbed. Along with that 70% water, 70% chloride is reabsorbed, 70% sodium is reabsorbed. So, sodium chloride concentration or the osmolarity of the urine is unchanged, but who actually decreases? Glucose slash amino acids slash bicarbonates, because you know glucose 100% reabsorbed, amino acids 100% reabsorbed, bicarbonates almost 80-85% of the bicarbonates are reabsorbed. So, actually these 3 substance concentration decreases, but not the sodium chloride, concentration. Okay, fine. Next. Sir, water reabsorption PCT, see, wherever sodium chloride goes, water follows. 70% sodium chloride reabsorption along with 70% water reabsorption. So, you require antidiuretic hormone for the reabsorption of water in the PCT? No need of antidiuretic hormone. No need of antidiuretic hormone for the reabsorption of water. No need of antidiuretic hormone for the reabsorption of water in the PCT. So, no need of ADH for water reabsorption. Okay, water reabsorption. Chalo, next. Loop of Henle. Sir, let me draw the loop of Henle. In the loop of Henle, what you should know? See, there is a descending limb of loop of Henle and there is a ascending limb of loop of Henle. Here is a, let's say, here is a PCT. Okay, here is a PCT. This is the PCT. In the descending limb of loop of Henle, see, in the PCT, what is the urine osmolarity? Tell me. The urine osmolarity in the PCT is 300. In the descending limb of loop of Henle, when the urine is going through the descending limb of loop of Henle, who is reabsorbed? It's only the water. Only the water will be reabsorbed. Only the water will be reabsorbed. Now tell me, as you are reabsorbing the water, what will happen to the urine? You are not removing any sodium chloride, only water is getting reabsorbed. So the urine will become concentrated. 400, 600, 800, 1000, 1200. So tell me, in the descending limb of loop of Henle, the urine is getting concentrated. So descending limb of loop of Henle is a concentrating segment. Descending limb of loop of Henle is a concentrating segment. Descending limb of loop of Henle is a concentrating segment for the urine. It's a concentrating segment for the nephron. It is concentrating the urine up to 1200 milliosmoles. But wait, in the ascending limb of loop of Henle, see, when the urine is going through the ascending limb of loop of Henle, do you know what happens? Sir, it is the sodium chloride which will be reabsorbed. It is the sodium chloride. Sodium chloride. Sodium chloride will be reabsorbed. So tell me, as you are removing the sodium chloride out of the urine will become diluted again. Again, 1000 milliosmoles, 800, 600, 400, 200, 100, something like that. So the urine is getting diluted. So ascending limb of loop of Henle is a diluting segment. Okay, diluting segment. Next, my question to you, sir, what is the name of the transporter with which the sodium chloride is getting reabsorbed? The name of the transporter with which the sodium chloride is getting reabsorbed, the name of this transporter is called as NKCC, that is sodium potassium 2 chloride symporter. Sodium potassium 2 chloride symporter. And what is the name of this transporter with which the water is getting reabsorbed? The name of this transporter with which the water is getting reabsorbed, that is called as aqua porin 1 channel. Aqua porin 1 channel. So water is getting reabsorbed with the help of the aqua porin 1 channel, and the sodium chloride are getting reabsorbed with the help of NKCC, sodium potassium 2 chloride symporter. Sodium potassium 2 chloride symporter. Okay. Now in your exam you may get a question that the sodium potassium 2 chloride symporter can be inhibited by which drugs? Sir, it can be inhibited by loop diuretics. Loop diuretics. So loop diuretics are the drugs. There are drugs called as a furosemide, torsemide. Loop diuretics are the drugs which will inhibit this NKCC transporter. Sir, if this NKCC transporter, if it is a mutated from birth, then it is going to cause a condition called as what? It is going to cause a condition called as Bartter syndrome. Bartter syndrome. So now tell me, Bartter syndrome is a defect in which part of the nephron? Bartter syndrome is a defect in ascending limb of loop of Henle. Bartter syndrome is a defect in the loop of Henle, sir. Due to mutation of which transporter? Due to the mutation of NKCC transporter. Okay. So this NKCC transporter is mutated. That will lead to Bartter syndrome. Okay. Next, what else you should know regarding the ascending limb of loop of Henle? See, this is the loop of Henle. Okay. In the ascending limb of loop of Henle, I have taught you there is a transporter. What is the name of this transporter? This is the NKCC transporter with which the sodium potassium 2 chloride are getting reabsorbed. But wait, one more thing which I want to teach, is, sir, in the ascending limb of loop of Henle, there is which charge? In the lumen, there is positive charge. In the lumen, what is that? There is positive charge. Why there is this positive charge? Wait, sir, in the ascending limb of loop of Henle, which charge is there? There is positive charge. Why? Because whatever the cells that are lining over here, these are the lining cells. No, cells will be like this. So these cells, what they are doing? They are excreting the potassium. So 24/7, they are excreting the potassium. So tell me, potassium is which charge? Positive charge. Is positive charge ke wajah se, because of this positive charge, the ascending limb of loop of Henle is having which charge? Positive charge. The ascending limb of loop of Henle is having which charge? Positive charge. Okay. So positive lumen potential. Now you might be thinking, sir, what is the importance of this positive charge? The positive charge is due to potassium secretion, and the positive charge, now I am asking you, do you think ions like calcium and magnesium, do you think this divalent cation, see this is Mg2 plus, do you think this calcium and magnesium, they can go through the ascending limb of loop of Henle easily? No, the positive charges will repel the positive charges, so they are forced to be reabsorbed. So the calcium and magnesium, they are forced to be reabsorbed into the medulla. Because the positive charge, what is the importance of the positive charge? The positive charge helps in reabsorption of calcium and magnesium. Okay. So Bartter syndrome is very, very important. Sir, Bartter syndrome is a defect in which transporter? NKCC transporter. Bartter is a neonatal. It is there from the birth. NKCC transporter is not working. So they will lose sodium out of the body, chloride out of the body. Whenever they are losing the sodium and chloride out, they will get dehydrated. Polyuria will be there. Dehydrated. Dehydration activates the RAS pathway. RAS pathway produces aldosterone in the body. Aldosterone will cause hypokalemia. Aldosterone excrete the acids out, potassium out, leading to hypokalemic alkalosis. Okay, that and all you will study in your medicine. Okay, so just remember in physiology, Bartter syndrome, defect in where? Bartter syndrome is a defect in ascending limb of loop of Henle. Mutation to which transporter? NKCC transporter. Okay, NKCC transporter. Okay, now after that, let's discuss about the distal convoluted tubule. Okay, not collecting duct directly. Let's discuss about the distal convoluted tubule. Now here imagine this is the distal convoluted tubule of the nephron. Here is the ascending limb of loop of Henle. Imagine this is the ascending limb of loop of Henle. The urine is coming like this, and here is the distal convoluted tubule. Distal convoluted tubule, what it will do? It continues as what? Okay, let me draw the diagram clearly. Imagine here is a distal convoluted tubule. Here is the ascending limb of loop of Henle. Here is the ascending limb of loop of Henle. Here is the distal convoluted tubule, and here down it is the collecting ducts. So these are the collecting ducts. Now you look at here in the distal convoluted tubule. These are the epithelial cells, and here there is a transporter. One important transporter is there. What is the name of this transporter? The name of this transporter is sodium chloride symporter. Sodium chloride symporter. Okay. So what is the transporter that is present in the ascending limb of loop of Henle? That is NKCC. Here what is this one? This is NCCT, sodium chloride co-transporter. You can actually inhibit this transporter. You can actually block this transporter with the help of which drugs? Drugs called as thiazides. Okay, thiazide diuretics. So thiazide diuretics inhibit which transporter? Thiazide diuretics acts on DCT. Thiazides acts on DCT, and thiazides are going to inhibit the sodium chloride transporter. Why I am teaching this here? Because imagine if this NCCC transporter, if this transporter, if it is inhibited, if it is mutated from birth, if it is mutated from birth itself, it is not working from birth itself. Okay, sorry, it's not mutated from the birth. It is actually going to be late in onset. Okay, sir, if this transporter is not working, usually somewhere around 10 years, 15 years, okay, at that time, not actually from the birth, you tell me if this transporter is not working, then it will cause a different disease that is called as Gittelman syndrome. Gittelman syndrome. Okay, Gittelman syndrome. Okay, so tell me in the distal convoluted tubule, what is the name of the transporter present? Sodium chloride co-transporter. If the sodium chloride co-transporter is mutated from the birth, then it is going to cause which syndrome? Gittelman syndrome. You can actually inhibit this transporter by using certain drugs called as thiazide diuretics. Thiazide diuretics. Okay. Next. Sir, tell me, in distal convoluted tubule, any water is reabsorbed? No. Distal convoluted tubule, no water reabsorption. No water reabsorption. Usually there is no water reabsorption. Only who is reabsorbed? Only sodium chloride is reabsorbed. Okay, only the sodium and chloride are getting reabsorbed. Okay, solutes, I mean solutes are getting reabsorbed, but not the water is getting reabsorbed. Okay, next, after this, let's look at the collecting duct. Sir, on the collecting duct, there are cells here. Look carefully. These cells are called as the principal cells. Okay, so who is going to act here? Sir, it is the aldosterone. Aldosterone is acting here. The hormone called as aldosterone. Aldosterone acts on this principal cells. When aldosterone is acting on these principal cells, there is a channel called as epithelial sodium channel. The name of this channel is called as ENaC, epithelial sodium channel. With the help of the epithelial sodium channel, who is getting reabsorbed? The sodium will be reabsorbed. Sodium will be reabsorbed. And the same principal cells, with the help of a potassium channel, potassium will be excreted. Potassium is going to be excreted. K plus is excreted. Okay, K plus is excreted. Actually, it's a different cell, but I am showing here for easy understanding purpose. There is one more thing happening here. Acids are also excreted. So in the collecting duct, under the influence of aldosterone, okay, let me just remove the principal cell, it will create confusion. So now, aldosterone acts on which cells? Cells of collecting ducts. So this is the collecting duct. Aldosterone is acting on the cells of the collecting duct. So what the cells of the collecting duct are doing? So these collecting duct cells, okay, the collecting duct cells, they are reabsorbing the sodium, excreting the potassium, excreting the acids. Okay, that's normal, that's normal. But today, imagine, what if these channels are doing the overaction? What if these channels are doing the overaction, especially the epithelial sodium channel? If this epithelial sodium channel, if it is doing overaction, means overactivity of the epithelial sodium channels. So that is going to cause, right, the overactivity of the epithelial sodium channel, overactivity. This is abnormal. Overactivity is going to cause a condition called as Liddle syndrome. Liddle syndrome. Okay, so tell me in Liddle syndrome what will happen? Sir, in Liddle syndrome, more and more sodium will be reabsorbed into the body. More and more sodium will be reabsorbed into the body. When more positive charges coming into the cell, more positive charge will automatically go out to balance the neutrality. As more and more sodium comes in, more and more potassium and more acid will go out, leading to hypernatremia, more sodium in the body. But what happened to potassium and acid level? Decreases. So in Liddle syndrome, which clinical features are there? Sir, your sodium levels may be increased, sometimes may be normal, but most of the time it is increased. Sodium levels are more, but what happened to the potassium levels? Decrease. Acid levels in the body decrease, leading to hypertension with hypokalemic alkalosis. Okay, hypokalemic alkalosis. So this is Liddle syndrome. So tell me, Fanconi syndrome is a defect in PCT. Bartter syndrome is a defect in loop of Henle, ascending limb of loop of Henle, NKCC transporter defect. Gittleman syndrome is a defect in sodium chloride co-transporter. Liddle syndrome is a defect in collecting duct, epithelial sodium channel overactivity, which is the autosomal dominant disorder. This is the autosomal dominant. Gittleman syndrome is autosomal recessive. Bartter syndrome is also autosomal recessive disorder. Okay, so now tell me how you are going to treat this Liddle syndrome. How you are going to treat this condition? Sir, Liddle syndrome. I am going to treat the Liddle syndrome by blocking the epithelial sodium channels. Epithelial sodium channel blocker. So treatment is a drug called as amiloride, which is epithelial sodium channel blocker. Epithelial sodium channel blocker, amiloride. So these are some important points which I want you to know regarding the collecting duct. Okay, how it is responsive to the aldosterone, how aldosterone is acting on the collecting duct. Now look carefully. Now I am showing you one more principle cell. Listen carefully. Here I am showing you one more principle cell. Now which hormone is acting here? Antidiuretic hormone. Now not the aldosterone, but I am talking about the antidiuretic hormone. When antidiuretic hormone is acting on the cells, now the cells, this receptor is called as a V2 receptor. When antidiuretic hormone is acting on the V2 receptor, now the collecting ducts will start to reabsorb what? Water. Now the collecting ducts will start to reabsorb water with the help of aquaporin 2 channel. With the help of aquaporin 2 channel, now the collecting duct will reabsorb water. So tell me, collecting duct mein water reabsorption will occur? Yes, occurs. Collecting ducts helps in water reabsorption, but only in the presence of antidiuretic hormone. Antidiuretic hormone है तो water reabsorb हो जाएगा, antidiuretic hormone नहीं है तो water reabsorb नहीं हो जाएगा. Okay, fine. What is the receptor for antidiuretic hormone? V2 receptor. With the help of which channels? Aquaporin 2 channels. This type of water reabsorption is called as what? Facultative water reabsorption. Facultative water reabsorption means whenever there is antidiuretic hormone, water is reabsorbed. Without antidiuretic hormone, water is not reabsorbed. Okay, done. Next, let's see how it is different with antidiuretic hormone and without antidiuretic hormone. What are the differences? Listen carefully. Let me draw this diagram. Yeah, let me draw this diagram. Everyone, listen carefully. Here is the glomerular capillary, let's say. What is the osmolarity of the of our blood? 300 milliosmoles. The plasma osmolarity is 300 milliosmoles. Okay, fine. Now here I am showing you the Bowman's capsule. Bowman's capsule continuing as what? Proximal convoluted tubule. Proximal convoluted tubule, it continues as the loop of Henle. Descending limb of loop of Henle. And the ascending limb of loop of Henle, it continues as distal convoluted tubule and collecting ducts. Okay, collecting ducts. Now let me duplicate this. With versus without antidiuretic hormone, how it is going to be different. Now first, let's say without antidiuretic hormone means in our body antidiuretic hormone is not there. It is not there. So when antidiuretic hormone is not there, look carefully. Sir, whenever the urine is filtered, the urine osmolarity in the Bowman's capsule 300, in the PCT also 300, but I have taught you in the descending limb of loop of Henle, as the water is getting reabsorbed. See, as the water is getting reabsorbed, the urine will start to concentrate up to how much? 1200 milliosmoles, 1200 milliosmoles. But in the ascending limb of Henle, only the solutes will be reabsorbed with the help of NKCC transporter. Only the sodium chloride will be reabsorbed. As the sodium chloride is getting reabsorbed, the urine will be diluted to how much? 100. In the ascending limb of Henle, the urine is diluted to 100. Then what about the DCT? Sir, in the DCT, again with the help of NCCT, sodium chloride co-transporter, again sodium chloride is reabsorbed. You tell me, as again the sodium and chloride are getting reabsorbed, the urine will further dilute. Urine is diluted to 90, 90 to 80, something like that. Sir, in the collecting duct, with the help of epithelial sodium channel, again the sodium is reabsorbed. Again you are removing the salts. When you are removing the salts, urine will be further diluted to how much? 75, 70, something like that. So urine osmolarity final, let's say 70 milliosmoles. So tell me, we are producing without antidiuretic hormone. When the antidiuretic hormone is not there, we are producing very diluted urine. My plasma osmolarity is 300, but my urine osmolarity is only 70, 80, 90 maximum. Okay, so we produce diluted urine. So now my question to you, without antidiuretic hormone, when the antidiuretic hormone is not there, when the antidiuretic hormone is not there in our body, the least osmolarity, the urine will have the least osmolarity. Where? The urine is going to have the least osmolarity, the last part of the collecting duct. That's the last part of the collecting duct. So least osmolarity seen in, the least osmolarity is seen in medullary collecting ducts. Medullary collecting duct is not the cortical collecting duct. It's not the cortical collecting duct. It's the medullary collecting duct. The medullary collecting duct is going to have the least osmolarity. Okay, because the antidiuretic hormone is not there, there is no water reabsorption. Okay, so the urine will be further diluted, and we are producing the diluted urine. Then what about the condition where there is antidiuretic hormone? Now today antidiuretic hormone is there. So now tell me, sir, same 300 milliosmoles filtered. PCT made is 300. In the descending limb of loop of Henle, the urine is concentrated to 1200. In the ascending limb of loop of Henle, the urine is diluted to 100. Now in the DCT, I have taught you DCT is again diluting segment. DCT may, as sodium chloride is reabsorbed, since sodium chloride is reabsorbed, the urine is diluted to, let's say, 90, 80, something like that. But today, which hormone is there in the body? Antidiuretic hormone. Antidiuretic hormone. Antidiuretic hormone acts on collecting ducts, but actually in reality, the antidiuretic hormone action begins from, the antidiuretic hormone action begins from the late part of the DCT, late DCT, this is early DCT. Okay, antidiuretic hormone shows its action from the late DCT, cortical collecting duct and medullary collecting duct. So now you tell me, whenever there is antidiuretic hormone, who is reabsorbed? Now water is reabsorbed. Now who is getting reabsorbed, sir? Now it's a water getting reabsorbed. So tell me, when the water is getting reabsorbed, what will happen to the urine? Urine will start to concentrate. 82, again 100, 120, 160, 200, something like that. Now you are going to produce concentrated urine. Now the urine is getting concentrated. So now tell me, in the presence of antidiuretic hormone, whenever the antidiuretic hormone is there, the least osmolarity is seen in which part of the nephron? Sir, least osmolarity, yeah. This is 160, don't confuse, this is 160. The least osmolarity is seen in early DCT. So with antidiuretic hormone, least osmolarity seen in early DCT. Okay, so this is the difference. Without antidiuretic hormone, least osmolarity is seen in the medullary collecting duct, but with antidiuretic hormone, least osmolarity is seen in early part of the DCT, because from the late part of the DCT, antidiuretic hormone increase the water reabsorption, the urine will start to concentrate. Okay, so this is what I want you to know for your exam. Okay, with antidiuretic hormone, without antidiuretic hormone differences. Next, what is the difference between RTA type 1 and RTA type 2? Okay, RTA type 1 and RTA type 2. See, let me explain you in a simple way. Here is a Bowman's capsule. Here is a PCT. Here is a blood vessel, let's say peritubular capillary. This blood vessel is called as what? Peritubular capillary. In the proximal convoluted tubule, bicarbonates are reabsorbed. HCO3 minus reabsorbed into the cells. Now from here, you have to reabsorb into the blood. You have to, with the help of a transporter, you have to reabsorb this bicarbonate into the blood. Okay, this is normal. So in the PCT you have to reabsorb the bicarbonates. But today this transporter is mutated. This transporter kya ho gaya sir? Mutate ho gaya. What is the name of this transporter? The name of this transporter is called as sodium bicarbonate co-transporter, which will help in the absorption of the bicarbonates. Today it is damaged. The sodium bicarbonate co-transporter is damaged. So now you cannot be able to absorb the bicarbonates. Now you won't be able to absorb the bicarbonates. So tell me, if you are not able to get the base bicarbonates, you will get to acidosis. So it's a problem with the bicarbonate reabsorption. Now you are not able to reabsorb the bicarbonates. So when you are not getting the bicarbonate, you will get into acidosis. So that is called as RTA type 2. RTA type 2. So first I am explaining you about the RTA type 2. So RTA type 2 is a problem with the bicarbonate reabsorption. Bicarbonates are not getting reabsorbed. The bicarbonates are getting excreted now. So you cannot get the bicarbonate into the blood. That will lead to acidosis. That is the RTA type 2, which is the PCT defect. The PCT defect, bicarbonate reabsorption problem. But what is the RTA type 1? Sir, in RTA type 1, look carefully. Now I am showing you the nephron. Sir, here is a nephron. Here is a proximal convoluted tubule, loop of Henle. This is the distal convoluted tubule. And here is the collecting duct, cortical or medullary collecting duct. Sir, actually, in the distal convoluted tubules, okay, in the distal convoluted tubules, sir, these cells are called as intercalated cells. Intercalated cells. These intercalated cells, do you know what they will do? Sir, they, with the help of a transporter called as proton pump, with the help of a transporter called as, proton pump, sir, this is called as proton pump. With the help of proton pumps, always they will excrete the acid into the urine. 24/7, they are acid excreting cells, sir. Intercalated cells are acid excreting cells. They are excreting acid out of the body. But today what happened? Today this one got mutated. Now you tell me, whenever this is mutated, these proton pumps are mutated, will you be able to excrete this acid? Will you be able to excrete this acid out? No, you can't able to excrete the acid out. So acids will stay in the body, so leading to acidosis again. So this is RTA type 1, sir. This is RTA type 1. That is problem with proton excretion, acid excretion problem. RTA type 2 is bicarbonate reabsorption problem. Here the problem is acid excretion. RTA type 1 is DCT defect. Proton pump mutation. Proton pump mutation. Here it is sodium bicarbonate co-transporter mutation. Okay, that's the difference between RTA type 1 and RTA type 2. Very, very important thing for your FMGE exam. RTA type 2 is a defect in PCT. RTA type 1 is a defect in DCT. DCT defect. One is a bicarbonate reabsorption problem. Other one is acid excretion problem. Okay, proton pump mutation, acid excretion problem. Okay, have I already taught you what is RTA type 4? RTA type 4 is a deficiency of aldosterone. Aldosterone is not there in the body. When aldosterone is not there, you cannot excrete acid. I have taught you aldosterone reabsorbs the sodium, protons and acid को excrete करेगा, protons को और potassium को excrete करेगा. Aldosterone नहीं है तो protons will build up in the body, acid will build up in the body, that will lead to acidosis. That is called as renal tubular acidosis type 4. So 3 types of RTAs are completed. RTA type 2, PCT defect. RTA type 1, DCT defect. RTA type 4, aldosterone deficiency. Aldosterone deficiency. Okay, so with this what we have completed? We have completed the renal physiology. Some image based questions were there. Okay, in some image based questions they will ask you in PCT. Okay, in PCT, what is the substance? 4 substances are there actually. 4 substances are there. What is this first substance number A whose amount in the PCT, in the proximal tubule, is decreasing to 0? The amount of the substance becomes immediately to 0. Means the amount of substance remaining in the PCT is 0. There is no substance left. What is that? Glucose and amino acids. Glucose and amino acids. Okay, because I have taught you 100% glucose, 100% amino acids are reabsorbed. So in the PCT, in the proximal convoluted tubule, the A is becoming 0, glucose, amino acids. But what about this B substance? Sir, B substance in the PCT, see, in the PCT, still almost 20% of the substance is left over. Almost 20% of the substance is still present, means 80% reabsorbed, 20% is left over. So what is the substance B? Bicarbonates. In PCT, 80% bicarbonate is reabsorbed, 20% of the bicarbonate is still left in the urine. Then what about the substance C? What is the substance C? That is 100% of the substance is filtered. In PCT also 100% present. Distal convoluted tubule also its value is same. In the urine also its value is same. Means the amount of substance that is filtered into the Bowman's capsule, in the PCT, DCT, collecting duct, urine, the amount is not changing, exactly the same. The substance is inulin. So inulin is freely filtered but never reabsorbed. So that's why its amount is going to be same in Bowman's capsule, PCT, DCT, urine, everywhere, same. But what is the substance D? What is the substance D whose amount is filtered? Let's say 100 molecules filtered. Let's say 100 molecules filtered. But in the PCT, look, maybe 200 molecules are present. So what is the substance D, sir, whose amount is actually increasing? When compared to the filtered amount, the amount in the PCT is increasing. That is para-aminohippuric acid. Because para-aminohippuric acid is not only filtered but also secreted. So para-aminohippuric acid is filtered but also secreted. It's both filtered as well as secreted. So let's imagine 100 molecules are filtered. Maybe some extra 100 molecules are also secreted. So value will become 100 to 200. So this is the image based question they will ask you. What is A? Glucose. B. Bicarbonate. C. Inulin. D. Para-aminohippuric acid. Okay, just know them. Okay, next, cystometrogram. Sir, what is the cystometrogram? What you should know in the cystometrogram? Sir, in this cystometrogram, look carefully. It is volume and pressure relationship. Volume and pressure relationship in bladder. Okay, so volume of urine in the bladder and pressure developed in the bladder. The volume of urine in the bladder and the pressure developed in the bladder. The volume and pressure relationship in the bladder. That's called as a cystometrogram. See, initially, starting from the kidneys, urine is coming into the bladder. So the urine volume increases. See, from 0 ml to 100 ml, the urine in the bladder is increasing. So pressure also slightly increasing. But wait, the urine volume increasing from 100 to 200, 200 to 300, 300 to 400. The urine volume is increasing, but the pressure is not rising fastly. The pressure is not rising sharply. The pressure is almost constant. The pressure is almost like a flat line, sir. Almost constant. There is not sharp rise in the pressure. Why? Because bladder is highly stretchable, highly plastic. With the upcoming urine, as more and more urine comes into the bladder, bladder is distending, stretching. So the pressure inside the bladder will not rise significantly because the bladder is increasing in volume. More the volume, the pressure is not going to rise quickly. Okay, because at the same time urine volume is increasing, along with that the shape of the bladder is also changing. Okay, now, so that's why, see, what is 1A represents, sir? In this graph, the 1A represents what? 1A represents small rise in pressure. Bladder filling started. See, bladder filling started, just a small rise in pressure. But what is happening in phase 1B? Sir, in phase 1B, bladder filling continues, but bladder is also stretching. So, right, 1B, bladder filling continues, but bladder also distends. So, pressure is almost constant. The pressure is not going to rise. Okay, and what about the C? What about the 2? Okay, what about this 2, sir? Phase 2. Sir, once you get 400 ml of urine, bladder distension stops. Bladder completely stretches, sir. Now, bladder is no longer going to distend. The bladder is no longer going to distend. Bladder distension reaches maximum. So, now there is going to be sharp rise in pressure. Now, the pressure is going to rise sharply. Okay, so yes, in phase 2, there is sharp rise in pressure, so that you will have a strong urge for urination. What were the questions that came in the exam, sir? Image based question. First of all, it's the image based question they will ask you. They will give you this graph and they will ask you, what is this graph? Cystometrogram. Sir, phase 1B, 2 questions were there. Sir, question is, phase 1B is explained by which law? Which law tells you about, which law explains you about the phase 1B, why the pressure is not rising very sharply? The answer is explained by law of Laplace. Okay, law of Laplace. Law of Laplace explains the phase 1b. Next one, sir. Next one. Phase 1b is due to, why the phase 1b, why the pressure inside the bladder is not rising sharply? Why the pressure is not rising sharply? The phase 1b is due to bladder plasticity. Not elasticity, plasticity. Okay, so our bladder is highly plastic, our bladder is highly distendable, our bladder is highly stretchable, so the pressure inside the bladder is not going to rise. See, if it is having this recoil force, if it is having this elasticity, that elasticity is going to raise the pressure. No, but our bladder is highly plastic, not elastic. Elastic means what? Recoil. Plastic means what? Stretchability. So our bladder is highly stretchable, so the pressure inside our bladder is not going to rise sharply. Okay, so this cystomatogram is also image based question which I want you to know. Phase 1b is explained by law of Laplace, and that is due to the plasticity of the bladder, not the elasticity of the bladder. Okay, so these two image based questions I want you to know. Next one. Sir, what is this image based question talking about? The image based question is talking about the glomerulus, histology of the glomerulus. See, this is the Bowman's capsule. Here is the Bowman's capsule. Okay. Now, question is, sir, then what is this part of the nephron? Which part of the nephron is closely related to the, what is this part of the nephron closely related to the Bowman's capsule? See, this is the Bowman's capsule, okay. Then what is this part of the nephron? Remember, this is DCT, distal convoluted tubule. Always remember, distal convoluted tubule is closely related to, okay. Sir, what we are drawing is the two-dimensional diagrams, but actually in reality, it is the distal convoluted tubule. It is very closely related to the Bowman's capsule. And on the distal convoluted tubule, can you see these cells which I am highlighting? These densely packed cells. These densely packed cells on the distal convoluted tubule. So they will ask you this area. So they have already asked once. So what are these cells? These cells are macula densa. What are these cells called as? Macula densa. So tell me, macula densa cells are located on where? Macula densa cells located on distal convoluted tubule. Now you might be having a doubt, sir, what is the function of this macula densa cells? Macula densa cells, they sense sodium and chloride levels in urine. They are always checking how much sodium is going into the urine, how much sodium and chloride are losing in the urine. So they sense the sodium chloride levels. Macula densa cells, they sense the sodium chloride levels in the urine. Okay, done. So with this successfully what we have completed? We have completed the renal physiology also. Okay. So actually, yeah, I thought to complete by 9 o'clock exactly. In 7 hours, I thought I will be completing the entire thing by 9 o'clock. Exactly 7 hours, no? 2 to 9, 7 hours. But yeah, it's taking a little bit of time, but no issue. We can complete the general physiology in the next 1 hour. 1 hour I will complete the general physiology. Don't worry about that. Okay, so the honorable mentions, let's say. Here in the renal physiology, along with the medicine, you have to know the differences between the Bartter syndrome and Gittleman syndrome. See, Bartter syndrome Bartter syndrome is a defect in the ascending limb of loop of Henle, NKCC transporter defect. Gittleman syndrome is a defect in the distal convoluted tubule, where there is a defect in sodium chloride co-transporter defect. So you have to, in your medicine, you have to study differences between Bartter and Gittleman, because in Bartter syndrome there is going to be hypercalciuria. In Gittleman syndrome there is a hypocalciuria. In Bartter syndrome, okay, more calcium will be lost into the urine. In Gittleman syndrome, less calcium is lost into the urine. In your pharmacology, you will study Bartter syndrome resembles loop diuretic overusage. Gittleman syndrome resembles azide diuretic overusage. Okay, in Bartter syndrome, deafness is going to be there. In Bartter syndrome, usually the babies are going to be deaf. So yeah, some differences are there that anyway you will study in your medicine. Yeah, physiology, this is enough. Okay, next. In your medicine, extra points that you have to study is, what if antidiuretic hormone is not there in your body, gone, total antidiuretic hormone is gone. Sir, antidiuretic hormone, if it is not there in your body, that will cause a condition called as diabetes insipidus. If there is a too much amount of antidiuretic hormone, that will cause a condition called as SIADH, syndrome of inappropriate ADH synthesis. Okay, so how those conditions are different, that you have to do it in your medicine. Okay, If these classes are regular classes, I would have gone into those areas also because they are more clinical and internal medicine related topics. But as this is a rapid revision, I am not going into those areas because if I go into those areas, it will take one more extra hour. Okay, no, not needed, not needed. Chalo, next. After this, let's start the general physiology. Do you want me to give a small break of 5-10 minutes? Because general physiology, yeah, I think I can do it in 1 hour exactly. General physiology can be completed in 1 hour. So what I will do is just I will give you a 10 minutes of break. Just relax. After the break, we'll do the general physiology topics. Because wait, general physiology I am going to complete in 1 hour. But definitely from general physiology, I can write it on a bond paper. You will get 5 MCQs from the general physiology. In the next 1 hour, I am going to teach you 5 MCQs will come. 5 MCQs will come in the next 1 hour. Okay, 1 MCQ from the muscle physiology, 1 MCQ from the total body water, 1 MCQ from the transport topic, 1 MCQ from the nerve physiology, 1 MCQ is going to come from the cell membrane and cytoskeleton. Okay, 5 MCQs in the next 1 hour. Okay, take 10 minutes break. 10 minutes break. We'll see you after the 10 minutes. Okay, break. Started? Okay. Okay guys, now let's continue with the general physiology topics. I have already taught you even before the break that from the general physiology you can expect 5 MCQs, and we are going to do the entire general physiology in the next 1 hour. So 1 hour is equal to 5 MCQs. Okay. So chalo. Sir, in the cell membrane, okay, sir, in the cell membrane, what you should know? Sir, our cell membrane is made up of proteins, carbs, the first proteins, lipids and carbohydrates. How much? Proteins are the maximum, okay, that is 50 to 55%. Our cell membrane contains 50 to 55% of the proteins, 50 to 55% of the proteins. Lipids somewhere around 40 to 45%, 40 to 45%, in between anywhere, 40 to 45%. Carbohydrates are 1 to 3%, 1 to 3% are the carbohydrates. So proteins are the maximum composition of the cell membrane and carbohydrates are least composition of the cell membrane. Okay, so don't ask me like, sir, if you have 45 plus 55 already 100 ho gaya, then what about this 1 to 3%? See, range 50 to 55, 40 to 45, 1 to 3. I'm giving the like best values, okay, round figure values. Next, sir, exception. There is one membrane where lipids are greater than proteins. There is one membrane where the lipids in the membrane is greater than the proteins. That is membrane made up of 80% lipid, protein only 20%. What is that membrane? That is Schwann cell. Schwann cell membrane. Schwann cell membrane. So Schwann cell membranes, they contain more lipid when compared to the protein. If they ask you, in which membrane proteins are maximum, okay, but more than 55%, I have taught you usually proteins are 55%. What is that membrane where even more than 55% of the proteins are there? Means that is the maximum protein. Maximum proteins are present in which membrane? The membranes which is rich in proteins. So that membrane is the inner mitochondrial membrane. Inner mitochondrial membrane. Okay, so the inner mitochondrial membrane contains the maximum amount of proteins and Schwann cell membrane contains maximum amount of the lipids. Fine. Now let's see some important things that you should know. Sir, proteins in our cell membrane, and lipids and carbohydrates, carbs. So these are the three major things that are present in our cell membrane: proteins, lipids and carbohydrates. These are the three different things, right? Now how many types of proteins are there? See, in our cell membrane, there are three types of proteins: integral proteins, peripheral proteins, and lipid anchored proteins. Now, I am just dividing the things. Proteins in our cell membrane are divided into, proteins are of three types. What are they? Integral, peripheral, and lipid anchored proteins. Okay, now integral proteins, peripheral proteins, lipid anchored proteins. In your FMGE exam, they will ask you about the examples. Give me examples of integral or transmembranous proteins. Integral proteins are also called as what? Integral proteins are also called as transmembranous proteins. So in your FMGE exam, they will only ask you the examples. So integral protein or the transmembranous protein means, for example, look, imagine here is a membrane. Here is a cell membrane. And sir, in this cell membrane, if a protein is present from outside to inside, so like this, that is called as a transmembranous or integral protein. If a protein is attached to only one side of the cell membrane, that is called as a peripheral protein, either inside or either outside. But if a protein is attached to some lipid group, if a protein it is attached to some lipids, that is called as a lipid anchored protein. Anchoring means attaching. Lipid anchored protein. So examples they will ask you in your exam. Okay, examples of lipid anchored integral proteins. One example I am giving you: sodium, potassium, pump. Okay, all channels like sodium channel, chloride channel, calcium channel, potassium channel, all channels. Okay, G protein coupled receptors. These are examples of the integral or transmembranous proteins, like all sodium potassium pumps, all channels, G protein coupled receptors. Then what are the examples of peripheral proteins? Examples of peripheral proteins include spectrin, ankyrin, spectrin, ankyrin, and dystrophin. Spectrin, ankyrin, dystrophin. See, spectrin and ankyrin, where are they present? RBC mein. They are present in RBC. Dystrophin is present in skeletal muscles. Okay, dystrophin is present in skeletal muscles. Whenever the ankyrin and spectrin are mutated, RBC shape will change. RBC shape will change. That condition is called as what? That condition is called as, especially the ankyrin mutation. Ankyrin mutation is going to cause the defect in the shape of the RBC. That condition is called as hereditary spherocytosis. Okay, so hereditary spherocytosis is mainly due to the ankyrin mutation, not the spectrin mutation. Mainly it's the ankyrin mutation which is going to cause the hereditary spherocytosis. Of course, spectrin can be affected, band 3.2, like some other proteins are also affected. But mainly it's the ankyrin mutation which will lead to defect in the shape of the RBC, that is called as the hereditary spherocytosis. Then what about the dystrophin? Sir, this dystrophin, it is the largest gene in our body. The dystrophin gene, the dystrophin protein gene, the dystrophin gene is the largest gene in our genome. Now tell me, whenever this dystrophin is absent, complete absence, the dystrophin is completely absent in our skeletal muscles. So our skeletal muscles are going to be weak. Without this protein, our skeletal muscles will damage easily. So that condition is called as Duchenne's muscular dystrophy. Duchenne's muscular dystrophy is due to complete absence of dystrophin. So the skeletal muscles in the body are going to be weak. If you ask if you ask this child to sit and stand from the floor, see, he is taking the support of the upper limbs. He will take the support of the upper limbs to raise his body. So this sign is called as Gover sign. Okay, Gover sign. So Gover sign is going to be positive. Next, if you look at the calf of these babies, the calves are going to be very big because the muscle in this area is dead. In the place of muscle, it's a fat that is getting deposited, fat deposition. So this is called as pseudo calf hypertrophy. Pseudo calf hypertrophy. Seen with Duchenne's muscular dystrophy. So Gover sign is going to be positive. Pseudo calf hypertrophy is going to be seen. This is all because of complete absence of dystrophin. Dystrophin nahi hai, to weak muscles are going to cause these problems. Gover sign positive. Pseudo calf hypertrophy. Okay. Next, last one. What is the example of a lipid anchored protein, sir? The example of the lipid anchored protein is, the name of this protein is called as GPI, glycosyl phosphatidyl inositol. Glycosyl phosphatidyl inositol. If it is absent, complete absent, it will lead to a disease called as paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria. So GPI is a lipid anchored protein. If it is absent on our blood cells, that is RBC, WBC platelets, this GPI is actually on our blood cells. If it is absent, it will lead to a condition called as paroxysmal nocturnal hemoglobinuria, which is an acquired intravascular hemolytic anemia. Acquired condition, it's not genetic, it's an acquired intravascular hemolytic anemia. Means the RBCs, WBCs and platelets, they are damaged within the blood vessels, not in the spleen. Within the blood vessels, they are damaged. Okay, so that's it. Next, what else you should know regarding the lipids? Sir, how many types of lipids are there? Sir, in our body, lipids are also of three types. Three types of lipids are there. Number one is called as phospholipids. Second one, glycolipids. Glycolipids. Third one, in our cell membrane, the third type of lipid that is present is called as cholesterol. So these are the three types of lipids in our cell membrane. Three types of lipids: phospholipids, glycolipids, cholesterol. Out of which phospholipids are maximum. That's why we call our cell membranes as a phospholipid bilayer. Phospholipids are there, maximum. Okay. Out of these three lipids, phospholipids are maximum. Next, what are the examples of the phospholipids that are present? What are the examples of phospholipids? The examples of phospholipids include 1. Lecithin, sphingomyelin, third one, this is the second one, phosphatidyl, serine, Fourth one, cardiolipin. So these are the 4 different types of, listen carefully, just wait, let me change the color so that it will become easy for you. Let me change the color. Okay. So now tell me what are the examples of the phospholipids. The examples of the phospholipids include lecithin, sphingomyelin, phosphatidylserine, cardiolipin. Now for your FMG exam, what you should know? Sir, this phosphatidylserine is very much important for your exam. Phosphatidylserine and cardiolipin. See this phosphatidylserine, normally, see imagine here is a cell. Imagine here is a cell. Sir, this phosphatidylserine is always internalized. It is always internalized, means attached towards the inner leaflet of the membrane, means it is always inside the cell membrane. This phospholipid is always inside. But when a cell is undergoing apoptosis, when a cell is committing suicide, that is apoptosis, this phosphatidylserine, see now the cell is dying. It is dying. When a cell is dying, this phosphatidylserine, it is externalized. It will flip outside. This is called as PS flipping, phosphatidylserine flipping. So now it's actually signal. It is a eat me signal. Eat me signal for what? Eat me signal for macrophages. It is saying, the cells are saying to the macrophages that I am dying, you come and eat me, you come and clear me. So this phosphatidylserine flipping is seen in which cells? Apoptosis. Okay. Next, then what about the cardiolipin, sir? Cardiolipin, it is mainly found out, it is mainly found in which membranes? It is mainly found in mitochondrial membranes. Mitochondrial membranes. It is mainly found in the mitochondrial membranes. Okay, that question was asked. For cardiolipin is mainly found in mitochondrial membranes. Now, what you should know for your exam is, sir, this in certain diseases you will produce anti-cardiolipin antibodies. So, anti-cardiolipin antibodies are produced in which conditions? Anti-cardiolipin antibodies are seen in which conditions? One is syphilis and Apla syndrome. Okay, syphilis and Apla syndrome. So if a person gets the syphilis or Apla syndrome, he will produce anti-cardiolipin antibodies in his body. Fine. Next, what are the examples of the glycolipid, sir? The one important example of the glycolipid which I want you to know is GM1. It's an example. GM1 ganglioside. This GM1 ganglioside. Sir, where is this GM1 ganglioside located? Sir, this lipid called as a GM1 ganglioside, it is in your GIT. Okay, it is present in the intestinal cells. It is present in the epithelial cells of the intestine. It is present in the epithelial cells of the intestine. For example, let me show you. Sir, imagine here is your intestine. Here are the enterocytes. These are the epithelial cells. On these epithelial cells, here there is this GM1 ganglioside. Here this one is the GM1 ganglioside. Let's say this is the GM1 ganglioside. So now I am asking you, tell me what is this GM1 ganglioside doing? Sir, this GM1 ganglioside, it's actually a stupid thing. Do you know what it will do? It will allow cholera toxin. Okay, see, imagine Vibrio cholera entered into your body. And what it is going to produce? It's going to produce a cholera toxin. So this cholera toxin uses our GM1 ganglioside to get entry into the cell. So cholera toxin enters into our cell. So tell me, what is the importance of the GM1 ganglioside? The GM1 ganglioside acts as a receptor. It acts as receptor. For what? It acts as a receptor for cholera toxin. So GM1 ganglioside acts as a receptor for cholera toxin. Next, what about the cholesterol? So the cholesterol in our cell membranes. So what is the importance of the cholesterol? The cholesterol will make sure our cell membranes are flexible and fluid. Okay, our cell membranes are not rigid. Our cell membranes are not hard, sir. They are flexible. They will grow. They will stretch. Okay. So cholesterol acts as, the question is, cholesterol acts as fluidity buffer. So this is the exact question which was already asked in the exam. Which of the following is a fluidity buffer? Cholesterol makes sure that the cell membrane is flexible and it is a fluidity buffer. Okay. So this is what you should know regarding the lipids. So tell me students, how many types of lipids are there? Phospholipids, glycolipids and cholesterol is there. Cholesterol is a fluidity buffer. Glycolipids is the one important glycolipid which I want you to know is the GM1 ganglioside. GM1 ganglioside acts as a receptor for cholera toxin. And two phospholipids which I want you to know, one is the phosphatidylserine, the PS flipping. The phosphatidylserine flipping occurs in apoptosis, and anti-cardiolipin antibodies are going to be seen in the in the syphilis and Apla syndrome, and cardiolipin, it's a phospholipid present in the mitochondrial membranes. It's present in the mitochondrial membranes. That's the question which was already asked. Okay. Chalo, next. After this, regarding the cytoskeleton, what you should know? Sir, cytoskeleton, it gives, what is the function of the cytoskeleton? Sir, cytoskeleton, it gives structure to our cells. It gives a structure to our cells. Now, cytoskeleton, it is made up of what, sir? Sir, cytoskeleton is made up of what? Sir, the cytoskeleton is made up of three important things. Our cytoskeleton is made up of three important things. One is microtubules, microfilaments, and intermediate filaments. Okay. Intermediate filaments. So, microtubules, microfilaments, and intermediate filaments. Now, let's discuss about the microtubules now. What you should know regarding the microtubules is microtubules are the strongest out of all. They are the strongest. And they are dynamic. What does it mean by the word dynamic? Dynamic meaning they will grow. They will grow. Means these microtubules, with the addition of new tubulin molecules, one end of the microtubule will grow. That is called as a positive end, and one end is not going to grow. One end will not grow. That is called as a negative end. One end is kept on growing, and the other end is going to be static. So there is a positive end and there is a negative end. Okay. So microtubule grows. See, here I am showing you. Sir, this is a microtubule. First of all, write in your book, this is a microtubule. Sir, microtubule have a positive end, have a negative end. Now, on this microtubule, actually microtubule, it's like a road, sir. It's like a road. On the microtubule, sir, there is a molecule called as a kinesin and there is a molecule called as a dynein. What they are doing? They are actually walking. They are actually walking and transporting some important substances. They are transporting some important substances from one corner to the other corner. Okay. So, yes, on the microtubule, there are two molecular motors called as a dynein and a kinesin. They are actually helping the transport of substances within the cell. They are actually walking and they are helping in the transport of substances. Kinesin always walks towards the positive end. Dynein always walks towards the negative end. So, right, these are molecular motors. Okay, there are molecule motors. What are the examples of molecular motors? Three molecular motors are there in us. One is dynein, kinesin, and myosin. See, these three proteins, one is a dynein, kinesin, and myosin, they actually walk from one end to the other end. On the microtubules, they will walk. Dynein always moves towards the negative end. That is called as retrograde transport. Retrograde transport. What about the kinesin? Kinesin always moves towards the positive end, positive side of the microtubule. That is called as anterograde. Okay, anterograde transport or anterograde cargo. What about the myosin? Myosin can move in both the directions, especially in the neurons. Okay, myosin, that is bidirectional. So, how you can remember the mnemonic that I am giving you? You guys are going to be doctors, future doctors. Okay, so dynein always helps in retrograde transport, means it always moves towards the negative end. Now, why you should know this for your exam is they will ask, sir, what is the speed of retrograde transport? The speed of retrograde transport is with how much speed it will move? That is 200 millimeters per day. Then what is the speed of the anterograde transport? The speed of the anterograde transport is 400 millimeters per day. This is the speed of the anterograde transport as well as the retrograde transport. Okay. Now, why you should know this for your exam is one more important MCQ came from this area. One more important MCQ, that is, you know about the rabies virus. Rabies. See, this rabies virus, once it enters into your body, see, imagine a rabid dog, it came and it bite me. So, the rabies virus enters into the area. This is the area where the rabies virus got entry. Now, from here, do you know how the rabies virus is transported into the brain? Not through the blood, not through the blood. Now, the rabies virus enters into the neurons and it will go and bind with what? It will go and bind with dynein. So, the dynein, with the help of retrograde transport, with the help of retrograde transport in our neurons, it will bring the virus into our brain. So, viruses like rabies virus and tetanus toxins like tetanus, they use retrograde transport to enter, retrograde transport to enter into our central nervous system. Okay, so don't think that rabies virus enters into the blood and through the blood it will go to the central nervous system. No, rabies virus and tetanus toxin, they use as the retrograde transport to get access into our brain. Okay, done. Next, sir, what about the microfilaments? What are the examples of the microfilaments? The examples of the microfilaments are actin and myosin. Now, some of the students might be thinking, sir, actin and myosin are present in the skeletal muscle, they help in the muscle contraction. Wait, the actin and myosin, they are not only present in the skeletal muscles, but they are present in each and every cell in your body. Actin and myosin, they are the part of cytoskeleton, they will give the structure to the cell. Just now I have taught you, myosin helps in the bidirectional transport also. Okay, so yes, they are present in each and every cell. Then what about the intermediate filaments? Intermediate filaments are cell specific. They are cell specific. What does it mean by the word cell specific? Means they are only present in some types of cells. Only present in some types of cells. For example, look, keratin is an intermediate filament. It is only present in keratin. It is seen in epithelial cells, especially squamous epithelial cells. Okay, epithelial cells. Okay, so this intermediate filament called as a keratin, it is only present in the epithelial cells. Next, what about the vimentin, sir? Vimentin is also an intermediate filament. It is present in the cells of connective tissue in origin. Connective tissue cells, seen in connective tissue cells or mesenchymal cells. Connective tissue cells are the mesenchymal cells. Can you tell me what are the examples of the mesenchymal cells? For example, connective tissue cell like the fibroblast which produce a collagen. Okay, next, desmin. So this desmin, it is a intermediate filament. It is seen only in the skeletal muscles. Next, what about the GFAP? Glial fibrillary acidic protein. This glial fibrillary acidic protein, it is an intermediate filament. It is only seen in where? It is only seen in glial cells. Glial cells, for example, like astrocytes. Astrocytes are part of the glial cells. Okay, next, lamins. Lamins are seen in nuclear membrane. Attached to nuclear membrane. So what I want you to know is, see, these intermediate filaments, they are only specific to the cell type. Okay, for example, if I am talking about carcinoma, what is carcinoma? Carcinoma is the cancer of epithelial cells. So inside the carcinoma, you will find keratin pearls, keratin filaments are present. If I say there is astrocytoma, inside the astrocytoma, which marker is there? Glial fibrillary acidic proteins are there. Inside skeletal muscle cancer, that is a rhabdomyosarcoma. Which filaments are seen? Desmin. So desmin is the tumor marker of rhabdomyosarcoma. GFAP is the tumor marker of gliomas. Keratin is the tumor marker of epithelial cell cancers, that is carcinomas. Okay, so that's what I want you to know. So these are cell specific. Intermediate filaments are cell specific. Next, sir, next topic that we are going to discuss is the total body fluids. Total body fluids. See, in my body right now, say as an adult male, let's say, adult male, how much water is there? See, 60% of my total body weight, 60% of the total body weight is water as a male. If I am talking about the females, 50% of the total body weight is water. In children, 70% of their total body weight is water. So males are more watery, sir. Male contain more water. Males contain more water. Females contain less water. Males are more watery. Females are more fatty. Females contain more fat in their body. Males contain more water in their body. Okay. Okay, sir. Fine. Look at carefully here, my dear students. Imagine this is these are my cells. These are my cells and the blood vessels. Where is water present? Water is present inside the cell. That is called as the intracellular fluid. Water is present inside. That's called intracellular fluid. And water is also present in between the cells. Water is also present in between the cells. So this water which is present in between the cells, this is called as an interstitial fluid. Okay. Water is also present in your blood. Water is also present in your blood. That is a liquid component of the blood. That is called as what? Plasma. So now tell me, plasma plus interstitial fluid together called as extracellular fluids. So tell me, there are intracellular fluids and extracellular fluids. Extracellular fluids include plasma plus interstitial fluid. Okay, bye. Okay, fine. Which fluid do you think is more? Sir, always remember intracellular fluids are 2/3, extracellular fluids are only 1/3. Always it's the intracellular fluids are more. Okay, so look carefully here. Total body water, I have taught you 60% of my body weight, 60% of my body weight. How much water is there right now in my body? 42 liters of water is there right now in my body. In my body, there is 42 liters of water. Okay, Total body water is divided into intracellular fluid, extracellular fluid. Intracellular fluid 2/3, intracellular fluid 2/3, extracellular fluid 1/3. Intracellular fluid 28 liters, extracellular fluid only 14 liters. Intracellular fluid 40% of the body weight, extracellular fluid 20% of the body weight. Wait, tell me. 28 plus 14 how much? 8 plus 14 42. Okay. 40 plus 20 how much? 60. So yes, out of the total body weight, 60% total body weight, intracellular fluid contribute to 40% of my body weight, extracellular fluid contribute to 20% of my body weight. Have I already taught you? Extracellular fluids are further divided into interstitial fluid and plasma. How much is interstitial fluid, sir? 3/4, important MCQ. 3/4 is interstitial fluid, plasma is only 1/4, 25% only plasma. Interstitial fluid contributes to 15% body weight, plasma contributes to 5% body weight. This is the MCQ. Plasma contributes to how much body weight? 5% body weight. 5% body weight. Actually, right now in my body, how much plasma will be there in liters? Almost approximately 3 liters of plasma will be there. 3 liters of plasma will be there in my body. 3 liters of plasma contributing to 5% of my body weight. Okay, done? Chalo. Next, what else you should know? That is formula to calculate blood volume. Formula to calculate the blood volume, total blood volume. That is plasma value divided by 1 minus hematocrit. Plasma value divided by 1 minus hematocrit. You already know how much plasma is there. For example, in me 3 liters of plasma is there. By 1 minus hematocrit. How much is my hematocrit? 0.4. That's a constant value hematocrit. So 3 divided by 0.6. How much is that? 5 liters. In your exam, they may change these values. Instead of 3, they may give you 2 or 2.5 or 3.5. They may change it. Okay. So plasma by 1 minus hematocrit will tell you the blood volume in the body. Okay. Next, with age, what will happen? So when you are aging, you tell me, imagine 1 year, 2 year, 3 year, 4 year, 5 year. With aging, the number of cells in our body increases. So more the number of cells, more intracellular fluid. So with age, intracellular fluids increases, extracellular fluid decreases, total body water decreases. Okay. Then what about the intrauterine life? Intrauterine life. Sir, intrauterine life mein you are in the uterus. Okay. You are having less number of cells. So less number of cells means intrauterine life mein the extracellular fluids are greater than intracellular fluids. Remember this one thing. Okay, these are the differences. So once you take birth and when you are aging, intracellular fluids will increase, all others will decrease. But during intrauterine life, it is the extracellular fluids which are greater than intracellular fluids. Okay, fine. Next, at one point in your life, the intracellular fluid is exactly equal to extracellular fluid. When the intracellular fluid is exactly 1:1 to the extracellular fluid, that is 3 months after birth. Okay, 3 months after birth. So next, after this, what else I should teach you is indicators. Sir, in order to calculate this, the different body fluids, for example, how much is interstitial fluid, how much is extracellular fluid, how much is the plasma, how much is the total body water. In order to calculate these compartments, how much body fluids are there, you have to inject certain substances into the blood. You have to use certain indicators. What are those indicators? In order to calculate the total body water को calculate करने के लिए, the indicator that is used is D2O, deuterium oxide, or tritium oxide, or aminopyrin. Okay, so deuterium oxide, tritium oxide, or aminopyrin. This can be used. Extracellular fluid. In order to calculate the extracellular fluid, what you can use is SIM, that is sucrose, inulin, and mannitol. Okay, plasma. In order to calculate the plasma volume, I know almost 3 liters of plasma is there in my body. But in order to calculate your plasma volume, how much plasma is there in your body? So the indicator that I am going to use is radio labeled albumin. Radio labeled albumin, or Evans blue dye. Evans blue dye. Evans blue dye I will use. Last one. In order to calculate your RBC, how much amount of RBCs are there? RBC volume. I am going to use chromium, okay, radioactive chromium, chromium tagged RBCs, okay, chromium 55. So chromium I am going to use. So these are the different indicators which are used to calculate different volumes, okay. Next, after this, the next topic that I am going to discuss with you is the transport. Okay, the transport topic. Before going further, one important MCQ which I want you to know is, see, the one important MCQ which I want you to know is dehydration is more severe in children, okay, than adults. Due to, tell me, whenever there is a dehydration, see, whenever there is dehydration, that's going to be more severe in the children. Okay, dehydration is more severe in children when compared to adults due to, I have taught you in the children, whenever you are child, whenever during the childhood, we have more extracellular fluids when compared to adult age. So during childhood, it's the extracellular fluids are more when compared to intracellular fluids. Okay, sorry, extracellular fluids are more than adults. Sorry, extracellular fluids are more than adults means when compared to me, a child have more extracellular fluid. In me, there is more intracellular fluid. So tell me, more the extracellular fluid means more easy to lose it. Intracellular fluids are not easy to lose. See, sweating, extracellular fluid loss. Hemorrhage, extracellular fluid loss. Okay. So diarrhea, extracellular fluid loss. So the extracellular fluids are easy to lose. So childs are more prone to dehydration, and if the dehydration occurs, that is going to be more severe in the children when compared to the adults, because more extracellular fluid when compared to what? When compared to adults. Okay, that. Next, transport. Sir, in the transport topic, what you should know? Sir, how many types of transport are there? The transport, one MCQ is going to be pakka, definitely one MCQ is going to come in your exam. Sir, transport is mainly of two types, that is active and passive. Active and passive. Sir, active transport is again of two types, primary active transport and secondary active transport. Primary active transport, secondary active transport. Passive transport is again of two types, that is diffusion and osmosis. Diffusion and osmosis. Diffusion is of again further two types, that is simple and facilitated. Okay, so these are the different types of transport: active transport, passive transport, and further types. Now, how to identify a primary active transport? Sir, see, the mnemonic I am giving you, simple tricks I am going to teach you. Sir, how to identify a primary active transport? To say this is a primary active transport, there are some keywords, that is any transporter which ends with the name pump or ATPase. Any transporter which ends with the name pump or ATPase, they are all examples of primary active transport. For example, sodium, potassium, pump, proton, pump, something like that. Then how to identify secondary active transport? Any transporter which ends with the name co-transport. If you see two substances going together like sodium, glucose, co-transporter, sodium, potassium, 2-chloride, co-transporter, sodium chloride, co-transporter, something like that. So all co-transporters are symporters. For example, SGLT1, SGLT type 2, NKCC, sodium chloride co-transporter, they are all examples of secondary active transport. They are all examples of what? They are all examples of secondary active transport. Okay, these are all examples of secondary active transport. What are the examples of primary active transporters? The examples of primary active transporters are all ATPases and pumps. All ATPases and pumps. Then what are the examples of simple diffusion, sir? How to identify simple diffusion? Movement of substance from high concentration to low concentration. Of substance going from high concentration to low concentration. For example, gases transport. Example, oxygen going from high partial pressure to low partial pressure. Oxygen, carbon dioxide transport. oxygen carbon dioxide transport. Then what are the examples of facilitated diffusion? I have given you a mnemonic, that is GF. All gluts are examples of, all gluts are examples, all gluts. All glucose transporters, all gluts are examples of facilitated diffusion. Then what is the example of osmosis, sir? Then who is like moving according to osmosis? Water, water transport, water. You already know this. Sir, water will go from, sir, wherever there is sodium, water goes towards the sodium. Water always goes towards the high sodium levels, means high osmolarity. So water moves from high to low osmolarity. Water not from high to low, sir. Water always move from, sorry, mistake. Water always move from low osmolarity, means low sodium level, towards high sodium level, low to high osmolarity. Okay, so that is the example of osmosis. Okay, that's the example of osmosis. So these are all the different types of transport. Primary active transporters are identified with the pumps and ATPases. Secondary active transporters identified with the words co-transporters, importers. Simple diffusion, oxygen carbon dioxide transport is an example of simple diffusion. All gluts, glut 1, 2, 3, 4, doesn't matter, all gluts are examples of facilitated diffusion. Osmosis, water moves from low to high osmolarity, low sodium level towards the high sodium levels. Okay, done. Next, one more type of transport is there, which is very important for your exam, that is called as a vesicular transport. Vesicular transport. Right. Here, which type of vesicular transport I am showing you? Sir, here I am showing you, means see, in the vesicle there is a substance called as acetylcholine. It is going outside. So that is called as exocytosis. Exocytosis. Now, listen carefully. Sir, is acetylcholine ko, see, in order to release this acetylcholine, you have to do the exocytosis of acetylcholine. Vesicular transport. The vesicular transport can be sometime active, can be sometime passive. But in order to release this acetylcholine, exocytosis karne ke liye, which ions are required? Calcium. See, first of all, calcium is required for the exocytosis. I have taught you. Not only that, two important proteins will help in this process. Synaptobrevin, syntaxin. Exocytosis karne ke liye, is vesicle contents ko exocytosis karne ke liye, two important proteins are required. They are called as synaptobrevin and syntaxin. Together they are called as snare proteins. Snare proteins. Okay, snare proteins. So snare proteins helps in exocytosis. Okay, so acetylcholine is released. Acetylcholine will go and bind with the NM receptors on the muscle. So muscle will undergo contraction. That is normal. So this is the neuromuscular junction. This area is the neuromuscular junction. Acetylcholine goes and binds with the receptor. So muscle will contract. Normal. What is the name of this receptor? NM receptor. Nicotinic receptor on the muscle. Normal. But here what I want you to know is there is a toxin called as botulinum toxin. Botulinum toxin. You know, Clostridium botulinum produces this toxin called as a botulinum toxin. See, this botulinum toxin, it will enter into your neurons. It will cause a damage to this synaptobrevin and syntaxin. Synaptobrevin and the syntaxin will be destroyed. So now tell me, whenever these snare proteins are destroyed, do you think the exocytosis is possible? No. Without acetylcholine, muscle will contract? No. So that will lead to flaccid paralysis. Okay, so that is called as like descending flaccid paralysis or floppy baby syndrome. So whenever a baby gets infected with the Clostridium botulinum, you know, sporulated honey, when a baby is given with the sporulated honey, this sporulated honey may contain some Clostridium botulinum, and this Clostridium botulinum, it produces a toxin called as a botulinum toxin. So this botulinum toxin is one of the most powerful toxins in the world. So this botulinum toxin, do you know what it will do? It will cause a damage to the snare proteins. Without snare proteins, exocytosis of acetylcholine is not possible. Release of acetylcholine into the neuromuscular junction from the presynaptic membrane is not possible. Acetylcholine not released. Without acetylcholine, no muscle is contracted, so the baby will go into the paralysis. This is called as a floppy baby syndrome with descending flaccid paralysis. Okay, so tell me, exocytosis karne ke liye, sir, in order to do the exocytosis, which proteins are required? Snare. Okay, but tell me, have you ever heard about endocytosis? Endocytosis means taking the contents inside the cell, not outside. Exocytosis करने के लिए sir, exocytosis करने के लिए calcium is required as well as snare proteins are required. But endocytosis requires, just let me write here, endocytosis requires two proteins called as clathrins and caveolins. Okay, so clathrins and caveolins are required for clathrins and caveolins are required for endocytosis. Exocytosis require calcium and snare proteins. Clathrin and caveolins are required for endocytosis. Okay, done. What is the mechanism of action of a botulinum toxin? The botulinum toxin is going to cause the damage to the snare proteins, inhibits the release of what? Inhibits the release of acetylcholine from the presynaptic membrane. Without acetylcholine, muscle will not contract, the baby will go into the flaccid paralysis. Okay, flaccid descending paralysis. The paralysis will start from the upper part of the body, gradually it will go down. You know, ascending flaccid paralysis, ascending paralysis is going to be seen in the Guillain-Barré syndrome. Descending flaccid paralysis is going to be seen with the botulism. Okay. Next, so the next topic that I am going to discuss with you is skeletal muscle. Okay, skeletal muscle physiology. Skeletal muscle physiology. Sir, in this skeletal muscle physiology, I am going to teach you how the muscle will contract. Sir, here, first of all, I am showing you this is the muscle. Okay, this is your muscle. Okay, inside the muscle I am showing you. See, here there is a neuron. Okay, na? Here I am showing you the neuron and neuromuscular junction. This is the neuron along with the neuromuscular junction. Now, look carefully. This area which I am highlighting right now, what is this called as? This is called as a T tubule. First write in your book. This is called as what? This is a T tubule. T tubule. And what is this one? This is the L tubule. Okay, L tubule, T tubule and L tubule. Now you are having it out. So T meaning what? T meaning transverse tubule. This is nothing but the cell membrane. This is nothing but the cell membrane of the muscle. T tubule. This is all the cell membrane of the muscle. And what is this L tubule? So longitudinal tubule. This L tubule stands for longitudinal tubule. L tubule is nothing but sarcoendoplasmic reticulum. Sarcoendoplasmic reticulum. Okay, T tubule and L tubule. So now students, look carefully. On the T tubule, there is a channel called as a DHPR channel. DHPR, dihydropyridine receptor. On the L tubule, there is one more channel called as the RYR channel, ryanodine receptor. Inside this L tubule, there is a protein. Look at this protein. There is a protein. Okay, let me just duplicate this. Okay, wait. There is a protein to which calcium is attached. So this is all calcium. So there is a protein to which calcium is attached. So it's a calcium binding protein. What is the name of this red color calcium binding protein? So the name of this red color calcium binding protein is called as calsequestrin. Calsequestrin. It is binding with what? It is binding with the calcium ions. So in the sarcoendoplasmic reticulum, there are calcium ions available freely. Some calcium ions are free and some calcium ions are attached with this protein. Some calcium is free and some calcium ions are attached with the calcium binding protein. Okay, something like this. Now, here one more channel is there. You can see what is the name of this one. This is called as SERCA, sarcoendoplasmic reticulum, calcium ATPase. Sarcoendoplasmic reticulum, calcium ATPase, SERCA. Okay, so now you know T tubule is there, L tubule is there, DHPR channel is there, RYR channel is there. Okay, calsequestrin and SERCA, you know all these forms. Fine. Now, within the muscle, can you see this line which I am highlighting here? Can you see this line which I am highlighting? Sir, actually it is a protein, sir. These lines are nothing but the proteins. What is the name of this protein or what is the name of this line, sir? This line is called as a Z line. Okay, here is a Z line. Here is also one more Z line. The area between these two Z lines is called as what? The area between these two Z lines is called as sarcomere. The area between the two Z lines is called as what? Sarcomere. Okay, the area between the two Z lines is called as sarcomere, which is the functional unit of a skeletal muscle. It's a functional unit, okay, which will actually contract. That's a functional unit of a skeletal muscle. Now, in the center of the sarcomere, there is a line called as the M line. You can see in the middle of the sarcomere, there is one more protein which is forming this M line. Okay. Now, look, sir, to these Z lines, are you able to appreciate these filaments which are attached? So, these filaments which I am highlighting right now, they're all actin filaments, right? This is actin. Here is actin. And to this M line, look, to the central M line, one more protein which is attached, that is a myosin. Here it is a myosin. Okay. Sir, on the actin, are you able to appreciate there are these sites which are present? What are these things? These are active sites. Active sites. These are the active sites. Now, these active sites, look carefully, actually these active sites, they are never exposed. Okay, they are not exposed, they are actually closed with the help of this filament. See, this filament which is closing the active sites, the name of this filament which I am showing you here, this is called as a tropomyosin. Okay, tropomyosin. And this tropomyosin which is covering the active sites, it is attached to one more protein here. What is the name of this protein? The name of this protein is called as a troponin. Troponin. A better word is troponin C. Troponin C. Okay. So now listen carefully. You know some important areas of the sarcomere. Sir, tell me, what is this area which I am highlighting from the Z line till here, from the Z line till here. Okay, let me use a dotted line for your better understanding. So, okay, from the Z line till here. So, what is this area? Sir, this area contains only actin. Only actin is there. No myosin is there. So, this area is called as, right, this area is called as I band. Okay, this area is called as I band. Okay, fine. And what is this area? From here till here, both actin, myosin. Both the types of filaments are present. So, this area which I am highlighting right now, so this area is called as the A band, where both actin and myosin both are present. So, yes, this is A band. Okay, A band. So, I band is there, A band is there. Now, in the center, look carefully, in the center, you look carefully from here till here, only myosin, no actin filaments are coming to the center. So, this zone is called as the central zone where only the myosin is present. So, that area is called as the H zone. So, this area which I am highlighting right now, so the central area, this is called as H zone. Okay, this area is the H zone. Now, in the center of the H zone, which line is there? Sir, in the center of the H zone, there is an M line. So, that's it. So, now tell me the areas of the sarcomere from the periphery to center. Z, I, A, H. Within the H, there is M line. Z, I, A, H, M. Z line, I band, A band, H zone. Within the H zone, there is a M line. Okay. So, how you may get a question is, they will show you this electron micrographic image. Okay. They will show this electron micrographic image and they will ask you to identify the areas. So, now tell me students, this area which I am highlighting, what is this area, sir? Sir, these thick color bands, okay, these thick color bands, they are always Z line. Okay, Z line. After Z line, here is the I band. After I band, there is A band. In the center of the sarcomere, there is going to be area which is called as H zone. Within the H zone, there is a line that is M line. So, they will mark these areas, and they will ask you to identify, okay, which area is what. That always the two dark lines, always it is going to be Z lines. So, within the two Z lines, there is a sarcomere. Okay, so the mnemonic that I am giving you, ZIA HM, Z I A H M. Okay, Zia is the name of a girl. ZIA, Zia is the name of a girl. Marry her, she will become your home minister. Okay, she is going to control you, home minister or homemaker. She is going to cook for you. So, Zia HM, ZIA HM, Zia HM. Okay, so done. Now, what else you should know? Here itself, let me tell you. See, this actin, it is attached with what? This actin is attached with the Z line. With the help of a protein called as, the name of this protein is called as alpha actinin. Okay, so let me write here alpha actinin. And the myosin is attached with the M line. The myosin filaments are attached with the M line. The name of this protein is called as myomesin. Okay, the myosin filaments are attached to the central M line with the help of a myomesin protein. Okay, now next, last and final thing, sir, actually there is one more protein in the pink color. It is attaching the myosin with the Z line. It is attaching this myosin with the Z line. So, it is looking like a spring, right? The spring like protein is called as titin. So, So what is the titin doing? So titin attaches the myosin. Titin attaches the myosin to the Z line. Titin. So titin is looking like a spring. It is looking like a spring. So it is also called as a muscle spring cell. Okay, it is also called as what? Muscle spring. So that's it. Now last and final thing. Last and final. So let me explain you the entire muscle contraction just like that. So first you are getting a signal from the neuron, means the neurons are getting depolarized. When the neurons are depolarized, the neurons will release which neurotransmitter? Acetylcholine. Acetylcholine will go and bind with nicotinic M receptors, NM receptors. Now when the NM receptors are activated, sodium will come into the neuron leading to depolarization. Okay, sodium will come into the neuron leading to depolarization. Sir, this depolarization, look, the depolarization is going to go on the TTBule. The depolarization is going to go on this membrane called as a TTBule. Now this depolarization activates which channel? The depolarization is sensed by the DHPR channels. Now the DHPR channel actually, it is having a hand. Look, the DHPR channels actually have a hand, sir. Now these DHPR channels, they are mechanically attached. They were mechanically attached to the RYR channels. Now this DHPR channel, it will open the RYR channel. The DHPR channel open the RYR channel. So now for the first time, this RYR channel opens. When the RYR channel opens, the calcium will come out. So for the first time, calcium is released. This is called as electromechanical coupling. Electromechanical coupling. So tell me, what is electromechanical coupling, my dear students? They will ask you in your exam, what is happening during the electromechanical coupling? So during electromechanical coupling, because of the depolarization, the DHPR channel mechanically opens the RYR channel. Because of this electrical fluctuation, depolarization, so the DHPR channels opens RYR channel leading to the release of calcium. Now what the calcium will do? Now the calcium will come and bind with, look carefully, students, here I have taught you, actually these active sites are normally closed with the help of tropomyosin. This is tropomyosin. They are actually closed. And here it is what? Troponin C. Troponin C. Now what happened for the first time? This calcium, it comes, the calcium is coming and binding with what? The calcium is coming and binding with troponin C. Now when the calcium comes and binds with the troponin C, this troponin C, listen, the troponin C, it removes the tropomyosin away. So for the first time, the tropomyosin is removed. Calcium, when the calcium is available, the troponin C will remove the tropomyosin away. It will remove the tropomyosin away. When the tropomyosin is removed, the active sites are exposed. Now do you know what happens when the active sites are exposed? See, when the active sites are exposed, now this myosin heads, now look carefully. So these myosin heads, they will go and bind with the active sites. The myosin heads will go and bind with what? The myosin heads will go and bind with the active sites. And you know what this what these myosin heads are going to do? Now this myosin heads, now the myosin heads, they will pull the actin filaments. Now the actin filaments are being pulled towards the center of the sarcomere. The muscle will contract. Okay, so this is how the muscle will contract. Okay, so repeat again. Whenever the neurons are depolarized, neurons releases the acetylcholine to the neuromuscular junction. Acetylcholine binds with nicotinic receptor, NM receptor or acetylcholine receptor. Sodium comes into the muscle. Sodium is a positive charge leading to depolarization. The depolarization means it's electricity, no? Okay, this depolarization is going to spread onto the TTBule. When the depolarization is spreading onto the TTBule, the DHPR channels are activated. The DHPR channel mechanically opens the RYR channel. RYR channel opening will release the calcium. Calcium goes and binds with the troponin C. Troponin C removes the tropomyosin. Active sites are exposed. Myosin heads will go and bind with the active sites. They will pull the actin filaments, causing the muscle contraction. That's it. With this, what we have completed? Muscle contraction is completed. What you should know for your exam. So the questions which will come in your exam are, let me tell you, what were the questions that you should know? The questions that you should know for your exam, listen. Listen carefully. Sir, number 1. Tropomyosin, sir, not tropomyosin, troponin C, titin, they are absent in smooth muscle. Okay, so this troponin C I have taught you. Troponin C is not there in the smooth muscle. So who will bind with the calcium in the smooth muscle? So in the smooth muscle, the calcium will bind with which protein? The calcium will bind with a protein called as calmodulin. Calcium calmodulin complex. That is in the smooth muscle. But in skeletal muscle, calcium binds with the troponin C. Next, electromechanical coupling releases what? Sir, I have taught you electromechanical coupling is in the skeletal muscle where the DHPR channel opens the RYR channel. Electromechanical coupling release calcium. It will release calcium. Next, what else you should know? Sir, whenever a muscle is contracted, muscle contraction. Whenever a muscle is contracted, what will happen to Z lines? What will happen to I band, A band, H zone? See, Z lines, always remember Z lines comes close together. Okay, so whenever the muscle is contracting, whenever the sarcomere is contracting, the two Z lines in the periphery, they will come close together towards the center. Okay, then what about the H and I? H zone and I band. Okay, I used to remember like high, H and I, high. Okay, H and I both will decrease. The size of the H zone and the I band size decrease. What about the A band? A band size remain same. A band size remains same. So it was a favorite question for the examiners. They will every time they will ask you what happens to H zone, I band, A band and Z lines. Okay, that's it. Done. Next, I am asking you, sir, once the muscle contraction is completed, just imagine the muscle contraction is completed. Do you want this calcium to be present? No, we don't want the calcium. The calcium has to go back. Now the calcium has to go back into the sarcoendoplasmic reticulum with the help of SERCA. So SERCA kya karega, sir? SERCA will send the calcium back. Okay, SERCA sequesters the calcium back into the sarcoendoplasmic reticulum. So it's a relaxing protein. SERCA helps in not muscle contraction, muscle relaxation. It sends the calcium back into the sarcoendoplasmic reticulum. Done. Next. Sir, if this RYR channel, if it is a mutated, sir, this RYR channel, if it is having gain of function mutation, means overacting. If the RYR channel is having gain of function mutation, gain of function mutation in the sense it is working more than normal. So more and more calcium will come out, more and more muscle contraction, too much heat production in the body, that will lead to muscle damage. So that condition is called as malignant. Malignant hyperthermia. Okay, malignant hyperthermia, because the muscle will contract more and more heat is produced in the body. Too much muscle contraction is going to cause a muscle damage, leading to the leak of myoglobin into the blood. Okay, that will lead to the kidney, acute kidney injury. Okay, so that's why tell me, in a patient with a malignant hyperthermia, which channel is doing the overaction? RYR channel. So you have to use the RYR blocker. RYR blocker called as a dantrolene sodium. So the drug of choice for malignant hyperthermia, drug of choice is dantrolene sodium. Dantrolene sodium is a drug that is used in the treatment of malignant hyperthermia. Okay, done. Next, what else you should know in the skeletal muscle? Okay, what else? Sir, simple things that I will teach you. First of all, this is called as a cross bridge cycling. The image is talking about the cross bridge cycling. Only 1 minute. Cross bridge cycling. Cross bridge cycling. Okay, cross bridge cycling. Students, look carefully. First, whenever the active sites are exposed, imagine, sir, for the first time, who is exposed? Active site is exposed. When the active site is exposed, the myosin head has to go and bind with the active site. So this first step is called as cross bridge formation. So I am writing the short form cross bridge formation. Cross bridges are formed. Active processor, passive processor. No need of energy. So this is passive process. No need of any energy, sir. Just the myosin head is going and binding with the active site. No need of any energy. Passive process. Next, after the cross bridge formation, now look carefully. Sir, to this myosin head, one ADP molecule, one inorganic phosphate molecule are attached. They are released. So look carefully. First, the inorganic phosphate is released. Whenever the inorganic phosphate is released, now the myosin head will actually bend. The myosin head is going to pull the actin filament. It will pull the actin filament. That is called as power stroke. That is called as what? Power stroke. Active or passive? Passive, still passive process. Passive. Okay, because no need of any ATP break, like ATP is not broken down here. Just inorganic phosphate is released, that is going to cause the bending of the myosin head. And at the end of the power stroke, even the ADP is also released. So yes, can I say during the power stroke, first inorganic phosphate is released, later the ADP is also released. Both are released. Now you tell me, the myosin head is now in low energy form. Bend ho gaya. So the myosin head, it is into low energy form. Already is bent. It is bent. So now this is called as low energy form or rigor form. Rigor form. Now what you have to do, now for the first time I am using the ATP, means active process. Now for the first time ATP is coming. Now a new ATP will bind here. A new ATP binds to the myosin head. So that binding of new ATP will cause the cross bridge detachment. Cross bridge, it's cross bridges, myosin cross bridges को detach करने के लिए ATP is required. Not for the power stroke, not for the cross bridge formation, but for the cross bridge detachment करने के लिए ATP is required. Active process. Okay. Now wait. But still look at the myosin. Sir, it is still in the low energy form. It is still already in the bent form. Just cross bridges got detached. Now for the first time I am using the word ATP hydrolysis, means ATP will break down now. Now ATP will break down. So the myosin head, it will go back into high energy form. It will go back into high energy form, so that ATP is broken down. One new inorganic phosphate, ADP are available. Okay. So now if the active sites are still open, now it will go and bind with one more active site, one more new active site, and again cross bridge formation, power stroke, detachment, high energy form, one more cross bridge formation. So attachment, power stroke, detachment, high energy form. Attachment, power stroke, detachment, again go back to high energy form. So this is all the cross bridge cycling. So in a second, 1 second, this cross bridge cycling occurs for 5 times. Attachment, power stroke, detachment, attachment, power stroke, detachment. So like this, the muscle will contract. Okay. So this is what I want you to know. Next, sir, in nerve physiology, the most important thing which I want you to, even the last FMG exam, many questions came from this. Actually, almost 3 questions came from this one single image. 3 questions almost came from this one single image. So what is this, sir? What is this? Let me tell you. First, let me write about the classification of neurons. Classification of neurons in our body. Classification of neurons. Sir, in our body, the neurons are classified into 3 types: A, B, and C. Based on what? Based on the size. So based on the size, okay, the neurons are classified into 3 types: A, B, and C. But only based on the size? No, actually it is based on the myelination. Sir, A neurons are having this high insulation, sir, or you can say myelination. B neurons are having little myelination. C neurons, they don't have myelination at all, unmyelinated. So based on the myelination and based on the size, the neurons in our body are classified into A, B, C. But you tell me, sir, which neurons will conduct the electricity very, very quickly, very fast conduction of the electricity? The fast conduction of the electricity is always seen by A, because A neurons are having heavy myelination, so they will conduct the electricity very, very quickly. So tell me, when you go from A towards C, when you go from A to C, size will decrease, myelination decreases, and what about the conduction velocity, electricity conduction velocity also? Conduction velocity also decreases. So that's why in the recent FMG exam, do you know what was the question asked? Sir, conduction velocity is dependent on what? Conduction velocity is dependent on, when you go from A towards the C, okay. So when you go from A towards the C, the electricity conduction, the conduction velocity decreases, the size of the neuron decreases, the myelination decreases. So in the recent exam, the conduction velocity depends on the what? It depends on the diameter. More the diameter, fast conduction; less the diameter, slow conduction. This option was there. Conduction velocity depends on the diameter of the neurons. Okay. Next, Sir, this neurons in our body, okay, just wait. So based on their function, these A neurons are further divided into classified into 4 different types. That is A alpha, beta, gamma, delta. A neurons based on their function they are further classified into alpha, beta, gamma, delta according to one scientist. So alpha meaning what? Alpha motor neurons which will cause the muscle contraction. Beta, A beta, what do they carry? They will carry touch sensation and also pressure. A gamma, what they will do? They are gamma motor neurons which will cause the contraction of muscle spindles. Okay, in our muscles there are muscle spindles. So gamma motor neurons cause the contraction of the muscle spindles. And what about the A delta? Sir, A delta neurons, they will carry fast pain. They will carry fast pain as well as cold sensation. So different neurons in our body, they will have different function. A alpha are the alpha motor neurons causing the contraction of the skeletal muscles. Okay, the neuron which is, for example, look here, this is the alpha motor neuron. So this is the neuron which is contracting the muscle. No, this is the alpha motor neuron which will cause the contraction of the skeletal muscles. Okay, something like that. Next, then what about the C type of neurons? See, the C type of neurons, they will carry slow pain and hot temperature. Slow pain as well as the hot temperature. Now you are having doubt, okay sir, I know alpha, beta, gamma, delta, then they are having different function. C type of neurons are unmyelinated, they carry the slow pain and hot temperature. Then what about the B? Wait, in your pharmacology, you have studied, here is the spinal cord. Sir, side to the spinal cord, there is sympathetic chain present. Sympathetic trunk or sympathetic chain present. Sympathetic ganglia. Sympathetic trunk, or you can say sympathetic chain, something like that. Sir, from here, the preganglionic sympathetic nerves will come. And from here, the postganglionic sympathetic neurons. Will leave. So these are the preganglionic fibers. These are the preganglionic sympathetic fibers. And these are the postganglionic sympathetic fibers. Now look carefully. So this preganglionic sympathetic fibers, look, so the preganglionic sympathetic fibers, they are having little myelination around them. So as there is little myelination, they are classified as B. But what about the postganglionic sympathetic fibers? Sir, this postganglionic sympathetic fibers, they don't have any myelination, so they are classified as C. So now tell me, where are B type of neurons present? So the B type of neurons are preganglionic sympathetic fibers, and C type of neurons are the postganglionic sympathetic fibers. So that is what I have shown. Everything is given here. Look carefully. Sir, classification of nerve fibers in our body according to Erlanger and Grasser classification. Okay, according to this Erlanger-Grasser classification, the neurons in our body are classified into A, B, C. A is further divided into alpha, beta, gamma, delta. A alpha, they are somatic motor. Causing the contraction of the skeletal muscles. A beta carry touch and pressure. A gamma are the motor neurons causing the contraction of skeletal muscle spindles. B, have I taught you B fibers are preganglionic sympathetic fibers and C fibers are postganglionic sympathetic fibers. And not only that, C fibers also have some sensory role. Sir, C fibers, C type of neurons, they are also carrying some sensations. Which sensations? C type of neurons carry slow pain, hot sensation. Fast pain is carried by A delta and cold is also carried by A delta. Okay? Done. So this is the Erlanger-Grasser classification which I want you to know for your exam. Now how the questions may come up in your exam? Is for whenever there is a pressure. Whenever you apply pressure, for example, see, you are keeping your hand under your head. Okay, you are keeping your arm under your head and you are sleeping. See, that is pressure. No, 5-6 kgs of pressure. When you are applying pressure, the neurons will die. Which neurons will die first? Sir, with pressure kills. Which neurons are highly sensitive to pressure? Pressure kills A alpha followed by B, followed by C. So the first neurons which will die are the alpha motor neurons will die. When the alpha motor neurons are dead, I should say not dead, actually damages. Okay, they will be affected. Okay, So in the early morning, I cannot be able to contract my skeletal muscle. So there will be muscle weakness. So there will be muscle weakness in the morning. Okay. So pressure always is going to cause damage to what? Pressure always going to cause the damage to A alpha followed by B followed by C. Next, hypoxia. Hypoxia. Hypoxia causes damage to what? Hypoxia is very bad. I will say hypoxia, go back. Hypoxia is not welcome into my body. Hypoxia, go back. So remember back. BAC. Okay. B followed by A followed by C. B type of neurons will die first with hypoxia. Okay. In Guillain-Barré syndrome, in the recent FMGE exam, this question was there. In Guillain-Barré syndrome, sir, in Guillain-Barré syndrome, sir, it's a demyelinating disorder. Okay, demyelinating disorder, the neurons will be affected in the body. Which type of neurons are first affected in the Guillain-Barré syndrome? The first type of neurons that will be affected in the Guillain-Barré syndrome is A beta. Okay, A beta, it's actually pathology related thing. Just I am keeping it here. In Guillain-Barré syndrome, the first type of neurons that will be affected are the A beta fibers. The A beta fibers are the first neurons that will be affected. Okay, so done. So with this, the classification of nerve fibers are completed. Okay, where is the A neuron, B neuron, C neuron present in our body and what are their functions? Okay, only remember the Erlanger-Grasser classification, that will be enough. Next, sir, in the nerve physiology, what else you should know is the action potential of a neuron. The action potential of a neuron. See, whenever you give little stimulus to a neuron, for example, imagine here is a neuron. Imagine this is the neuron. I am giving little stimulus, very little stimulus. See, normally the neurons are having a resting membrane potential of how much? So the normal resting membrane potential of a neuron, RMP, is minus 70 millivolts. If I give very little stimulus, see, these are very little stimulus. Because of this little stimulus, the voltage within the neuron is going from minus 70 little bit positive and they are dying off. So the very little stimulus is not sufficient to produce an action potential. Means, for example, see, here there are millions of bacteria might be present. They are doing party, they are reproducing, they are enjoying, okay, they are doing so many things, but can I feel? See, these bacteria which are around my neurons, they are doing so many things. They might be hanging onto my neurons, they are just like, swinging. They are doing so many things, but can I feel them? No, I cannot feel them because the stimulus is very less. So, such small stimulus I cannot feel. In order to produce an action potential, in order to feel a stimulus, the stimulus should be at least bringing the voltage. The stimulus should bring the voltage from minus 70 millivolts to minus 55 millivolts. So this minus 55 is considered as a threshold potential. At least that's a minimum. That's the minimum. So once the stimulus will bring the voltage from minus 70 millivolts to minus 55 millivolts because of the stimulus, the voltage changed inside the neuron. Now, God created our neurons in such a way, once the voltage within the neuron reaches to minus 55 millivolts, now in the neuron, all the voltage gated sodium channels in the neuron will open. They will open. Now tell me, when the voltage gated sodium channels, when they open, sodium will come into the neuron, lot of positive charges will come into the neuron. So the voltage from minus 55, it will become plus 20, plus 30, plus 40. So this event is called as what? Depolarization. So now the neuron get electrically activated. Now the neuron have high voltage. Now lots and lots of sodium channels, sodium ions are there in the neuron. The neuron is activated. Now, electricity is generated. Now, electricity will go, it will transmit, it will propagate. These are action potentials which are propagating. Okay. So the neurons are depolarized. Now that sensation will travel on the neuron and it will go towards my brain. Okay. Next. Sir, okay, depolarization is due to what? The depolarization is due to sodium ions. But tell me, once the neuron is activated, it has to come back to its original position. Again, it has to come back to its original value. Okay, we should not have the continuous we should not have the continuous sensation, right? Okay, now see, when I am stimulating it, neuron is getting depolarized, the action potentials are generated, the information will go to the brain. Okay, I can feel it. But tell me, once the depolarization is done, now you have to do the repolarization. So now once the plus 40 millivolts is attained, the sodium channels will close now. Once plus 40 millivolts came, the sodium channels will close and the potassium channels will open. So potassium will go out of the neuron. The potassium will go out of the neuron as the positive charges. As the positive charges will go out of the neuron, the voltage will again becomes negative. But these potassium channels are lazy channels. They won't close on time. They won't close on time. So more and more potassium will go. As more and more potassium goes out, the voltage will come back to first minus 70, and even more and more potassium as it is going out, the voltage will become minus 90 millivolts. So that is called as hyperpolarization. That is called as hyperpolarization due to the lazy potassium channels. The voltage even becoming more negative, the voltage becomes even more negative. But after some time, because of the sodium potassium pumps, what the sodium potassium pumps will do, they will correct the voltage. They will correct the voltage again back to minus 70. So this area which I am highlighting, this is called as what? Hyperpolarization. After some time, because of the sodium potassium pumps, the voltage will come back to normal, minus 70. So first, depolarization, repolarization, hyperpolarization, and resting membrane potential again. So they will ask you, depolarization is dependent on sodium, repolarization is dependent on potassium, hyperpolarization is due to potassium leakage, potassium efflux outside. Okay, so they will, in your exam they will ask you, depolarization is due to, repolarization is due to, and hyperpolarization is due to. Resting membrane potential is how much? Minus 70 millivolts. And what else you should know? Sir, this area which I am highlighting from the beginning of the depolarization, to here, sir, to the repolarization here. So this area which I am highlighting, this is called as absolute refractory period. Which means during this time, this is the time, no, here, this is all the time. On x-axis I am showing the time. Sir, during this time, sir, the neuron is getting depolarized and repolarized. Okay, depolarized due to the opening of the sodium channels and repolarized due to the closing of the sodium channels. Depolarization and repolarization. So during this time period, that is absolute refractory period, no new action potential is produced. No new action potential is possible. Okay, so if you stimulate the neuron again, one more depolarization can occur. No new depolarization is possible. No action potential is possible. No new action potential is possible. But tell me, during this time period, sir, that is during the hyperpolarization state. During this period, tell me, sir, normal person, you have to bring the voltage from minus 70 to minus 55. Little bit stimulus is enough. But during this period, you have to bring the voltage from minus 90 to minus 55 to produce one more action potential. Which means normal stimulus is not enough. You have to give more stimulus. To produce one more action potential. So this is called as relative refractory period. So in relative refractory period, yes, new action potential possible with higher stimulus than normal. So absolute refractory period. So first here this area is the absolute refractory period and this area is a relative refractory period. Okay. Now, last and final thing, I am asking you one thing. Okay, last and final, sir. See, now I am giving a stimulus. I am giving stimulus. Sir, because of that stimulus, little stimulus I gave, the voltage goes from minus 70 to minus 56. So tell me, action potential possible? No, threshold not reached. I almost came, no, sir. Almost 149 marks I got, sir. Please pass me, sir. Do you think examiner will pass you? Do you think NB will let you pass? No, he will say 150 means 100% pass, 149 means 0. Okay, so in the same way, once threshold potential is attained, complete depolarization will happen. Repolarization will happen. But if the threshold potential is not attained, no depolarization at all. So don't think that, sir, if I give almost stimulus came, no, sir, at least little depolarization. No, it's not like that. Whether there will be either there will be a complete depolarization or no depolarization. That is called as all or none law. What is all or none law? If the threshold potential is attained, complete minus plus 40 millivolts depolarization and repolarization will occur. But if threshold potential is not attained, no depolarization at all. Don't think that little depolarization will happen. No, if there is a depolarization, there will be complete depolarization. If threshold is not attained, no depolarization at all. So this is called as all or none law. Okay, either there will be complete or no complete, either they will be complete or no. There is no such thing as middle value, middle, like little depolarization, no such thing like that. Okay, so with this successfully what we have done, we have completed. Okay, so the nerve physiology also, okay. So actually I thought I will be completing by 9 o'clock, but it happened. Okay, so anyway, had a good time. So guys, try to do as many revisions as possible. Okay, try to do as many revisions as possible and as many PYQs as possible. This is the like only last 50 days. No, take them as, okay, the last 50 days. Okay, take them so seriously. What you have to do is revision PYQs mainly. Okay, do the revision PYQs. If you, for example, like for those students who haven't touched any subject, do the rapid revision. For example, rapid revision of like 5-6 hours will be there. Do the rapid revision and do the PYQs. If you haven't started orthopedics, let's say, do the rapid revision of orthopedics and do the PYQs. If you haven't done your PSM, do the rapid revision of PSM and do the PYQs. Rather than leaving the subject, do the PYQ and do the rapid revision. It will almost get you, they will almost get you 75% of the marks. 75% pakka you will get pakka. Okay, so had a good time with you. Hope this session is going to be helpful for you in your exam. Okay, I'm pretty sure that like most of the questions are going to come from here. And general physiology, mainly concentrate on the general physiology, because from the general physiology definitely you are going to get the 5 MCQs. Okay, so all the best guys. Okay, you should all clear your exam with the flying colors. Okay, thank you. I'm going to end the session. Thank you. I will share the PDF in the Telegram group. Okay, good night. Thank you.